Мы расширяем границы науки, чтобы предоставить лекарственные препараты, способные изменить жизнь. В наши дни наука развивается как никогда быстро. Не отставать и держаться на равных – непростая задача. Мы должны продолжать добиваться новых результатов. Оставаться лидером. С помощью нашей коммерческой деятельности, с помощью нашего бренда. Вот из чего мы созданы. Сила научных достижений.
Мы Янсен. Каждое утро мы просыпаемся для того, чтобы сделать возможным то, что еще вчера казалось невероятным. Мы прокладываем путь туда, куда другие боятся смотреть. Изучаем и воссоздаем сам код жизни, чтобы лечить, помогать, исцелять. Мы открываем двери для сотрудничества, а умы и сердца для пациентов, чтобы наши успехи в лабораториях спасали жизни. Мы создаем инновации в лекарственной терапии и делаем их доступными для всего мира. Мы Янсен, фармацевтические компании Джонсон и Джонсон. Это наша жизнь и мечта, в которую мы верим. Мы будем использовать науку для борьбы с заболеваниями, изобретать, как помочь тем, кто нуждается в помощи, исцелять безнадежность человеческим теплом до тех пор, пока самые тяжелые заболевания не останутся лишь на страницах истории. Янсен. Создаем будущее, где заболевания останутся в прошлом.
It is the future that calls us, our history that forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift: life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science, from despair to hope. In 2021, we come together to celebrate where we have been, what we're doing, and where we'll go next. To celebrate 125 years. To celebrate all of us. To celebrate the future. We come together to celebrate life.
We are here together to celebrate life.
Каждые 2 секунды у кого-то в мире диагностируется рак. Это не просто статистика, это близкие нам люди. Поэтому нет ничего более срочного или более личного, чем наша цель – найти способы излечения от этого смертельного заболевания. Но мы знаем, это чересчур грандиозная цель, чтобы справиться в одиночку. Мы сотрудничаем с научным сообществом, чтобы открыть новые методы лечения, используя силу реальных доказательств для более точного действия наших препаратов. Сотрудничаем с группами защиты прав пациентов для поддержки и расширения прав и возможностей людей, которые живут и борются с раком. Взаимодействуем с организациями здравоохранения для предоставления доступа к нашим лекарствам тем, кто в них нуждается. Вместе мы достигли значительного прогресса, но наша работа далека от завершения. Рак забирает миллионы жизней каждый год. Чтобы превратить истории потерь в истории надежд, мы все должны объединить свои усилия. Чтобы найти способ победить рак, мы все должны объединиться.
Караганда. Индустриальный центр и магистральный узел железнодорожных и воздушных путей. По своему экономическому и научному потенциалу она по праву занимает одно из ведущих мест в республике. Именно здесь было создано первое в Казахстане предприятие, производящее современные, высокоэффективные биотехнологические препараты. Карагандинский фармацевтический комплекс. В создании завода было инвестировано более 100 миллионов долларов. Мы первое предприятие.
All right, good morning, everyone. Once again, welcome back to the third day session of the summit. And the first session here will be starting from the very important the talk by the very important person from the deputy in the parliament from the government, the Mrs. Ugo Tao. So I'd like to welcome her to the podium.
Thank you very much. Қайырлы таң, құрметті қонақтар. Бүгін әрине бұл үлкен мәселе көтеріп отырған. Елімізде осы обыр ауруымен қаншама адам ауырады, соның ішінде осы әйелдердің ішіндегі қаншама мәселе бар. Осыны қозғап, бүгін осының алдын алу жолдарын осындай халықаралық дәрежеде көтеріп жатқан сіздерге үлкен алғысым шексіз. Шынымен де бұл жұмысқа барлығымыз жұмыла атқаруымыз керек деп ойлаймын. Оны қолдамасақ, жастарымыздың болашақ денсаулығын алаңдамасақ, бұның барлығы бекер болады деп ойлаймын. Сондықтан осыны қолдауларыңызды сұраймын. Рахмет. Thank you very much.
Yes.
I'm sorry, the speaker was speaking Kazakh language. Good morning. The speaker was speaking the Kazakh language, and now the next presentation.
IGCS, Kyuji Fujiwara, IGCS Annual Global Meeting, Seoul, 2023.
Good morning, everyone. Once again, I really want to thank you for this the kind invitation for this very, very important summit meeting for the gynecology oncology patients in this region. So, as a president of the IGCS, I'd like to announce the great enthusiastic invitation from our society, which will be held in Seoul, November 5th to 7th. So the registration has been already started. You can just approach to the igcsmeeting.com, register now. We have a very, very best strong scientific program committee co-chairs. One is from Korea, Dr. Sakjun Chan, and another person, the chairperson is a Christina Fotopueblo from the United Kingdom. So these two individuals are working really, really hard to make the program of the Seoul meeting as great as possible. So also we have the scientific program committees under the supervising of the Dr. Sakchun Chan and Christina Hotfobro. And I cannot pronounce all the names here, but if you just take a look at the members, huge, strong members. So that I'm pretty sure the program will be really strong and beneficial for everyone. And abstract. So we have just three the pillars. I forgot to mention that. So one is surgical treatment, which is important for learning object for everyone, the G1 oncologist surgeons. And also the second pillar is the translational systemic treatment. So this is very important, another important pillar for all the treatment doctors, and to learn what is the best systemic treatment and based on the translational research. And another pillar is a survivorship. This is another important topics because all the patients is suffering from some side effects from the treatment, and also the patient will be suffering from the situation that we need a palliative care. So those three pillars are the topics we are focusing on. And this is a list of the abstract topics. So covering from those three the important pillars. So please consider to submit your work, the research work, the experience to the Seoul meeting. So we invite you in this region. We will have. It is very important to have you guys to submit and discuss among the leaders from all over the world. So our members are always supportive for the researchers who just started make some progress. So these are the key dates. Please consider to submit the abstract and film by May the 5th. It's almost 1 week or 10 days from now. So please be sure to meet that date. And also we will have the late-breaking abstract submission opened in May 23rd, and late-breaking the trial in progress submission deadline will be August 21st. This means that you can submit very important, the cutting the edge information to the society. And the registration deadline for the abstract, okay, so these are the most important dates, okay? And IGCS has booked the Society Intercontinental Coax, which is just next to the Congress Center. And you can just book your hotel today at the hotel.kenneth.com, Congress IGCS 23. Remember that, once again, we'd like to invite you, honestly, to our global meeting in Seoul. Thank you for your attention.
Thank you, Professor. Thank you. I hope that we will all together go into next our meeting will be in Seoul. Yes, welcome to Seoul, because it will be our Eurasian session.
Yes, that's right.
And all participants from that session will need to be in Seoul. Thank you.
I would like to introduce our next speaker. Her name is Rayhan Balatbekova. She represents Kazakhstan. However, I would like to say a few words. Before Rayhan starts, is that Rayhan has been absolutely instrumental in the relationship between Kazakhstan Cancer Society and International Gynecological Cancer Society and American Eurasian Cancer Alliance. She is the moderator of the tumor boards. She is the organizer of this right now what's called multinational relationship. We're very, very thankful to Rayhan. Appreciate your efforts. Thank you.
Good morning, dear colleagues. Thank you so much. Thank you so much for chairs for giving the opportunity to present current situation in Kazakhstan. In last year, according to Kazakhstan Cancer Registry, we registered around 40,000 new cases of cancer in Kazakhstan. So 11% of these occupied by gynecological cancer. Ovarian cancer in Kazakhstan in one of the main cause of death from gynecological cancer in Kazakhstan. So according to Cancer Registry database, the most of the cases we found in advanced stage. It more than half of new cases is in third and fourth cases. Here we presented data from survival rate. Survival rate is 20%, also according to Kaplan-Meier statistical data. Here we presented endometrial cancer data from 2004 and 2020. It is a stable rate of incidence of endometrial cancer. We found more than 1,300 new cases of endometrial cancer, and most of the cases we found in early stages of disease. So, and most of the cases is endometrioid type of endometrial cancer. Cervical cancer is one of the most common cancer in women after breast cancer, and we, according to Cancer Registry database, we registered more than 1,900 new cases of cervical cancer, and it's around 600 new cases, new deaths from this disease. And here you see the age standardized incidence per 100,000 new cases of cervical cancer. There is a moving of peak of incidence of cervical cancer from 50 years to 40 years to young ages. So in 2008, we started our national screening program of cervical cancer, and from 2008 we made several changes to improve this program, and for these days we provide screening program for women from 30 to 70 years every 4 years of screening. In 2017, our current program was revised with WHO experts. So from 2018 we increased coverage, and for these days more than 800,000 women screened annually in screening. So according to recommendation of WHO, we increased detection of precancer lesion, and now it's 1.16% from all screened women. So here in this slide, in the overall survival from cervical cancer. So for last 5 years, we increased survival rate for 7%, and now for 2022 is 59.6%. we started HPV, we provided HPV vaccinational pilot program in 2013 and 2015. It was immunization program in 4 regions of Kazakhstan. We chose this region according to regional north, west, east, and south part of Kazakhstan. And more than 17,000 adolescent girls were fully vaccinated in 1 dose, and more than 11,000 girls were fully vaccinated in 2 doses. So it was school-based vaccination, and we offered for parents to their choice Gardasil and Cervarix, and most of the parents chose Gardasil, and they chose in use. Gardasil was used in 62% of the case. So in 2015, due to high level of refusing from vaccination, Ministry of Health stopped this program. Also in 2017, we provide a study on the prevalence of high-risk human papillomavirus in women with cervical cancer. We provided study on cervical cancer specimen, FFP. We started, we provided HPV PCR in FFP of cervical cancer, and we found that in 74% of specimen, we found HPV 16 and HPV 18. So HPV vaccination in Kazakhstan can potentially reduce cervical cancer for 74%. And if we add other types of HPV, we found in 78% of the cases high-risk HPV. So if we provide nanovalent Gardasil 9, so we can potentially reduce cervical cancer for 78%. Now, our project on efficacy of HPV vaccination is ongoing. We invited all women, all girls who received vaccine in 2013 and 2015 to our program, to our project, which is supported by Ministry of Health and Ministry of Education. So this is a preliminary result of our program. More than 800 vaccinated girls who age from 18 to 30 years now, and around 800 girls, unvaccinated girls, women were invited to our study. So we found that HPV prevalence in unvaccinated group was 17%, and HPV prevalence in vaccinated group was 0.87%. So also here in this trend, you see that we found HPV 16 in 3 cases of vaccinated women. So this study is ongoing, and we are planning to provide all data regarding does this woman where we found 3 cases HPV 16, maybe they vaccinated in 1 dose or not. We are going to check it. So thank you so much. Thank you so much for your attention. Thank you so much.
Questions? Do you have questions, Kurayhan? Okay, thank you.
Thank you.
Next presentations from Georgia, Tamar Skirtladze, Preventing Cervical Cancer in Georgia, Achievements and Challenges.
I'd like to add that Georgia has just been recently added as a member for strategic partnership of International Gynecological Cancer Society. We congratulate the country on this wonderful step. Thank you.
Thank you very much. It's my pleasure to be here, and I would like also to express my gratitude for inviting us, for giving us opportunity to take part into this summit and to present the information about cervical cancer screening program in Georgia, about statistical data and the activities done by National Screening Center and the challenges that we face during this implementation process. So This slide shows the basic information and statistical data. In 2021, the population of Georgia was 3.7 million, and 52% out of total population is a female population, and women aged from 25 to 60 years are 900,000 around, which is the target age group for cervical cancer screening program. So in Georgia, as in many other countries, communicable diseases are the main cause for mortality. 50% is caused with cancer. So in 2021, there were around 10,000 new cases of all cancer registered. The incidence rate per 100,000 women was 281, and mortality around 200. So, according to registered data, cervical cancer is the 5th most common cancer among women in Georgia. So, the graph shows incidence and mortality rate, where we can see more or less stable situation with a slight fluctuations, though in last 3 years the trend is declining. So if we look at the stage distribution, around half of them are detected on late stages. Though in 2021 there still was a slight positive changes when detection on 3rd and 4th stages declined a little bit. So due to the fact that cancer is one of the main causes of mortality in our country, and detection at early stages is still challenging, so to fight against cancer is priority for Georgian healthcare policymakers. So, and in 2008, by the initiation of National Reproductive Health Cancer, was initiated cancer screening program, and it was supported by Tbilisi municipality and UNFPA country office. So, at the same year was established National Screening Center with the aim to launch and operate cancer screening programs. So, at the beginning, the services were available only for Tbilisi residents, though gradually the services expanded, and since 2011, all cancer screening services are available to the rest of the Georgia. So in 2015 was launched the Cancer Population Registry for the purpose to improve surveillance of cancer diseases, and in 2019 Unified Cancer Information System was created, which combines cancer registry data, cancer screening data, and also laboratory data. So, cervical cancer screening program in Georgia is based on the guideline for cervical cancer screening and diagnosis, and the program includes conventional pap testing with further cytology, and also colposcopy and biopsy with a further histological examination. So target age group is from 25 to 60 years old, and the screening intervals is 3 years. So the services are free of charge for the target population, and the program is financed by Tbilisi City Hall and National Center for Disease Control and Public Health. So quality assurance, this is the top priority of our National Screening Center team. So, and with the huge effort of our center team, and also with the support of UNFPA Georgia, last year was adopted and approved new cervical cancer screening guidelines, which is based on European and WHO guideline. Also, there is an independent internal and external quality control of cervical cytology. So our medical staff are regularly participating in different trainings, conferences, workshops for the purpose to bring up-to-date information, modern methodology, and to apply it into the practice. So besides this, several of our team members has a TOT trainings done, so training of trainers in quality assurance for cancer screening, which is also supported by different international organizations. And our center is a base for the continuous medical education, so we have a course for colposcopy. So as we all know, in 2018, World Health Organization adopted global strategy for elimination of cervical cancer, and in 2020, November 17, Georgia also joined this strategy and officially announced to start the acceleration of cervical cancer elimination program. And as we know, the first target is that 90% of girls should be vaccinated by the HPV vaccines. So as regards the vaccination situation in our country is that in 2017, HPV vaccination was launched. At the beginning, it was as a pilot project in 4 regions, though in 2019, it expanded and it is available throughout the country, and also it is included into the immunization calendar. So, and the target age group is from 10 to 12 years old girls, and there is done 2 doses, and interval between the vaccination is a 6 month. As regards the coverage rate, in 2022 year, 38% of girls who have been vaccinated with the 1 dose and 26% with 2 doses. So this slide shows the examination coverage trend and rate of target population in the cervical cancer screening program, where is a more or less stable trend. So, but since the COVID year, there is a remarkable achievement and progress. So, based on our huge effort, the rate has been increased last year with 6% and in Tbilisi and 2% in regions. So, and we do hope that we will keep this trend and rise more to reach to the desirable level. So, to keep this and to increase the participation rate, where our team is doing a lot of activities, like including to open different new screening centers in different locations to improve and enhance geographical accessibility. Also, there are many activities for raising awareness campaign, like a mass media, social media, leaflets, brochures, and I would like to mention that with the organization of National Screening Center last month, there was a concert at State Opera in Tbilisi, Save the Life. And the aim of this concert was to raise awareness of screening programs. And many Georgian prominent musicians and opera singers took part into this event, and they were encouraging women to regularly participate in screening programs. Besides this, the new booking system was established in our country. This is a website, a web-based queue management system. It's an online registration system where the women who are already eligible for screening, they can do their registration appointment by themselves, or their GPs can do it on behalf of them. So as I mentioned, we have a good cooperation and partnership with the various organizations for the purpose to strengthen this system and to bring new modern approaches and methodologies. And our aim is to transit from cytology-based screening model to the HPV testing screening model. For that purpose, we had a cooperation with Roche Diagnostics and jointly implemented a project last year. So the aim was of this project was to do a comparative assessment of 2 screening models. On one hand, primary conventional pap testing, and on the other hand, HPV testing. So to detect CIN2 and plus. So the study was designed for 1,000 women. The results are already ready, calculated, analyzed, and they are ready to be published. And but it study definitely show evidence that HPV testing as a primary screening model is much reliable to compare with the cytology. So, and the sensitivity is much higher comparing with the conventional pap testing. So the other project that aimed to do an assessment of cervical cancer screening program was done last year in collaboration with the IARC. So the quantitative and qualitative data were collected, analyzed, and also SWOT analysis was done. Barriers and different opportunities were discussed, and the actions were discussed together with the IARC EPR branch members for the better performance of the screening. And should be mentioned that all activities were taken into consideration by the National Screening Center team, and a couple of them are already accomplished, though there is still room for improvement. And I would like to talk about the further steps that we need to improve cervical cancer screening in Georgia. So first of all, we have to introduce HPV testing for cervical cancer screening as it is recommended by the WHO guidelines. Also, we have to implement organized cancer screening model, which means that we need to do an personal invitation of women to participate in screening, and for that we have to get the personal data from Public Service Development Agency, which is now in progress. Also to enhance public awareness campaign and to educate not only target population, but also to strengthen and to educate primary healthcare physicians and family doctors. And definitely we need to strengthen our international collaborations. So thank you very much for your attention. Thank you.
Thank you, Tamar. Okay, so I'd like to invite next speaker, Dr. Ades Karatepe from Turkey. His talk will be the update on human oncology in Turkey. Ades?
Dear President, dear colleagues, first of all, I would like to thank this presentation. First of all, I would like to thank Professor Dilara to inviting Turkey and me for this excellent summit. Thank you very much, and her hospitality. Thank you very much. My subject is gynecologic oncology updates, but I will talk about the screening program in Turkey, and I will give the Istanbul result. I published this data 1 year ago in National Journal. When we look at the cervical cancer, is a big problem for the less developed country. In Turkish data, yes, incidence is not high, but we look at the number. Every year, approximately 2,500 new cases occur, and 1,500 young women lost their life from this cervical cancer. In 2012, Turkish Ministry of Health started the screening program and implemented HPV testing as primary method for cervical cancer screening. In 2014, centralized HPV testing laboratories started to serve in Ankara and Istanbul in order to achieve adequate coverage of population. Screening procedure started to be performed by family health centers, also all other government institutions. Cervical cancer screening are performed in women the age of 30 to 65 years. The interval for screening is 5 years. Screening method is based on HPV DNA testing, hybrid capture too. 2 cervical specimens are collected simultaneously during the procedure, one for HPV isolation and subtype, and the other one serologic evaluation. This is our protocol. If the DNA test result comes negative at first round screening, these cases are dropped from the targeted population list of Family Health Center for following 5 years. If the results come positive, we performing 2 reflex tests. One is genotype, subtyping analysis. The other one, serologic evaluation. Women who are referred to the colposcopy center, if subtype analysis comes positive for HPV 16 and or 18, subtype analysis revealed other than 16 and 18 strain positive but have any abnormality in cytologic evaluation, this group will go to the colposcopy center. The subtype analysis revealed other than HPV 16, HPV 18 strains positive, but serologic evaluation is normal, is follow-up in annual basis. In Istanbul, in this time, 2015 and 2020, 723,000 screening procedures were performed. A total number of HPV positivity result was approximately 47,000. HPV DNA positivity ratio in this year 6.5%. The maximum number of screening was performed in 2016. In 2020, a significant reduction was observed due to the COVID-19 pandemics. The rate of HPV positivity cases has been increasing over the screening years. Positivity rates was 4.29% in 2015 to reach 8.9% in 2020. I think that is related to Istanbul took a lot of refugees in this period, and these refugees people are living with our population together. Majority of HPV positive individuals in screening population were infected with more than one HPV subtypes. Proportion of individuals infected by more than 5 HPV subtypes was 1.78%. These are our data, age group distribution of HPV subtype detected in Istanbul population. According to this data, the most common subtypes were as follows. HPV 16, the most common subtypes. This range was the same each age group. When we look at the 10 HPV, the most common 10 HPV subtypes, HPV 18, HPV 45, and HPV 33 are not seen in the first 10 HPV subtype detected in Istanbul population. The other population, we are seeing these subtypes, the first 10 subtypes. Also, cytologic evaluation were resulted as normal in 64.3% of HPV positive individual. A pathologic serologic finding was seen only 8.1% of HPV positive cases. HPV testing has eventually become the state-of-art cervical cancer screening methodology since the introduction of World Health Organization's Essential Practice Guidance in 2014. Turkey is one of the early adopted countries to this approach by accepting HPV DNA testing as the primary methodology in 2012. HPV 16, in conclusion, HPV 16 was the highest subtypes. The detected ratio is approximately 17%. In Istanbul population, the first 10 HPV subtypes does not include HPV 18, HPV 33, and HPV 45. Every year, HPV positive ratio is rising in Istanbul, reach 8.9% in 2012 in screening population. Following years, the cervical cancer incidence would be probably increase. So vaccination must be started as soon as possible in a national program in Turkey. Cytologic evaluation revealed only 8.1% pathologic result in HPV DNA positive cases. This finding may suggest that superiority for screening role of HPV DNA testing when compared to cytology. Thank you.
Thank you so much. All right. So
Thank you.
I have a question. Atish, sorry, one question.
Yes, of course.
For your for statistics and during maybe now more than 10 years, you have cervical screening in your country.
Cervical screening started in the 2015. Yes. National program started 2015, but 2012 decided to make HPV DNA testing, but the preparation and lab establishing in Ankara and Istanbul then started 2015.
Yes, and we are seeing your statistics, new cases of cervical cancer are increasing.
Yes, of course. Maybe affected by screening program started new, and this time we found a lot of occult cervical cancer cases.
Yes, and what do you think? How long we need to do this cervical screening in our country? Yes, we are doing cervical cancer screening 10 years too, and every year the new cases are increasing because we think that we will start screening, the cancer needs to decrease, but now in all countries is increasing.
Yes, of course.
Basically, the question is, the more you screen, the more you see.
Yes. More screening, we are finding more cases.
When do we see less?
Yes, maybe the 10 years later. Because the process is minimum 10 years. We must continue to screening and vaccination. I mentioned that the HPV ratio is increasing very rapidly in Istanbul. It means that the cancer will increase 10 years later, so will be a very, very big problem. So vaccination must be started as soon as possible. Yes, we are performing vaccination, but there isn't any national program. We are performing only willingness patients.
So what's the percentage of the very much advanced cases right now in Turkey? What do you see?
In my clinics, I've seen 50% in later stage, but especially the older women. Especially older women, we catch the cases very, very, very late stage. Thank you.
So I'd like to welcome the next speaker from Armenia, Dr. Artem Stefanyan. No? Sorry? Oh, recording, okay. Yeah, it's coming up?
Tom, today he is in Berlin.
Okay.
And he sent his presentation to us from
Dear
Armenia.
organizers, dear Dilara, thank you very much for having me as a speaker on your tremendous event. The topic of my speak is the current state of gynecologic oncology in Armenia. Let's start over the introduction. Armenia is a small country located in the Caucasus region in Eurasia. The healthcare system in Armenia has undergone significant reforms in recent years, with a focus on improving access to healthcare services and increasing the quality of care provided. However, gynecological oncology remains a relatively underserved area in Armenia. Limited resources, including a shortage of qualified healthcare professionals and limited access to specialized diagnostics and treatment facilities, have contributed to challenges in the treatment of gynecological cancers. As for statistics, according to the World Health Organization, cervical cancer is the second most common cancer among women in Armenia after breast cancer. The age-standardized incidence rate of cervical cancer in Armenia was 9.1 per 100,000 women in 2020, compared to a global rate of 13 per 100,000 women. The age-standardized incidence rate of ovarian cancer in Armenia was 9.7, according to 2020, compared to global rate of 6.6. The age-standardized mortality rate of cervical cancer in Armenia was 4.2 per 100,000 women in 2020, compared to a global rate equal to 6.8 per 100,000 women. The age-standardized mortality rate of ovarian cancer in Armenia was higher, it equals 6.3 per 100,000 women, compared to a global rate equal to 3.8 per 100,000 women. So here we can conclude that the situation is not so good with ovarian cancer in our country. What are the challenges in screening and the diagnostics? The first challenge is the limited access to screening program for cervical cancer and diagnosis of advanced stage of the disease. Challenges in accessing specialized diagnostic facilities like screening, MRI, CT scan. For example, only 21% of eligible women in Armenia received cervical cancer screening in 2018, according to the Ministry of Health. Delayed diagnosis and treatment can reduce the chances of successful outcomes for our patients. What are the challenges in the treatment? Limited access to treatment options like surgery, chemotherapy, and radiation therapy, and shortage of qualified gynecologists, delay in diagnosis and treatment. For example, Armenia has only 2 specialized gynecology centers with limited capacity to provide treatment to all patients who need it. The shortage of qualified gynecologists means that patients may experience delays in receiving treatment or have to travel a long distance to access the specialized care. As for support services, according to the Armenian National Palliative Care Strategy, palliative care services are still not widely available in Armenia, and the coverage of those services is limited. The strategy highlights the need to improve the capacity of healthcare professionals to provide palliative care services and to increase the availability of palliative care medications. Overall, while there is some provision for support services in Armenia, there is still significant room for improvement in terms of availability and accessibility of psychological and palliative care for patients with gynecological cancers. Government initiatives. The Armenian government has launched a new cancer control program aimed at improving cancer prevention, early detection and treatment. The program, which was approved in 2020, is a comprehensive strategy that covers all types of cancers, including gynecological cancers. To support the implementation of the cancer control program, the Armenian government has allocated significant funding. For example, in 2020, the government allocated 1 billion Armenian dirham, it's approximately $2 million US, to the Ministry of Health for cancer control initiatives. By prioritizing cancer prevention, early detection and treatment, and by allocating significant resources to support these initiatives, the government is taking important steps towards improving the lives of our patients with gynecological cancers in Armenia. In conclusion, the current situation in gynecologic oncology in Armenia presents both challenging and opportunities. While there are some positive developments, such as establishment of specialized centers and the implementation of comprehensive cancer control program, there are still significant gaps in the availability of resources and support services for patients with gynecologic cancers. Nevertheless, the Armenian government is committed to improving cancer control is a positive development, and the allocation of significant funding to support these initiatives is encouraging. By continuing to prioritize cancer prevention, early detection and treatment, and by addressing the gaps in support services, it's possible to improve the state of gynecologic oncology in Armenia and reduce the burden of gynecologic cancers on patients and the healthcare system. Thank you very much for your attention.
I would like to introduce our next speaker. Next speaker will be from Azerbaijan, Dr. Shemistan Aliyev. And the wonderful news that will happen today at the end of the session is that Azerbaijan will be joining an International Gynecological Cancer Society. Please don't leave. We will have a wonderful signing ceremony. But now we would like to listen your update. Thank you so much for joining us.
Thank you very much. I'm appreciated for your invitation. A lot of thanks, ICGS, Dilara Radikovna. Thank you very much. I'm very appreciative. Уважаемые коллеги, я бы хотел продолжить доклад на русском. Это относительно сентинельных лимфоузлов по поводу...
Let me continue in English. The sentinel nodal treatment and endometric cancer in the sentinel lymph nodes. Latest years we started to introduce sentinel lymph node mapping. During the latest decade, the role of the sentinel node dissection was changed a lot. Mainly, it includes the transfer from the open dissection to the small invasive surgery. Now it includes the small invasive hysterectomy. Before, we elaborated the concept of the surgical staging of the endometrial cancer. Before, the treatment was without radiation therapy, depending on the uterine factors of risk. The study of GOG-33 showed that the surgical pathologic features of 621 patients with stage 1 of carcinoma of endometrium were included into that study, and all patients were treated with primary surgery consisting of total abdominal hysterectomy, bilateral salpinal oophorectomy, and selective pelvic cancer. and it included invasion. In 1988, the International Federation on Gynecology and Obstetrics developed its classification and the staging system, also for lymphatic system. But the question, should all patients get otilectomy, and is it a disputable issue? This is one of the most contradictory issues in oncogynecology. Two studies you see on the slide. 2008 and 2009, two randomized trials, but they did not prove survival improve those who were under the lymph dissection against those who did not have lymph dissection. But those who had a lymphadenectomy, they had lots of side effects and lymphedema, and it was not recommended to perform paraortal lymphadenectomy because it's a heavy and difficult surgery, and it's not safe for patients with obesity. Lately, the oncogynecologists started to use a high variety of staging, starting from the bilateral pelvic dissection up to selective dissection of nodes, basing on the intraoperative studies. As an alternative of a concept of a complete dissection, there was a mapping developed for the lymph node basin. It is about a pool of the lymph nodes basin before involving other groups of the nodes, and the transing media goes via the lymph channels into the lymph drainage basin and accumulated in the first node that is called sentinel node. The sentinel lymph node mapping algorithm is a very appropriate strategy. It is based on the best practices and experience of different organizations. The negative sentinel node should show that the nodes of the secondary level are really negative and not under lesion. So, the dissection of those secondary nodes is not needed. This prospective non-randomized trial of FIRES describing sentinel lymph nodes identified with the indocyanine green have a high degree of diagnostic accuracy in detecting endometrial cancer metastasis and can safely replace lymphadenectomy in the staging of endometrial cancer. Sentinel lymph node biopsy will not identify metastasis in 3% of patients with node-positive disease, but has the potential to expose fewer patients to the morbidity of a complete lymphadenectomy, so can replace safely the endometrial cancer dissection and can escape the side effects. The near-infrared fluorescence for detection of sentinel lymph nodes, use of ICG is a very efficient method for mapping substances, and it was proved and suggested that ICG introduced into the cervix can be as a detection while mapping the patients with cervical cancer. The majority of gynecologists from Europe and US believe that this recommendation is useful, and they use this recommendation. More than 57% of doctors use that principle. The technique is introduced to map SLN, but still there is no complete solution for that. So this is the first part of the sentinel node mapping. It depends on the variety of surgical techniques. Still further study is required in order to get a consensus what should be obligatory or what should not be obligatory in mapping of SLN. The second issue is ultra-staging. It includes additional cuts and coloring with the SLN together with H&E and immune histochemistry to study the node for metastasis of small scope. The protocols of the optimum histopathological and molecular assessment is still not studied properly. The results of patients are not studied properly either, because we do not know which way SLN may impact the results of treatment, life quality, and incidence and survival. Still, there is no evidence-based proof of a high level which way SLN mapping impacts the results of treatment of such patients. According to the data from our treatment center, we implemented widely sentinel lymph nodes, and the incidence for the SLN is about 81%, and the bilateral site detection 62%. But we have not proved the correlation. The metastatic lymph nodes in total group against the group of the intermittent risk was from 6 up to 7%. And when we transited to the sentinel node detection, we started to use the ultra-staging and metastase detection. So there was 10 and 18% into groups of detection. In the conclusion, the use of SLN is a very appropriate solution for surgical treatment of women with the early stage. The SLN mapping proves, together with laparoscopy, a reliability and safety. There is an efficiency proved when you provide SLN while detecting metastasis. Thank you very much for inviting me in Eurasian Summit of Modern Approaches in Management of Gynecological Tumors. I wish you good health. Thank you very much for your presentation. Thank you very much.
Cervical cancer in Kyrgyzstan, Shinara Batyrkhanova.
Good morning. Kind greetings to all from Kyrgyzstan. I'd like to thank my colleagues from Kazakhstan, to Rayhan and Professor Dilara, for the excellent organization of the summit and for the invitation. Let's start with some data about our country. Current population 6.6 million, equivalent to 0.09% of the total world population. Number 110th in the list of countries by population. Total land area is 77 square miles. Kyrgyzstan, landlocked in Central Asia. The country shares its borders with Kazakhstan, Uzbekistan, Tajikistan, and China. The death rate in Kyrgyzstan has pretty much held steady for many years. The birth rate is higher than the death rate. There are a huge number of causes of death in Kyrgyzstan, but the most recent data show that the top 3 causes of death are heart, maternal, and neonatal diseases and cancer. Men of all ages in Kyrgyzstan are often diagnosed with stomach, lung, liver, colorectal, prostate cancer. According to Globocan data for 2020, new cases of cancer of the breast, cervix, stomach, ovaries, uterine body, and others are most common among women of all ages. Stomach, lung, breast, cervical, and liver cancer are ranked by incidence, and in terms of mortality, the ranking is stomach, lung, liver, cervical, pancreatic, and breast cancer. There is only one center in Kyrgyzstan where patients can receive radiotherapy and brachytherapy, and it's located in the north of the country in the capital, Bishkek. The second center in the south of the country doesn't have radiotherapy. Soviet-era oncology hospitals, oncology rooms, screening rooms, and regional polyclinics have been eliminated, and the number of cancer specialists has been reduced due to healthcare reforms imposed from outside after Kyrgyzstan gained independence. The equipment used for cancer staging in our cancer center is 5 ultrasound machines, 6 X-ray units, 1 mammography system, 1 CT scanner in terms of purchasing an MRI system. PET-CT is available in only 1 private center in the country. In our center, we have 1 radiotherapy planning CT scanner, which also used for diagnostic, 2 linear accelerators, 1 gamma radiotherapy machine, 1 X-ray therapy machine, 3 cobalt brachytherapy machines, 1 2D brachy, and 2 3D brachy. We have 16 radiation oncologists, 10 radiation therapy technologists, 20 nurses, 6 medical physicists, 2 dosimetrists, 5 engineers. There is a constant need to train new staff and improve the skills of existing staff. Radiation therapy staff requires the most attention due to low salaries and high cost of upgrading knowledge. A well-coordinated team of medical personnel at the National Center of Oncology and Hematology of the Kyrgyz Republic is open to everything new and ready to participate in the implementation of measures for the prevention, early detection, and treatment of cancer. Some of our weaknesses is insufficient funding for public health and lack of cytological and histological services in state clinics of the regions, lack of treatment for cancer patients in the regions, presence of only 1 cancer center in the country, disruption in the maintenance and repair of existing radiation and brachytherapy equipment due to insufficient government funding and insufficient training of engineers. Weak training of medical physicists and the lack of training of engineers in our universities, low salaries, low medical literacy of the population. Our opportunities is acquisition of modern equipment and training of specialists for radiotherapy and brachytherapy at the expense of the state and through technical cooperation in international projects. Relapses and metastases in treated patients due to advanced cancer, due to waiting for the arrival of engineers from the factory during difficult equipment breakdowns, it's our traits. The state doesn't have priority in financing healthcare in general and radiation therapy and brachytherapy in particular. Delaying the implementation of international projects due to inconsistency of legislation with international radiation safety standards. We need to reduce the number of advanced cancer and increase the early detection of cancer. This can be achieved through oncological screening, the restoration of state inexpensive laboratories for cytology and histology in the regions of the Republic, and the opening of oncological hospital in the regions of the country. With the financial and technical support of Gavi, the Vaccination Alliance, the HPV vaccine is being introduced into the preventive vaccination calendar of the Kyrgyz Republic. On November 14, 2022, vaccination against the human papilloma virus began for girls aged 14 years. With support from Gavi, 368,000 doses of HPV vaccines have arrived in the country. To date, more than 2,000 health workers have been trained, more than 100,000 informational materials have been printed, and active explanatory works is being carried out among the population and parents of girls. Thank you very much.
If I may, in Russian, okay. I should like to ask, so you've showed one mammograph. What's that? So it's one mammograph in one center, in our center, and one is in the south, I think. And that's it. So you mean 2 mammographs per the country? Maybe I'm wrong, maybe 3. But we have one for the entire northern region. Okay. You've mentioned Gavi, so what's the vaccine? That's the 4-valent Gardasil. Thank you so much. Thank you for coming here. Thank you actually for taking part in the Alliance IGCS and the Kazakhstan Cancer Society activities. Thank you.
Next presentation from Tajikistan, Matluba Hadjayeva. PIPEC in the combined treatment of locally advanced ovarian cancer in the Republic of Tajikistan.
Thank you so much for inviting me here. Enabling me to take part in this conference. Dear Chairman, dear colleagues, I'm very pleased to be here, and I'm very, very glad to be able to share our experience.
Allow me to
brief you on the state of cancer diseases in our country. So the structure of the onco-service of the Ministry of Health and the Public Social Protection consists of 5 specialized institutions that are coordinated by the National Cancer Center. So in Tajikistan, the disease tends to increase just as across the globe. Over past 10 years, it's nearly doubled. So the comparative statistics per 100K population has also been growing from 142 back in 2010 to 200 in 2022. Annually, the primary detection of malignant tumors is increasing. It shall be noted that despite this rising trend, the mortality is not growing. In terms of nosology, the first place is taken by breast cancer, followed by cervical cancer, skin cancer, stomach cancer, and lymphomas. So their numbers are growing annually. In terms of the nosology, So we have 17.5% of breast cancer, followed by cervical cancer with 9.5%, stomach cancer was 7.9%, skin cancer was 5.2%, and lymphoma was 4.6%. So it is the statistics of women who are registered with national onco centers and services. So in 2022, breast cancer took 28%, followed by 17% with cervical cancer. As compared to WHO data, the global disease rate is 17% for breast cancer, stomach was 5.6%, and lung was 11.4%. So the statistical data shows that when the primary screening of cervical cancer pathologies are carried out, the number of such cases has grown. The ovarian cancer is the most aggressive type of reproductive cancer, and over 75% of women learn their diagnosis at later stages, and most have metastasis to other organs. Ovarian cancer remains localized and metastasized into neighbor countries or by way of cancer cell displaced transperitoneally in all the abdominal area. And there is a need for more effective therapeutic methodologies to improve the survival rate and by reducing the various symptoms, the occurrence of the symptoms of the disease and also, it is important when the country is limited in finances. So back in 2011, there was the intra-abdominal aerosol chemotherapy pipe pack, and new delivery method was introduced. And with the support of the Russian colleagues, the pipe pack was applied to our patient with ovarian cancer. And the pipe pack is well tolerated, it improves the quality of life of the patients, even terminal patients, and using the lower dosage and can be nearly 10% to traditional dosage. So it reduces toxicity, and a patient can be discharged the second day after the surgery, thus reducing the costs. And it is also possible to introduce a pipe pack alongside the hyperthermic intra-abdominal chemotherapy. The purpose of our study was to evaluate pipe pack efficiency with ovarian cancer. So we had 18 patients who were with the National Cancer Center between October 22 to March 2023, and they had 3A and 0, so that was the grading, and in the end the patients were divided into two groups. So 6 patient had a site reduction, and the first group received a pilus PIPAG biopsy, and then patients of both groups received systemic chemotherapy with follow-up PIPAG. And the chemotherapy included the cisplatinum and carboplatinum, and each patient received 2 PIPAG sessions and 2 4 system chemotherapy sessions, and all the patients received also were done comprehensive tested oncomarkers and cytological as well as instrumental studies, and with a laparoscopic control to reevaluate the cancer mitosis. And the results of the test showed that the average age of the patients were around 55 years, and they mainly complained about the increase in the stomach volume and abdominal pain. And 83% of patients had this free-flowing liquid less than 5 liters, acids, and the tumor volume did not increase 5%, so mostly it was of combined type. And the histological structure of the tumor was represented by cirrhosis, adenocarcinoma with moderate differentiation. And according to figure classification, half of the patients had T3A and followed by T3C and then T3B. And as part of our study, site reduction was performed, and PIPAG was delivered in parallel, and we succeeded in 6 cases. And at the first stage, it was only biopsy laparotomy performed, and the site reduction is optimal and was achieved in 50%, in 27% suboptimal, and neo-optimal in 22% of cases. And the subjective study of the patient pre and post PIPAG showed that the symptoms were diminished, as well as oncomarkers like CA125, and the X-ray response was obtained in full in 66% of cases, and partial response in 16% of cases, and the full regression with no cancer cells was obtained in 44% of cases, and moderate response in 38% of cases, and insignificant in 16.7% of cases. And this slide shows our clinical case. A patient is 60 years of age, and it was the explorative laparotomy with biopsy and PIPAG. And after the first PIPAG session and 2 system chemotherapy sessions, as you can see here. Oh, it doesn't. I can't click it. It just doesn't show.
Here you may see the regression of the lesion, parietal and in visceral zone of abdomina. And the second case, a patient 52 years old. Here is before imaging before, and then 4 times PIPAG. We got good results. Pity I cannot open a video, but then afterwards there was a progression of the tumor, and we made the biopsy, and we got to the 4th stage of the treatment pathomorphosis. This way, we obtained preliminary data that proved that PIPAC is safe to treat the abdominal tumors, and it inspires us to continue studies further on in our country. And the studies proved that it is safe, efficient, and improves the life quality comparing to the traditional chemotherapy. There were no complaints from patients to the classical side effects that are obtained with the systematic chemotherapy, such as mucositis, vomiting, diarrhea, paresthesia, and alopecia. And this study is going on. We combine the new approaches in diagnostics and combine the treatment with the aerosol chemotherapy with PIPAC. Right now, we did that on 18 women, the reductive surgery. Out of 18, 6 cases got the complete reduction. So PIPAC therapy is also included into our clinic. Is there any differences? Yes, there are some technical differences. This method of the direct impact to the tumor cells under the pressure. Difference between HIPAC and PIPAC is about the pressure to spray around the medication. It improves the treatment.
Really congratulate on your the new Oh. Ready? So I really congratulate on your the new trials. Yes, and honestly, I have been researching the IP chemotherapy for 30 years, and we have just published our new data, and I will show our data today's afternoon. This is the first presentation after my publication of the New England Journal of Medicine Evidence. Yeah, 2 days ago. So I will just consider thinking that our data may be combined with the PIPAC methodology. So let's collaborate with the new technology for the IP chemotherapy. Thank you so much.
Yes, of course. Thank you very much for your suggestion. Yes, thank you very much for your support and for your suggestion. We would be happy to collaborate with you. And our next speaker is from Moldova, Dr. Uliana Tabuica.
Express my gratitude for this unique opportunity to be here, and especially to Professor Juliana Kaidarova for this priceless experience. First of all, to see how different countries interact, because Moldova, even if it is in some kind in the middle of Europe, we are somehow separated from interaction with different countries. Yes, we have, of course, collaboration with our neighbors like Romania, maybe less Ukraine, but such a big collaboration, or better to say, collaboration with such a big number of countries is unique experience for us, and hopefully we'll learn from it. In continuation, with your permission, I will present in Russian, just maybe it will be more explicit and clear what I want to tell. Дорогие коллеги, я хотела бы поделиться нашим опытом Республики Молдова.
Dear colleagues, let me show the experience of Moldova. I'm Uliana Tabuika, the Associate Professor from Nikolai Testimitanut State University of Medicine and Pharmacy. The topic of my report is the implementation of a modern colposcopy service in the Republic of Moldova, especially when we speak about the pre-cancer patients. So, since it is not the cancer, that's why it is at the level of the gynecological service in the primary healthcare facilities. Us, being gynecologists, we are responsible for detection and treatment of pre-cancer conditions. And only when the cancer itself is detected, then we refer such patients to the oncological departments. The situation is quite sad regarding the cervical cancer in Moldova, despite we do many things to improve our indices. The incidence and mortality is quite high in Moldova. Moldova is in the top of the countries with the highest rate of incidence and mortality from the cervical cancer of Europe. Pity to say, the detection in early stages of cervical cancer is very low. We cannot improve that index, but during latest 2-3 years, we gradually improve this index. Taking into consideration that it's not easy to work on that in the country, we use assistance of international and national experts to assess the current situation in our country in order to detect what are the gaps and be able to improve the situation. Not only cervical cancer, but other cancers as well, particularly regarding colposcopy in Moldova. Before 2015-2017, there was no formal curriculum or certification provided. Means all colposcopists were self-taught and self-declared in order to prove their qualification, because there was no clinical guidelines or manuals. So, no official colposcopy clinical guidelines means colposcopists were free to do what they thought the best. And there were no official training centers with an appropriate qualified personnel, teachers, equipment, and patient flow to train themselves with patients. And also there was no procedure established for quality assurance regarding theta, colpa, histo correlation, and there was no multidisciplinary meeting. In 2015, as a result of multiple collaborations with international experts, we adopted 5-year project plan. It's not only regarding colposcopy, we provided training for teachers. It was provided in the gynecological department in a medical university. And there is a family medicine to identify women from the target screening group. The sampling on colposcopy, cytology, and colposcopy is just
если говорим о кольпоскопии. Во-первых, два преподавателя с кафедры акушерства и гинекологии университета, медицинского университета. У нас только один медицинский университет в стране. Соответственно, с единственной кафедрой акушерства и гинекологии два преподавателя проходили, прошли курсы,
So two of the professors upgraded their qualification and certification
британским обществом,
in the
British
Society
британского общества по кольпоскопии, которое, насколько мы все знаем, является одним из золотых стандартов по обучению и сертифицированию кольпоскопистов. Тот золотой стандарт, на который основываются многие страны, которые принимают собственные программы, либо разрабатывают собственные программы обучения. Для этого нужно было пройти регистрацию в так называемом GMC, Генеральный медицинский совет
UK General Medical Council. We learned English to be fluent in English because no English, no access to the practice. And we got colposcopy primary theory course, and only upon the successful completion, then we undertook a clinical training. And after that, during 6 weeks, we obtained hands-on training, not just observing, but participating in 75 cases of patients. Me and my colleague, after that training course, we were examined and certified by a UK college. That was the very first step that was highly required to provide high-quality further training of Moldova doctors on colposcopy. After that, we developed a colposcopy curriculum based and adopted from BCCP, BSCCP curriculum, and it was approved by medical university, and our curriculum was reviewed and approved by the European Federation on Colposcopy. Our official training contains 75 hours theoretical course, and after that 2 months of hands-on clinical training in our training center in small groups, 2-3 doctors only in one group, in order to provide many cases to be enough practical. All that was accompanied with the preparation of clinical guidelines on screening against cervical cancer. The SOPs, operational standards, recommended the functioning and stipulated the procedures for all the departments on the screening of cervical cancer, including colposcopy. And the national protocol and all the doctors working in the screening program and integrated screening, they are obliged to base their work on those guidelines. Our country is very small, and it is quite easy to control the process because the cervical cancer screening is one of the main directions in oncological screening, and it is well supported by Moldovan Ministry of Health. They provided renovation of the facilities, and also there is a Japanese embassy in Moldova who financed and helped us a lot buying all the equipment that we needed. It was a very generous support from Japanese embassy, and the primary dedication of cervical screening guidelines specified that all women with high-grade cytology or repeated low-grade cytology should be referred to our center. Thereby, we guaranteed a sufficient patient flow for training program as well. Here is the establishment of clinical training center. we comply with the requirements on equipping and diagnostics and treatment for the cervical cancer patients.
Наверное, еще не последнее, но тем не менее, что нам
And
еще
what about
удалось сделать? Мы
implementation of
внедрили
the
процедуру
QA
обеспечения качества, по крайней мере, на данный
And
момент мы разработали
currently we have
те
already
критерии
developed
качества,
the
которые
criteria on
необходимы для
quality
оценки
assurance that are
кольпоскопической службы.
necessary
Они
for
также
the
находятся и в программе обучения, то есть каждый врач,
service
который проходит
department.
обучение
And each
кольпоскопии,
doctor trained in
обучается и
colposcopy
тому, что какие в результате критерии будут
to
оценены,
interpret
как
the
будет оценено его
criteria
качество работы. И,
and to
конечно,
know
эти
the
рекомендации, которые
assessment
сказал
of
наш
his work.
SOP,
And
включают
SOP
эти
guideline
стандарты
includes
эффективности для того,
those
чтобы мы знали,
standards
что нужно оценивать в результате.
to understand which
Из
way
того,
the
что у нас было до
efficiency
2015
and
года, что у
quality
нас
to be
изменилось
assessed.
сейчас, у нас существует
So,
на данный
since
момент официальная программа обучения
2015,
по
what
кольпоскопии,
has been changed?
проводимая
We have an
сертифицированным британским
official
обществом
colposcopy
кольпоскопистами в
training
хорошо
program
оборудованном
that
учебном
is
центре с
delivered by
достаточным
the
потоком
British
пациентов, чтобы дать врачам-курсантам
BSCCP.
необходимый опыт. Клинические
We
рекомендации у нас
certified
существуют по
colposcopists
кольпоскопии,
through a
которые
well-equipped training
кольпоскописты
center.
обязаны
We
следовать по закону.
provided
И
a
у нас
well-established patient
внедряется, и
flow that is
надеемся, в дальнейшем
sufficient
будут еще, скажем
to
так,
give trainees
лучше
the
работать. Программа
experience
контроля
that they
качества
highly
кольпоскопии
need.
с широким диапазоном
The
показателей
colposcopy clinical
эффективности. Спасибо за
guidelines
внимание.
are
Я
legally
сфокусировалась
required to
исключительно на
follow.
кольпоскопии.
Thank you very much for your attention. Thank you very much for your informative presentation. Let us ask you regarding your training center on colposcopy. How many persons from which countries you accept? Is it dedicated for Moldova country only, or? Thank you for your question. Now it's dedicated for Moldova only, at least now, because we established that training center on colposcopy 3 years ago only. It was initially dedicated to national needs, but further on it will be provided an opportunity for Russian, Romanian and other speaking countries to train. We have been thinking already to provide opportunity for other countries as well. So, are all the doctors certified, or you provide train the trainer? We have 5 doctors, 2 of them certified by the British Society, BSCCP. Then we obtained a train of trainers, TOT, means we are authorized to train the others, and other 3 doctors out of 5 are working as well. This is a national center. It is financed by the Ministry of Healthcare. And students, do they pay anything? No. In case they meet our requirements, the medical service is free of charge in our country. In case patients even should pay something in private clinics, it is paid according to the state rate. It is very cheap. Do you provide screening? Yes, of course. I was speaking about colposcopy only, but we have a screening program introduced in our country. It is based on cytology, at least now. The interval of screening is 3 years. This is a primary recruitment into the family-based screening should be done by gynecologists, and in case there is a cancer detection, they are referred to the oncological institute. What about vaccination? The vaccination works well in our country. Pity I have not prepared statistics. Starting from 2018, we introduced a Gavi-supported program for girls' vaccination from 9 years old. They understood it's too early and mothers are not early at that stage.
So the vaccination coverage is nearly 56%, girls under 12. But since we have, so to speak, extensive vaccination capacity, so it's for women before 26, so without the need for testing. Thank you. So far, the vaccination is free. Actually, we do not meet Moldova that often, so thanks for coming. Thank you for this opportunity to come here. So we will be in touch. Thank you.
Next presentation from Mongolia, update of gynecology oncology in Mongolia. Ayush Erdener Jargal. Sorry.
Good morning, everybody. I'm Erden Jargal, Ayush from Mongolia, work at the National Cancer Center of Mongolia Gynecological Surgery Department as a gynecological oncologist. It is a great honor to participate in great summit, to learn, to share, to get information, and also to know where Mongolians we are in this gynecological oncology field. And there's a Mongolian proverb says that seeing once is better than hearing 1,000 times. So it is, I'm quite indulged by your hospitality, Kazakh organization. Here is my homeland. Mongolia is quite similar to Kazakh landscape. The Kazakhstan landscape and socio-economic roots are quite the same. So Mongolia is one of the largest landlocked country and small population. Our Mongolian population is 3.5 million people roughly, and half of them are male population, half of them are female population. Also, the women aged 30 to 65 is 750,000 women are living in Mongolia now. And 1/3 of the population are children under 15-year-old, which is a quite young country. So we need to concern about our vaccination in the near future, HPV vaccination. This is the National Cancer Center of Mongolia, which is a territory-level cancer caring service, whole country, and then we are teaching and research and cancer caring service. In Mongolia is a quite unique compared to any other countries in the world. The most common cancer among Mongolian population is a liver cancer. 1/3 of the population suffers from liver cancer, male, female, in both sexes. And for male population, liver cancer is number 1, and second is stomach cancer, third is lung cancer, and esophageal cancer, and colon cancer. Among women, liver cancer is still number 1 common cancer, and cervical cancer is the second common cancer, and stomach and breast cancer and esophageal cancer is the 5th most common cancer among Mongolian women. Of course, the cervical cancer incidence is highest in Mongolia, as like 20 incidents for 100,000 women. And the mortality rate is also high because of the most women diagnosed with the cervical cancer is diagnosed in a late stage. And radiology treatment is given only in the Cancer Center of Mongolia. And cervical cancer morbidity is still the same for the last 7 years. It's almost plateau. And cervical cancer mortality is also quite, mortality rate shows a plateau too. And cervical cancer screening program we established in about 2010, cervical cancer screening based on cytology tests, but in 2021, WHO guideline translated and adopted into Mongolia, so we will soon use the new cervical cancer screening guidelines. So Mongolia is a country included in a target country to global strategy towards eliminating cervical cancer public health problem. And HPV vaccination will be scheduled for kids as a national scheduled vaccine program. Cervical cancer detected by screening versus incidence of the cervical cancer. The blue column shows that the cervical cancer incidence each year, and the yellow column shows that the cervical cancer indicated by cervical cancer screening program. So which shows that screening is not, efficacy is not well enough. And our department is the gynecological surgery for gynecological cancer patients. So we receive all gynecological cancer patients all over the country. And last year in 2022, we received 150 cervical cancer. We performed 150 cervical cancer surgical procedures, including a radical hysterectomy, simple hysterectomy, total laparoscopic hysterectomy, and modified radical hysterectomy, pelvic lymph node dissection. We also perform outpatient setting for pre-invasive ablation of the cervix, such as LEAP, large lobe excision T-zone, and cold knife conization. Here is we published a teaching book 2 years ago and used our radiological materials and then our biopsy materials and our materials. So pathology report comes with the figure staging, latest figure staging. We use those tumor types and size of the tumor and the cervical margin clearance and lymphovascular invasion, and all of those things will be analyzed and calculated for risk factor. National Cancer Center actively follow up for 5 years. And then after that, we refer the patients to their primary level. With the cervical cancer diagnosis and treatment, those advantages and disadvantages is happening. Improving cervical cancer screening coverage needed essential. Also, proficiency improvement at every level, primary, secondary, and laboratory level, and then even in surgical field. Quality control is weak side of cytology tests and every level. And the most challenging problem occurs practical doctors like for us is recurrent cervical cancer, especially after who had a radiation chemotherapy treatment for late-stage cervical cancer. There's some advantage of Mongolia in the cervical cancer field. If there's somebody wants to be screened, wants to get the proper care, there's always chance to be screened. And once person diagnosed with the cervical pre-invasive disease or cervical cancer, once they diagnosed, there's no delay of a surgical treatment. Radiation treatment takes, there is some time delays. Ovarian cancer is the deadliest cancer occurring in Mongolia among women. And last year, we received 1,404 ovarian cancer patients, including borderline tumor, epithelial, non-epithelial ovarian cancers. For ovarian cancer, we usually do staging surgery for all cancer cases. Intraoperation frozen biopsy done if the fertility-sparing surgery is indicated. Total hysterectomy, bilateral salpingo-oophorectomy, amantectomy, peritoneumectomy from at least 4 quadrants of abdomen, and selective pelvic and para-aortic lymph node dissection performed, resection of the intestine, and appendectomies as well as performed. Also, the National Cancer Center, all the OR units located at the same place, so once it's scheduled, or even though it's unrevealed situation, we get help from general oncologists or hepatobiliary surgery department. Surgeons will help us in the surgery. And also, even though we don't have the high-tech machine, we tried several cases for mechanically. After we did the debulking surgery, we just washed the abdomen with the chemotherapy, especially most cisplatin. We see that the results were quite good than we were expecting, especially towards to the original chemotherapy versus generic chemotherapy. Also, we use the neoadjuvant chemotherapy for late-stage ovarian cancer. Like, it is not big study. It's just in my department, 68 patients enrolled in this study, and neoadjuvant case for 30, and primary surgery and adjuvant chemotherapy for 38 cases. Still, until today, we don't see the big difference between those two arms. For adjuvant chemotherapy, we use the platinum-based chemo and Avastin mostly. And last year, the monoclonal antibody atezolizumab are introduced. We don't have PARP inhibitor, immuno checkpoint inhibitors, or that receptor of tyrosine kinase target therapies. But in our practice, recurrent ovarian cancer is the most challenging project. And then also, because of we don't know it is platinum-resistant ovarian cancer or no. With ovarian cancer diagnosis and treatment, those advantages and disadvantages is happening. Neoadjuvant chemotherapy reduces the surgery-related complication. Also, chemotherapy choices are increasing every year, like the pemetrexed, pertuzumab, atezolizumab. Those are the new drugs officially entered the drug registration like a few months ago in Mongolia. Diagnosing issue and issues in primary and secondary level is always a big problem. And once the surgery is performed in a primary and secondary level, second surgeries need to be performed in our hospital. So it is due to the malpractice. With endometrial cancer, it's quite the same as in other countries. And we have been using sentinel lymph node mapping by using indocyanine green fluorescence imaging technology for endometrial cancer staging for the last year and a half. And then as well as the liver cancer patients using the indocyanine green fluorescence imaging technology. With endometrial cancer, those advantages, disadvantages is happening. Mostly the endometrial cancer diagnosed in the early stage, we are facing with some real rare endometrial cancer, for example, primary squamous cell carcinoma of endometrium and some sarcoma types. And the challenges occurs like recent years, the Mongolian population became very obese and diabetic patients, and younger generations are getting hormonal side effects. So if endometrial cancer diagnosed in younger patients and nulliparous patients, when they need fertility-sparing cases, the hormone treatment options are very limited. And so for the last 5 years, this endometrial cancer classification and staging is versus to genetic mutation-based classification. So it causes our treatment goal, like if something totally different than we were used to working now, gets us some confused. Okay, thank you very much for your attention.
Thank you so much. Thank you so much
for your presentation. And now we would like to introduce the representative from Uzbekistan, Dr. Nargiza Zahirova, old partner and friend of International Gynecological Cancer Society and American Eurasian Cancer Alliance. Very unique experience in Uzbekistan for HPV vaccination, for Central Asia and all throughout. So we're very much looking forward to seeing your update. Thank you.
Thank you very much, dear Sophia. Здравствуйте, уважаемые коллеги, уважаемые организаторы. Для меня большая честь.
For me, it is a great honor to present such a significant event, not only for the ONCA service of Kazakhstan, for the practitioners, but also for the entire globe, especially for such developing countries as ourselves, and best regards from Uzbekistan to you, Dilara and Sophia. So I will update you on the achievements and prospects. I will deliver in Russian. You will see slides in English. So cervical cancer takes second place after breast cancer. As you can see on this slide, there are 14 regions, or we call them oblasts, or like territorial zones in the country. So the biggest is Tashkent in the capital, but it also depends on the level of the diagnostics, the screening level. So in it's Tashkent and Pakistan. So over the past 10 years, the mortality, both mortality and morbidity, have been growing. Last year, 2021, we had 1,827 cases, and nearly half died. So in terms of the stages, so these are usually locally distributed stage. So this slide shows the incidence of cervical cancer by age, and you can see that the peak is between the age of 45-55. As of today, or to date, we had the following programs developed. In 2006, there was a 5-year UN Global Joint Program on Cervical Cancer Prevention and Control, and we were selected among other countries as a partner. And within the framework of this program, we received WHO Regional Bureau experts who explored the primary service, the ONCO service, the lab service, and the conclusions that they came to were the following. Since there is no cytology lab service, it is not able to introduce the screening, as they cannot maintain the quality control. So Uzbekistan was recommended to introduce HPV screening. So how is the program managed? So we have 3 levels: primary, secondary, and tertiary prevention. So in each of these levels, huge work was carried out, and one of the achievements was back in 2019, and in October that year, HPV vaccination of girls aged 9 to 14 was launched nationally, and there was around 300,000 girls aged 9, and it was the tetravalent vaccine Gardasil.
And I believe very soon Kazakhstan will start to implement the national program as well. And it's not easy in such countries like ours. It's more difficult because we are Muslims countries. That's why there were lots of impediments and contradictions. Yes, there were lots of challenges. 1 week before vaccination, we started to have 1 week in advance anti-vaccination movement via social networks. They started to make sabotage and different information. They were sending misinformation that someone passed away because of vaccination, and lots of non-fertility cases after vaccination. And we got lots of claims asking to stop the vaccination. It was not easy for us to work there in Uzbekistan. So these are the pictures, the way we were driving around the schools to explain the vaccination purposes. The vaccinations were conducted in medical centers, secondary, primary healthcare facilities. The vaccination coverage of 9-year-old girls in Tashkent city, the capital of Uzbekistan, at the initial stage, after the first dose vaccination, in a percentage it was almost nothing. It was not easy to convince the parents. It was not easy to work for doctors and for teachers in schools. And together with UNICEF and WHO office in Uzbekistan, we established mobile groups driving around religious centers that are called mahala, and they were driving around schools explaining the purpose of vaccination. And after that we improved coverage, but it was extremely not easy in the beginning. Also, we provided the communications in mass media together with bloggers. We shot different videos. And the main reason to refuse was the fact that vaccination impacted fertility. That was the main thing that they cared about. And then, together with the Ministry of Healthcare, we have found girls who were vaccinated in 2010. And Vaccina Cervarix, 10,000 doses were imported in 2010. Those girls were 15 years old. We found not all of them, especially those who have already had kids. We invited them and made videos together with them. Here are the main reasons for non-vaccination at the induction of the first dose in the Republic of Uzbekistan. The data is starting from October till November 2019. So the main reason was the orange medical exemption, yellow refusal to vaccinate, green temporary refusal. Here is the vaccination coverage table, data from 2019 till 2020, the first dose data. And the second column is the second dose on 9-year-old girls and the vaccination coverage So they were subfebrile, increase of temperature, sometimes losing conscious, not more than that. So almost no severe adverse effects during and after vaccination were observed. Here is the data about the elder girls, 12, 13, 14 years old, and the data is for 2021 for the first dose, and the process of vaccination is regulated by our agency on epidemiological surveillance that is reporting to the Ministry of Health in Uzbekistan. This is the percentage of coverage. What about the secondary prevention? The secondary prevention is screening in Uzbekistan. Within the framework of the joint UNDP-UNFPA pilot program to strengthen the resilience of local communities in Aral Sea region for environmental and economic vulnerabilities, as well as in the public healthcare issues. That was supported with the kind support of Japanese government. It was implemented in Karakol, Pakistan, and Cherchikersk city. We organized local laboratories. The expert HPV assays was a qualitative in vitro diagnostic test to detect the E6, E7 region for HPV 16, 18 in patient specimen. The analysis was performed in a CFA gene expert system. The gene expert HPV test specifically identified HPV 16 and HPV 18/45 types in two separate ways. In order to prove our words, these are the pictures. And also, we obtained good results from videos developed by UNFPA. 2 videos in 2 languages, Karakalpak and Russian languages. The biggest success was from Karakalpakstan language. It was much more clear in a simpler language. And we were traveling around Aral Sea, and we involved bloggers. That system is well developed there. One of the main issues to successfully implement a screening project is a regular monitoring of your project in order to evaluate the quality of screening workers. We were driving around monthly in Cherchik and Karakalpakstan regions to provide monitoring. Here is the data on monitoring of pathomorphological service. And after referring to oncological centers, the patients were sampled with biopsy. I don't know which way it works in Kazakhstan, but in Uzbekistan, life is very different in the capital and in the rural area. The qualification of a specialist is completely different. And that's why we had to invite a leading specialist from a capital, from Tashkent, and send him the results from rural area. Because before we had very strong differences in the results from assays. And the blue line is showing the Republic of Karakalpakstan. The yellow is Tashkent region. The results of that project included women from 30 up to 35 years old. Here on the slide, you may see different diseases detected. The cancer in situ is in yellow color and invasive cervical cancer is in blue. All those patients were served in Nukus city and in Tashkent Regional Center, and to our center as well. There are identified precancerous diseases and cervical cancer based on the results of a pilot project in the Republic of Karakol, Pakistan, in the city of Chirchik. And the third graph is showing the distribution of identified patients with cervical cancer by stages. Here is the way we provide the sample collection, the algorithm that we used. After testing in women with a positive reaction by randomization, we provided two types of triage. A simple observational colposcopy and another one is visualization with an acid, VIA. And after colposcopy, if there is a suspect on the lesion with cancer, they were referred to the oncological center. For those with the CIN more than 2, they got thermoablation. Those who are CIN 2/3, they will be invited for next screening in 7 years next time. And this year we are going to retest them again, by the way. Thanks to that project, we thank the Embassy of France as well. We obtained 4 pieces of ablative thermal coagulation equipment, very important equipment against the cervical cancer. 3 of them were delivered to Karakol, Pakistan, and 1 is to Chirchik city for excision of the transformation zone with a large section. These are the standards and clinical guidelines that we elaborated and proved with the Ministry of Health in Uzbekistan. They are updated annually. Here is the way we work on radiation therapy. And we had a very poor situation regarding radiation therapy. Thanks to the implementation of Islamic Bank project, we obtained 2 linear accelerators named Electa Infinity, operating in Tashkent city branch and in our clinic. We have purchased and installed 11 gamma therapeutic and 7 brachytherapist units. In order to eliminate cervical cancer and prevent it, we implemented different initiatives. What are the prospects? By the end of this year, we finalized the building of our center. It is almost done. And now we hope to obtain second phase investments from the Islamic Bank, including equipment equipment to test against HPV. Thank you very much for that, and let me thank colleagues and experts from WHO and UNFPA. Thanks a lot to Philip Davis. He is regularly assisting and supporting us during this screening program. He provided a regular consultancy because it's a very new thing for us. And thanks a lot to Isabel Hurd, Vitaly, and Ms. Skorbix. Their assistance is so precious for us. And thanks a lot to IGCS and Miss Sophia Michelson. She is a close friend of ours. And I have not finished the colposcopy training course, but this is a very interesting training course. Thanks to Mary. It's really worth making that with Mary Aiken. She is great. The International Oncogynecological Society, IGCS. And also I liked the presentation from Uliana from Moldova, because when we introduce colposcopy screening, it will be a big issue to train our specialists, because we have triage. We cannot afford cytology. That's why we would like to contact Moldova to train our specialists for colposcopy. If you have any questions, you are more than welcome. Thank you very much, Nargiza, for your interesting experience, and I'm sure that you are going to have the first results. Yes, probably you will visit us. Thank you. And the next presentation is from our friends from Ukraine, Professor Svintsitsky. The So Professor Svintsitsky, together with his daughter Anna, Miss Svintsitska, arrived to us from Ukraine with his topic vulva cancer, the non-standard surgeries. Good day, dear colleagues. Let me thank IGCS representatives and the Kazakh Oncologists Society. Thank you very much, dear Dilara Radikovna, for inviting me and giving me an opportunity to be with you here. My report is dedicated to the topic of vulvar cancer. It's a quite rare disease. We cannot say it's an orphan disease, but even oncologists meet that patients quite rarely. So this is a disease with a specific clinical course and characterized by high growth rate and most often with unpredictable prognosis. This cancer is treated with surgery and radiation. And according to different authors, the structure of malignant tumors in vulvar is not easy to treat. The suture place, it can be with side effects. You should provide a proper cosmetic effect and to minimize surgical side effects. In the Cancer National Institute of Ukraine, we have 30 years experience in treating about 800 patients with vulvar cancer. 800 patients are registered with our center. They are elderly people. 80% of patients are aged from 50 up to 70 years, and more than 20% of patients are aged and elder than 70%. The vulvar cancer, clitoris cancer, is usually treated with standard radical vulvectomy and usually is having the good effect. Sometimes you may see the giant pigmented tumors, the benign tumors, and this is a very young patient. She was 28 years old, and it was a cosmetic surgery for her. But today, when Ukraine is busy with the war, there are lots of issues to be solved with women, children. Such problems of today are relevant to medical workers as well. They are provided for the war and to service the needs of the war. And some patients could not be referred to us timely, and they could not obtain treatment on time. Here is a patient. She is not old, just 57 years old, but she had such a big tumor. That was the first time detection, and we detected the metastasis in the lymph nodes. And we provided quite a big scale traumatic surgery on her. That was a radical vulvectomy, resection of urethra, and the femoral dissection.
So the patients after such types of surgery have a challenge of adaptation to this injury margin and the replacement of that defect. So you can dissect it all, but how the wound will be healed and how to prevent those to post-surgical complications, because sometimes there can be osteomyelitis and perostitis of the femoral bone. So here we see the displacement of the tissues and the as well as the displacement of the layers, but we were able to stitch them without extending them too much so as to disrupt the blood flow. So this is the patient 6 weeks after the surgery, and she already started the radiotherapy. And this is another case, a patient who received cancer treatment. She had the surgery, she had her vulva removed, and there was an attempted resection of the tumor, and she had radiotherapy, and it was difficult to perform such a surgery, so we were thinking how to replace the defect. Of course, we can do the surgery. So this is the very start of the surgery, and the patient had this recurring tumor growing into the urethra. And after the surgery, we decided that just the surgery would not be radical, so we had to resect the urethral neck as well, and then to drain it and to divert the urine, and then to perform the plastic surgery. And there are a few ways or approaches to replace the defect. So there can be flaps, transverse flaps used from the rectus abdominis muscle, or as we can see here, so there can be few approaches. So our thinking was to find the flap closer to that replacement area, and so that was our selection logic. So here we have musculus rectus abdominis and the epigastric inferior vessel, and that the anatomy. And we could see that all the branches that feed that muscle and the artery, which is circumflex femoris medialis. And the plan was to cut that flap with modulus gratilis. And this is the flap fragment and the distal end of the musculus gracilis that was intersected, and also the tunnel was formed that is commensurate to the size of that flap, and through this tunnel it was moved to the groin, and then we started to form the vulva. So it is the stage closer to the surgery, so we really need to be careful during the flap procedures as not to damage the artery. Otherwise, the surgery would not make any sense, because if the blood flow will be disrupted, you know, it will be rejected, the thrombosis. So it will be rejected. So of course, the surgeon has to be mindful of that. So another patient, but the same logic of the surgery, and so that was the initial stage, and this is post-surgery. The oncogynecologist, the patient visited the oncogynecologist, so that's the surgery. And next patient, and the tumor appeared to be histologic lymphosarcoma in the vulva area, so the pain was acute, and the patient received a number of painkillers, including those with narcotic effect, and she demanded any treatment because she simply couldn't live with that tumor. And we thought that we could perform the primary surgery with the replacement of the flap from the front abdominal wall, and oftentimes this flap is used by mammologists, cosmetics and plastic surgeries. So this is the surgery stage where the flap was moved, where the wound was stitched, and so here how we just formed the vulva, and some 3 weeks or 4 weeks after, so that's the last photo available. So what are the prospects? So what are the prospects for the treatment of patients with vulvar cancer? Unfortunately, we see them more often because people simply can't reach the doctor, or in this situation they are in, they simply just don't care about themselves. And we also believe that another serious factor that disrupts the diagnostics and the treatment is the spontaneous blackouts, and of course the poor operation of the diagnostic equipment and radiotherapy equipment. So, and what is possible, the wider use of combined operations with the resection of the centrally located structures for the vulva, the use of plastic and reconstructive operations such as fascial or musculoskeletal flap, and early detection and treatment of relapses. Thank you for your attention. Thank you. Thank you. I have one question. So in the current situation, as I understand, there are a number of sick persons with interrupted chemotherapeutic sessions or any other treatment sessions. So where do these people go? So not only people in Europe, but I would say that patients receive a full treatment cycle in Ukraine, but we also have internally displaced persons who out of the front line. You know, the war covers the entire Ukraine, so we have over 1,000 kilometers of front line, but there can be, you know, air attacks every other day. So it means that even during the air warnings, you know, we just don't go to these shelters. We just continue performing our surgeries. But patients are able to come to us, you know, not only to us, but in the clinics that are located beyond the front line, so outside of that area. So we have a full chemotherapy medication cycle. It's all free. But the first way, when the war was just started, so millions of patients moved abroad. And of course, Poland was and Moldova were the first ones to receive our citizens. And thank you so much. So our citizens moved there to the states that located closer. So it's also the Baltic countries, Germany, Italy. I don't want to actually to ignore anyone, but there are just many countries that received our patients, but we were in closer contacts with Poland. And our patients who couldn't receive target therapy in Ukraine were actually administered the target therapy in Poland, in Germany. But 6 months after the war, half of the population returned, even though they just found the solace, some safety and security outside the country. They returned. And they now receive treatment in the central areas and the peripheral areas of Ukraine. And of course, we actually have this support from other countries like the United States, England, Poland, Germany, and others. And we are very thankful for that because there is like an unending flow of people. Just like 2 months ago, we uninterrupted flow of deliveries. So we received support not only for the military, for the army, but also for regular citizens, including occupations. Thank you so much. And representing the actually both the American Eurasian ENG Alliance and the and ICCPA stand ready to assist your center, just as any other center located in Ukraine. I know that we have representatives from Kharkiv here, so we meet often, but we can actually cooperate more closely. So anytime, together with Dilara, we will be glad actually with you and with the IGCS. We will be happy to cooperate with you, to talk with you, and to engage you in any project you may wish to. Thank you. Thank you, Valentin. And now we have another reporter from Ukraine.
Владислав Сухин, our friends. Мы дружим с Владиславом уже более 12 лет.
So we know Vladislav for, I think, 12 or even 15 years.
When we was younger, way younger, we started our professional.
Dear Dilara, Sophia, I'm so pleased to take part in such a wide-scale international event. It is very important for us to have friends, you know, here.
Carcinoma is that kind of cancer we can discuss for a long period of time, and after a talk we had yesterday, it was very fruitful work. I can just add some key points we need as practitioner oncogynecologists to pay attention at. It's not hidden disease, so-called. Patients come to us with clinical, usually bleedings, but many colleagues forget about examination for Lynch syndrome, because parallel with endometrial cancer, we can from time to time reveal colon cancer. So in our century, many things were changed. Now we don't pay attention about traditional histological classification. It comes to the second position, but to the first position come molecular biological classification and biological life of tumors. They were detected for molecular subtypes, due which we should prescribe more or less aggressive treatment for our patient. And it doesn't matter if it's the onset of disease or it's advanced cases. The preoperative examination is almost the same, was not changed during the last period of time, but what we have now, opportunity, especially for colleagues who work not at cancer centers, but in small hospitals, they could just make pipal biopsy in order to obtain tumor tissue and send for pathology for investigation. There is another problem I've got to know during the last period of time, especially in Z clinics who works under insurance medicine. They are not allowed to prescribe for the patient CT, MRI investigation as the first step of preoperative examination. It's very important for us because if you don't perform such investigation, we can lose, for example, metastatic affection of liver or lungs or some groups of lymphatic nodes. So the stage should be changed and we don't know about it. It's not obligatory to perform PET-CT, which is more expensive, and patients need to spend a lot of time waiting for their termin, but CT is quite easy. Among the recommendations which were obtained last year, it's every specimen which obtained by a physician during curettage, pipal biopsy, or after operation should be sent for pathology, not for detection just for myometrial invasion, but LVSI detection and immunohistochemistry staining for P53 and MMR status of tumor. The most important prognostic factors, it's tumor profile of molecular markers of the tumor. And also, it's very important in which situation come to pathologists the tumor after operation. Was it intact? Was it morcellated? If operation was opened or laparoscopy, because not every colleagues have so high skills as big cancer centers. So we see a lot of mistakes in our practice, but they should be corrected with the time. And so the most important principle of surgical staging which comes on the market now is sentinel lymph node mapping in order to check the stage of disease and concern appropriate treatment program for each patient. It's a very good thing for us. Many societies such as NCCN, ESGO, ESMO, ESTRO review guidelines each year or each 3 months in order to provide us the most important modern information how is better to treat our patients. Depending on cancer center, it could be a good oncological team and they could meet each week for discussion the most important clinical cases, but on contrary, there is such centers, they don't have such habit, and each physician, each oncogynecologist make appropriate decisions themselves. That's why it's the best option for them. Yesterday we discussed adjuvant treatment, the best option for a certain group of patients, and we don't need to forget that besides radiation therapy as adjuvant treatment, there is also chemotherapy and hormonal treatment as its complex treatment. NCCN performed description of not common but peculiar tumor types such as clear cell carcinoma, or carcinosarcoma, which contribute the most aggressive treatment, starting from stage 1A. The most important thing, we obtained such news last month. It was announced that we have now one more new medicine which should be prescribed for advanced or recurrent disease, which shows reduction of risk of disease progression or death observed in certain group of patients, but you see the difference in survival rate is great. In spite of the work which lasted in Ukraine for more than 1 year, we working and my colleagues in Research Institute and our investigational project, which was started before the war, are continued, and we have certain results. We investigated the tumor markers expression and obtain results in which combination are of poor prognosis. The 5-year survival more or less in the same level without dependence on countries. Hormonal treatment is also suitable for recurrent and metastatic carcinoma, especially for those patients who, with advanced cases, have no possibility to come for the hospital and obtain chemotherapy, which is very hard for them. In conclusion, I would say that lymphatic node styles, due to modern approach, should be the key point. And in case of carcinosarcoma, we need to apply the most aggressive treatment because we don't know what to suspect further. Sarcoma is one of the most aggressive tumor types of the uterine disease. Incidence is very low, but still we should know what to do. Here's the list of tumor markers which use our pathology in order to detect certain type of sarcoma. NCCN guidelines propose us different approaches for the treatment because sarcoma is such a tumor which cannot be precisely defined on the first stage, on the first examination, and in the most part, about 99%, I would say so, we obtain diagnosis only after the operations, which usually conducted in certain gynecological inpatient departments, not in oncological clinics. And many patients come to us for adjuvant treatment or for another OP because it was not appropriate. Hormonal therapy has its own position. Our experience, we have performed investigational project. We tried to define which of tumor markers, molecular markers, should be prognostical. One of them is PD-L1. It's transmembrane protein, which was quite new and not investigated in uterine sarcoma. And due to our results, we observed in endometrial stromal sarcoma about 40% expression level and responded to the low expression level in 80% of cases. So the expression of this marker is concerned to unfavorable prognosis with a relapse rate up to 50% of cases. We also evaluate the expression of MMP9 marker, and we've seen that co-expression of these two markers are extremely unfavorable prognostic factors. The relapse rate was detected in 100% of uterine sarcoma patients. We defined combination of tumor markers which should be prescribed more or less aggressive adjuvant treatment. It's our own experience as an investigational center. And you see, in case of expression of both estrogen and progesterone receptor, it's a situation when it's the most favorable prognosis. In such patients, contribute only hormone therapy. In the treatment results are the same as chemotherapy. They don't need to obtain chemotherapy because they obtain only toxicity and that's all. And opposite, patients who have negative expression of P53, they contribute the most aggressive and long-lasting treatment. So you see, if we have co-expression of estrogen and progesterone, is the best results. The relapse rate is lower than 20%. In conclusion, I would say that detection of molecular markers define the treatment plans and prognosis of the disease. A couple of words of our country. Ukraine is a huge country. It's more than 1,000 kilometers from east to west, and it's the second largest European country in the world. Previously, we have the population about 45 million people, but due to the war, many people migrate abroad, and from time to time, they try to come back home. In Ukraine, in every big city, there is oncological clinic, and besides that, in Ukraine there are two research institutes. It's National Cancer Institute, which is located in Kyiv, and our institute where I work, Institute for Medical Radiology and Oncology in Kharkov. Both institutes, they have more than 100 years history, and so the whole this time we try to perform investigation in different fields, not only gynecology, but all branches of oncology. War started more than a year ago. It was very awful to us, unexpected, but we try to, in spite of less personnel in clinics and low medication supply, we try to continue treating of our patients as soon as possible. But we survive, and we hope we continue our work, our investigation on the better level. Thank you.
Oh, well, it's a very nice presentation. Thank you so much.
Thank you.
I have one question about the treatment strategy for the sarcoma you are approaching. The one question is that we do not provide any radiation therapy as an adjuvant therapy at all. The second question is that you investigated about the PD-L1 expression. Are you going to incorporate that IO therapy for the sarcoma?
Let me start from the last questions. Actually, the information, our results about investigation of PD-L1 markers were presented even in Kyoto. It was first step, it was meeting where we published our abstracts, and it was very interesting for us, and the reason was to find a marker which should be prognostic. And when we see there is expression in sarcoma tissue, this marker, it should be investigated second step how it can be applicable anti-PDL therapy in these tumors. But the problem is uterine sarcoma, it's a rare disease. We were happy, we collected about 150 patients. It's 2 centers. It's a rare disease. Previously we have 1-2 cases a year. During this work, I know how could we attract it, but we have 2 cases a month in our centers. So we collected such cohort, and investigation of PDL marker was conducted together with our Swedish colleagues. It was double-checked because it was quite new marker and nobody knows how to operate with it. And we will be happy to continue these investigations from the position how it can be applicable treatments. Our center participating in international clinical trials and in the most part with MSD and GSK, and I've asked colleagues, I've asked medical team, how is it possible we have such experience? It will be great to cooperate. We will be glad to be helpful in this process if it's possible to start this investigation. But until now, as far as I know, there are some projects concerning soft tissue sarcoma, but concerning uterine sarcoma, there is no. And about radiation therapy, actually, our institute is based in the most part on radiation. We have many labs which perform investigations also in animals, in cells, under radiation influences. That's why it was decision try to perform radiation therapy in different oncological disease. Breast pathology, uterine pathology, and so on, so on, so on. There are published data, it was before us, that there is some success in conducting radiation therapy in uterine sarcoma also. We, based on that, we collected data, and there is lab which perform under electronic microscope investigation and try to define how many alive cells stay after a certain stage of irradiation. We cooperate with them, and they help us to define which dose we need in case of sarcoma. Of course, it's different to the dose of radiation in case of endometrial cancer. It's up to 50, but it's the same in NCCN protocols now, which were presented yesterday. And we tried to perform the most comprehensive treatment for this cohort of patient in order to obtain better results. But because it's better to do it now on the first step than obtain later patient with relapse disease, and then it's a question what to do. And then there should be change. It's not topic of this talk, but what we have suspected. In relapse disease, in the most part of patient, the tumor biology was changed. And we have another expression of these markers, and also morphological grade. And we try to find appropriate treatment. Of course, it is chemotherapy or hormone therapy in this patient, because at the first stage there was already applied the whole dose of radiation therapy, and it's impossible to apply. The only thing, if in certain patients there was applied only EBRT and there was no brachytherapy, of course we can do. But it's nothing, it's like 20% of success. And that's why we strive to make the most aggressive, most comprehensive treatment on the first stage.
Great, thank you so much.
Thank you. Thank you for interesting discussion.
Thank you, my friend Vladislav. Yes, I hope that you will stay and you will survive, and we will meet many, many times in our life. Thank you.
It's a pleasure. Thank you.
Last report from Korea, Doni Hon-sang.
Video?
He will be online, yes? Yes. Uh-huh. Suggestion from ASGO and GGO. Yes. Hello, Don?
Hi, hello. Can you hear me?
Yeah.
Yes.
Yes, good. Yeah, actually, good morning. I'm Dong Sa from Korea. I'm a gynecology oncologist, and now I'm serving as an editor-in-chief of the Journal of Gynecology Oncology, JGO. Actually, it's my great honor to have this opportunity of presenting about my journal plan together with the affiliated society, ASCO, the Asian Society of Gynecology Oncology. Actually, the plan is about a periodic report of cancer statistics in Asia. Actually, it is not about the medical thing like a cancer diagnosis or treatment. Before I start my presentation, I have to tell you I'm so sorry I'm not attending the meeting in person there in Kazakhstan, Almaty. The annual Congress of Korean Society of Gynecology Oncology, KSGO, is now ongoing here in Korea. So I am like this, I have to attend this meeting. I cannot miss this. Please excuse me to make my presentation by online. Okay, let's get started. Please give my presentation slide. Can I share my slide here?
You need to share because...
Okay, let me do that. Can you see my slide there?
No.
No?
Oh, we got it.
Yes, it's okay. Okay.
Yeah. This is my presentation title of today. Suggestion from ASCO and JGO. The subtitle is about report of the cancer statistics in Asia. Okay, let me start. Okay. You are seeing now the world map with the corresponding gynecology cancer society. So center is ASCO, is about Asia Society, and for Europe, European Society of Gynecology and Oncology, and also ASGO is for North America. And also we have IGCS, International Society, the president by Dr. Keiji Fujiwara. And we also have the corresponding affiliated journal for each society. For ASCO, we have JGO. So compared with the three gynecology cancer societies, European Society and IGCS and ASGO, the Asian Society ASCO was launched late in 2009. Actually, IARC, International Agency for Research on Cancer, regularly reports worldwide cancer statistics regarding estimates of the incidence and mortality in 185 countries. On your right side of this slide, American Cancer Society also publishes yearly statistics about the estimated numbers of new cases and deaths in the US. Asia is huge, as you can see here, and has a lot of countries, of course. Actually, ASCO, the Asian Society of Gynecology and Oncology, currently does not have Central and Middle Asia as a member country yet. If you take a look at the sources and method of GlobalCon 2020 by country here, you might find that many of the Asian countries do not have their own national database. Now, let me briefly introduce JGO. Now you are seeing the journal homepage. Now I'm attending this meeting. Yeah, we just start our meeting today. It ends tomorrow. Wow. It is now held in Gyeongju, Korea. Okay, JGO is open access peer-reviewed journal. We publish every issue every other month. We are affiliated with Asian Society of Gynecology and Oncology, Korean Society, and also we are affiliated with Japanese Society of Gynecology and Oncology. So JGO is supposed to report cancer statistics regularly on these regions. But until now, JGO publications on cancer statistics have not been systematically organized. They were from only a few countries by chance irregularly from time to time. You can see here, we published 2018 one epidemiologic data from China and Korea in 2019, and also southern part of Thailand, we get very local epidemiologic data from there and publish it 2019. And recently, we published another data from Korea, but anyway, it is not a periodic publication at all. Now you are seeing the editorial board member of our journal. We have principal editors, in total 29 from 9 countries here. Not only from Asian country, but also we are having principal editors from Italy, Canada, and also United States. Now we are seeing the journal impact factor trend for the last 10 years. The latest one, it is about 2021 journal impact factor, and it was 4.756. And you are seeing, as you can see here, the trend of impact factor is steadily and slowly rising. Yeah. This is journal rank. For the category of OBGYN journal, we ranked the first quartile. And the oncology journal category, we ranked the second quartile. This is the submission by country of last year. As you can see here, more than 1/3 of our submission is from China, which is followed by Japan, Korea, and Italy, United States, and so on. Again, the Asia is a huge country, but the journal only covers the small part of Asia. So now I am planning about the center statistics from as many Asian countries as possible. So this is my first future plan about that. The first one is establishing national registry, or at least using the same reliable sources and methods. And I hope maybe it is impossible for the first time at the beginning, but in the end, I hope we can publish this periodic publication on cancer statistics every 3 years at least. Of course, it should cover as many countries as possible. Currently, for this plan, I have been contacting key persons or set up national registry for collecting data on regular basis. For example, Korea, Japan, China, Thailand, Indonesia, and Taiwan. For some countries, I have significant progress on this discussion with key persons, but for some country, the progression is not that significant, so I'm so sorry. But anyway, I'm now trying again. So now you can see the big red circle here is Central Asia, also Middle East Asia. So ASCO and JGO have no members from this area. I'm so sorry for that. Maybe that is why I have no data from this area, including the cancer statistics. So maybe that is why I'm now presenting my presentation about this here in Almaty, Kazakhstan. So, okay, briefly, it is about the geographical distribution about the online users for JGO material. The first top 3 is United States, China, and India. Maybe it is because the volume of the population of the country. And this is about JGO promotion activities in the past. From 2016, we are traveling many Asian countries, especially for attending domestic meeting, and we are holding the JGO session there to promote the journal activity and also teach or promote journal activity to the domestic meeting participants. Actually, this is the last slide of mine today. And I know this is a huge plan. Maybe it is not easy to to complete at once, maybe it can only be possible with your help. I really want to discuss more with you in the future. Thank you for listening.
Thank you, Dr. Don, for your presentations. I think we will work in the future, and we will do our own Asian statistics. And of course, thank you very much, and see you in Seoul in
See you.
November. Thank you.
And congratulations on your big event in Almaty, Kazakhstan.
Thank you very much. See you.
Thank you. So it's the time of the discussion, but we are so running out behind the schedule. But is there anyone who really want to bring up some specific topic during this session, Eurasian session? It was so great to learn the differences of the situation of the gynecologic cancer, the statistics and the treatment plans in our Eurasian area. So I was so impressed, and we need to work together. If nobody has the questions or discussion, we really want to thank you for everyone to participate in this session. And before we close, we will have some sign-up ceremony here, right?
Yes, now we will do sign ceremony with our Azerbaijans. And at 1 o'clock, now it's lunch. And at 1 o'clock, we will start next session, our next session here. And at 1 o'clock, round table for palliative care in hall 2.
Right, and another announcement is that the similar format of the Eurasian session will be in Korea. We will have a little bit of a different unfold by country, but looking forward to seeing you there at our Eurasian session during a GCS annual congress. Thank you so much.
Thank you.
And here on the table, you can see our apple. Almaty, it means Alma. Alma, it means apple. And city of apple.
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 Oh,
Alma.
That's why.
Yes, that is why you can try our national apple.
Yeah, yes, yes.
Нет, нет, нет.
Otherwise, people will not understand why. Все понятно. Сейчас где девочка?
Два чуть выше, два чуть ниже сделайте. Во, во. Не, ну. Во.
Нормально?
Yes. Kyrgyzstan would like to make a photo with flag. Oh, sure. Yeah, and Kyrgyzstan and I can give a caution. Yeah, with Putin. Yeah.
Oh, great.
Yes.
Great.
Great. Thank you so much. And did you meet Dr. Nauman? Did you meet Dr. Nauman?
Yes, yes.
Okay,
Professor.
Давайте я тоже встану.
Давай, давай, стопцы. Нашли.
Конечно, нашли. Все есть. Все страны.
Можно за более праздный вопрос?
Прям сразу. Здесь будет обед, кажется.
Давай,
я точно не уверена.
Ты не можешь сказать, куда мне пойти поесть?
Вчера обед был?
Сейчас у нас еще подписание меморандума с турецкой ассоциацией онкологов.
В совместном сотрудничестве. У нас есть представители в Азербайджане, у нас есть представители, как президент, который в Грузии. И мы хотим вместе расти, вместе делать вместе обучать своих резидентов и лечить своих пациентов.
Так, типа как это, да? Для ринса.
Видео, Костя,
Для
снимите, пожалуйста,
ринса
видео.
сделайте.
Ну, если вы что делаете, я уверена.
Все, начинаем, да, Тина? Ты нам говоришь? Подожди. Все?
Так, возьмите друг другу руки. Так, сейчас подожди тоже сюда, пожалуйста.
Сбоку.
Еще. Грузия. А в Азербайджан тоже, пожалуйста.
Да. Шамисан, иди сюда.
С той стороны. С той стороны.
Давай. Где азербайджанский флаг? Ладно, а тут что, убрали, что ли, флаг?
Азербайджанский
поставьте,
да, как-то.
Подожди, флаг забыл.
Это вот этот?
Да.
Спасибо. Спасибо. Райхан.
Райхан,
Забирай меморандум. Один экземпляр тебе.
Через Райхана.
А?
Окей, хорошо, спасибо.
Это тебе? Положите это.
Наша цель ясна. Она не изменилась. Мы расширяем границы науки, чтобы предоставить лекарственные препараты, способные изменить жизнь. В наши дни наука развивается как никогда быстро. Не отставать и держаться на равных – непростая задача. Мы должны продолжать добиваться новых результатов. Оставаться лидером. С помощью нашей коммерческой деятельности, с помощью нашего бренда. Вот из чего мы созданы. Сила научных достижений.
Мы Янсен. Каждое утро мы просыпаемся для того, чтобы сделать возможным то, что еще вчера казалось невероятным. Мы прокладываем путь туда, куда другие боятся смотреть. Изучаем и воссоздаем сам код жизни, чтобы лечить, помогать, исцелять. Мы открываем двери для сотрудничества, а умы и сердца для пациентов, чтобы наши успехи в лабораториях спасали жизни. Мы создаем инновации в лекарственной терапии и делаем их доступными для всего мира. Мы Янсен, фармацевтические компании Джонсон & Джонсон. Это наша жизнь и мечта, в которую мы верим. Мы будем использовать науку для борьбы с заболеваниями, изобретать, как помочь тем, кто нуждается в помощи, исцелять безнадежность человеческим теплом до тех пор, пока самые тяжелые заболевания не останутся лишь на страницах истории. Янсен. Создаем будущее, где заболевания останутся в прошлом.
It is the future that calls us, our history that forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift: life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science, from despair to hope. In 2021, we come together to celebrate where we have been, what we're doing, and where we'll go next. To celebrate 125 years. To celebrate all of us. To celebrate the future. We come together to celebrate life.
We are here together to celebrate life.
Каждые 2 секунды у кого-то в мире диагностируется рак. Это не просто статистика, это близкие нам люди. Поэтому нет ничего более срочного или более личного, чем наша цель – найти способы излечения от этого смертельного заболевания. Но мы знаем, это чересчур грандиозная цель, чтобы справиться в одиночку. Мы сотрудничаем с научным сообществом, чтобы открыть новые методы лечения, используя силу реальных доказательств для более точного действия наших препаратов. Сотрудничаем с группами защиты прав пациентов для поддержки и расширения прав и возможностей людей, которые живут и борются с раком. Взаимодействуем с организациями здравоохранения для предоставления доступа к нашим лекарствам тем, кто в них нуждается. Вместе мы достигли значительного прогресса, но наша работа далека от завершения. Рак забирает миллионы жизней каждый год. Чтобы превратить истории потерь в истории надежд, мы все должны объединить свои усилия. Чтобы найти способ победить рак, мы все должны объединиться.
Караганда. Индустриальный центр и магистральный узел железнодорожных и воздушных путей. По своему экономическому и научному потенциалу она по праву занимает одно из ведущих мест в республике. Именно здесь было создано первое в Казахстане предприятие, производящее современные, высокоэффективные биотехнологические препараты. Карагандинский фармацевтический комплекс. В создании завода было инвестировано более $100 миллионов. Мы первое предприятие в Казахстане, производящее препараты в асептических условиях, соответствующие международному стандарту надлежащей производственной практики.
В Казахстане были созданы благоприятные условия для привлечения инвестиций в отечественную фармотрасль, и в результате чего и было создано наше предприятие.
Карагандинский фармацевтический комплекс. Мы осуществляем трансфер технологии производства биотехнологических лекарственных препаратов для лечения таких социально значимых заболеваний, как онкология, гемофилия, ревматоидный артрит, сахарный диабет и других редких болезней, которые ранее здесь не производились. Впервые в Казахстане внедрена технология производства препаратов в преднаполненных шприцах.
Все наши производственные цеха спроектированы и построены в соответствии с международными стандартами надлежащей производственной практики. Цех оснащен современным европейским оборудованием, позволяющим производить препараты высокого качества.
В 2015 году у нас основана испытательная лаборатория отдела контроля качества. В нее входят физико-химическая лаборатория, микробиологическая лаборатория, и единственная в республике биохимическая лаборатория, выполняющая анализы биотехнологических препаратов.
Мы производим биотехнологические инъекционные лекарственные средства, требующие особых условий при хранении, производстве, транспортировке и контроле качества. В связи с этим нами выстроена фармацевтическая система качества на требуемом уровне для обеспечения населения качественными, безопасными и эффективными лекарствами.
Наш современный фармацевтический склад оснащен холодильными камерами для хранения лекарственных препаратов со специальным температурным режимом и морозильными камерами для хранения активных фармацевтических субстанций и вакцин. Датчики контроля взаимодействуют с центральной диспетчерской службой. Это позволяет осуществлять круглосуточный контроль температурного режима, мгновенно реагируя на любые изменения. Транспортировка наших лекарственных средств осуществляется валидированными авторефрижераторами. Мониторинг безопасности препаратов ведется и после его доставки.
Процессы производства поддерживаются инженерными системами мирового уровня. Системы электроснабжения, теплоснабжения, водоподготовки и воздухотехники обеспечивают безаварийную работу предприятия.
В нашей компании работают высококвалифицированные специалисты. Для повышения уровня профессиональной подготовки сотрудников на предприятии реализуется четко организованный план по развитию и обучению. Мы взаимодействуем с крупнейшими медицинскими вузами страны для подготовки молодых кадров.
Миссия нашей компании – обеспечение населения нашей страны безопасными, эффективными и доступными лекарствами.
Наша приоритетная задача – это сохранить и приумножить здоровье нации, создавать рабочие места и быть активным участником развития своей страны. Быть лучшими не только в Казахстане, но и за его пределами.
penumbra and greater dose optimization than traditional pencil beam scanning systems by shaping or blocking any spot at any depth, while eliminating the need for manual apertures and adjustments.
We could talk about our company using key facts and figures. We can tell you that today we're around 5,000 people worldwide, with 4 production and 4 research and development sites. And that we sell our medicines in over 100 countries. We could also tell you that our annual turnover is over 3 billion euros. And that last year, we dedicated more than 445 million euros to research and development for new and innovative treatments. While these are all important and illustrate how strong we are, the quality of our research, the efficacy of our treatments, and our global footprint, they don't capture what's really important to us. It's patients who inspire us to get up every morning. Patients living with cancer, rare diseases, and neurological disorders. It's Ronnie, Janice, Diana, Nadine, Misha, Yugan, and Steve. Working in partnership with the healthcare community, we aim to support them and their families throughout their entire journey. That's what's really important to us. Improving patients' lives. We are relentless about making a difference. At Ipsen, we focus together for patients and society.
Hello, dear users. In this video, you will learn about the CAS-CS mobile application. Next, we will tell you how to use this application and what features it provides. The application is available for download in the App Store and Google Play Market. To use the application, you need to complete the registration procedure. In the window that opens, you need to enter your registration data, such as email address, mobile phone, last name and first name, city, organization and position. For security purposes, you must create your own unique password containing at least 9 characters. After registering, you will be taken to the main page of the application, which consists of the following sections: upcoming conferences, past conferences, and the other resources section. In order to take part in the upcoming conference, you need to click on the banner you are interested in, and in the window that opens, confirm your participation by clicking the Participate button. If you closed the registration offer and later decided to join the conference, then when you click on the conference banner again, you need to click on the button with a heart in the upper right corner of the screen. By going to the conference you are interested in, you can see the list of speakers and event organizers, as well as find out of the number of participants. In the speakers section, you can find out date and time of the speech of the specialist you are interested in. You can get acquainted with the conference program when choosing the day of the conference and specific hall. Also, by clicking on the video camera icon, you can go to the online broadcast of the selected hall. When you return to the main page, at the bottom of the screen you will see a set of icons which we will discuss in more detail. In the icon with hearts, you will find a list of conferences in which you are already participating. After clicking on the conference window, you will see a section with a personal QR code by which you can attend the conference in person. In the icon with doctor, you can find the necessary specialist, information about him, and contact him in a way convenient for you, via instant messengers, social networks, email, or by phone number. In the icon with document, there is a current news feed. By clicking on the profile icon, you will enter your personal account, where you can add or edit information about yourself, which will be displayed when searching for your profile in the specialist section. Here you can edit profile photos, links to social networks and instant messengers, as well as block access to them. In the profile section, you will be able to change the language and the ability to delete your account. CAS-CS application version is updated automatically. Turn on the auto-update feature in your mobile phone settings. We hope that this information was useful for you and the experience of using our application will be simple and convenient for you. Thank you for your attention.
Наша цель ясна. Она не изменилась. Мы расширяем границы науки, чтобы предоставить лекарственные препараты, способные изменить жизнь. В наши дни наука развивается как никогда быстро. Не отставать и держаться на равных – непростая задача. Мы должны продолжать добиваться новых результатов. Оставаться лидером. С помощью нашей коммерческой деятельности, с помощью нашего бренда. Вот из чего мы созданы. Сила научных достижений.
Мы Янсен. Каждое утро мы просыпаемся для того, чтобы сделать возможным то, что еще вчера казалось невероятным. Мы прокладываем путь туда, куда другие боятся смотреть. Изучаем и воссоздаем сам код жизни, чтобы лечить, помогать, исцелять. Мы открываем двери для сотрудничества, а умы и сердца для пациентов, чтобы наши успехи в лабораториях спасали жизни. Мы создаем инновации в лекарственной терапии и делаем их доступными для всего мира. Мы Янсен, фармацевтические компании Johnson & Johnson. Это наша жизнь и мечта, в которую мы верим. Мы будем использовать науку для борьбы с заболеваниями, изобретать, как помочь тем, кто нуждается в помощи, исцелять безнадежность человеческим теплом до тех пор, пока самые тяжелые заболевания не останутся лишь на страницах истории. Янсен. Создаем будущее, где заболевания останутся в прошлом.
It is the future that calls us, our history that forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift: life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science, from despair to hope. In 2021, we come together to celebrate where we have been, what we're doing, and where we'll go next. To celebrate 125 years. To celebrate all of us. To celebrate the future. We come together to celebrate life.
We are here together to celebrate life.
Каждые 2 секунды у кого-то в мире диагностируется рак. Это не просто статистика, это близкие нам люди. Поэтому нет ничего более срочного или более личного, чем наша цель – найти способы излечения от этого смертельного заболевания. Но мы знаем, это чересчур грандиозная цель, чтобы справиться в одиночку. Мы сотрудничаем с научным сообществом, чтобы открыть новые методы лечения, используя силу реальных доказательств для более точного действия наших препаратов. Сотрудничаем с группами защиты прав пациентов для поддержки и расширения прав и возможностей людей, которые живут и борются с раком. Взаимодействуем с организациями здравоохранения для предоставления доступа к нашим лекарствам тем, кто в них нуждается. Вместе мы достигли значительного прогресса, но наша работа далека от завершения. Рак забирает миллионы жизней каждый год. Чтобы превратить истории потерь в истории надежд, мы все должны объединить свои усилия. Чтобы найти способ победить рак, мы все должны объединиться.
Караганда. Индустриальный центр и магистральный узел железнодорожных и воздушных путей. По своему экономическому и научному потенциалу она по праву занимает одно из ведущих мест в республике. Именно здесь было создано первое в Казахстане предприятие, производящее современные, высокоэффективные биотехнологические препараты. Карагандинский фармацевтический комплекс. В создании завода было инвестировано более $100 миллионов. Мы первое предприятие в Казахстане, производящее препараты в асептических условиях, соответствующие международному стандарту надлежащей производственной практики.
В Казахстане были созданы благоприятные условия для привлечения инвестиций в отечественную фармотрасль, и в результате чего и было создано наше предприятие.
Карагандинский фармацевтический комплекс. Мы осуществляем трансфер технологии производства биотехнологических лекарственных препаратов для лечения таких социально значимых заболеваний, как онкология, гемофилия, ревматоидный артрит, сахарный диабет и других редких болезней, которые ранее здесь не производились. Впервые в Казахстане внедрена технология производства препаратов в преднаполненных шприцах.
Все наши производственные цеха спроектированы и построены в соответствии с международными стандартами надлежащей производственной практики. Цех оснащен современным европейским оборудованием, позволяющим производить препараты высокого качества.
В 2015 году у нас основана испытательная лаборатория отдела контроля качества. В нее входят физико-химическая лаборатория, микробиологическая лаборатория, и единственная в республике биохимическая лаборатория, выполняющая анализы биотехнологических препаратов.
Мы производим биотехнологические инъекционные лекарственные средства, требующие особых условий при хранении, производстве, транспортировке и контроле качества. В связи с этим нами выстроена фармацевтическая система качества на требуемом уровне для обеспечения населения качественными, безопасными и эффективными лекарствами.
Наш современный фармацевтический склад оснащен холодильными камерами для хранения лекарственных препаратов со специальным температурным режимом и морозильными камерами для хранения активных фармацевтических субстанций и вакцин. Датчики контроля взаимодействуют с центральной диспетчерской службой. Это позволяет осуществлять круглосуточный контроль температурного режима, мгновенно реагируя на любые изменения. Транспортировка наших лекарственных средств осуществляется валидированными авторефрижераторами. Мониторинг безопасности препаратов ведется и после его доставки.
Процессы производства поддерживаются инженерными системами мирового уровня. Системы электроснабжения, теплоснабжения, водоподготовки и воздухотехники обеспечивают безаварийную работу предприятия.
В нашей компании работают высококвалифицированные специалисты. Для повышения уровня профессиональной подготовки сотрудников на предприятии реализуется четко организованный план по развитию и обучению. Мы взаимодействуем с крупнейшими медицинскими вузами страны для подготовки молодых кадров.
Миссия нашей компании – обеспечение населения нашей страны безопасными, эффективными и доступными лекарствами.
Наша приоритетная задача – это сохранить и приумножить здоровье нации, создавать рабочие места и быть активным участником развития своей страны. Быть лучшими не только в Казахстане, но и за его пределами.
penumbra and greater dose optimization than traditional pencil beam scanning systems by shaping or blocking any spot at any depth, while eliminating the need for manual apertures and adjustments.
Here with you again today. Yesterday it was wonderful to speak with you and wonderful to be back today as well. So today I'm going to share with you advances and updates in rare ovarian tumors. This is an area that I'm very interested in and have spent the bulk of my research work in my career working on rare ovarian tumors. So I know that horses are quite popular here, but the joke in rare tumors is that we don't talk about horses, we talk about zebras when we hear hoofbeats because everything is rare. So we'll talk about the zebras of ovarian tumors today. We'll talk about trials and progress, surgery, and other therapy. So the world has changed with regard to rare tumors. Prior to 2005, all rare tumors were included in phase 2 and 3 trials. There were no trials that pulled out rare tumors specifically to study. And in fact, in 2005, the first rare tumor working group was established within the Gynecologic Oncology Group, which is the GOG, it's the cooperative group where most of the trials historically have been done in the United States. In 2010, this approach was endorsed by the GCIG, so it was taken internationally, and the next year became a part of the NCI Clinical Trials Planning Meeting. So then, this concept of studying rare tumors specifically is really a relatively new idea within GYN oncology. In 2011, that working group became a full NRG Rare Tumor Committee, and it remains to date like that. We do hypothesis-driven research in rare tumors, looking at novel agents, looking at using innovative statistical design because different rules apply when you have just a handful of patients. We try and incorporate translational research components into these trials because every patient is precious and we have to gain as much information out of these trials as we possibly can. In 2022, we put together a preclinical workshop where basically we brought together laboratory researchers, clinical trialists, basically everybody who had an interest in studying rare tumors, also brought in the pharmaceutical companies who shared with us actually very freely their pipeline drugs. So I think we're really on a fast track to study rare tumors. What I'll share with you today centers around rare ovarian tumors, but I always try and think about these things in a very organized fashion because they're different. And it's easy to think of a rare tumor as all rare tumors are the same, but they're not. They're very different. And so I actually think that unless you really think about these tumors a lot, it's helpful to just keep like this talk or a chapter as a resource and look up specifically each patient to make sure that you get the most up-to-date information correct as you treat your patients. So when I think about ovarian cancer, I think about three major categories, 3 major buckets: epithelial tumors, germ cell tumors, and sex cord stromal tumors. We'll focus first on epithelial tumors, which of course are derived from the epithelium of the ovary, also of the tube, also of the peritoneum. There are multiple histologic subtypes of epithelial ovarian cancers, but the one that we typically talk about when we talk about ovarian cancer is high-grade serous. So today what we'll talk about is not high-grade serous. We're going to talk about everything except high-grade serous. We'll talk about low-grade serous, we'll talk about mucinous, and we'll talk about clear cell, all within that epithelial subgroup. So let's start with low-grade serous ovarian cancer. So these tumors represent about 5% of all epithelial cancers. They're not high-grade serous carcinomas. They're very different. They exhibit typically mild to moderate atypia with a mitotic index of less than or equal to 12 per 10 high-power fields. These can arise by themselves, de novo, or from low malignant potential or borderline tumors when they recur. And these low-grade tumors, they're diagnosed in younger women. They have better survival, as you can see on the Kaplan-Meier curve below. The low grade is the solid line that's much higher than the higher grade. 70% of advanced stage patients do relapse, however, so it is really important to treat these patients specifically for what they have. And they act differently. So conventional chemotherapy that we use to treat high-grade serous ovarian carcinoma is not effective for low-grade serous. Paclitaxel carboplatin, it simply doesn't work as well as it does for high-grade serous. So we've looked at other options. So the way things look under the microscope is different, and in fact, the way things look as in terms of molecular profiling is also different. These tumors tend to overexpress KRAS, BRAF, and NRAS, and because of that, they're very susceptible to MEK inhibitors. I'll show you some of that data. In addition, these tumors highly overexpress estrogen and progesterone receptors, and so hormonal therapy can be very active. In fact, we are able to achieve about 60% stable disease with long-term hormonal therapy in these patients. And it turns out that about 55% of patients have actionable mutations. We just published on this earlier this year. So the most important, I think, clinical trial to focus on right now that's underway is GY019. So this is a randomized phase 3 2-arm trial of paclitaxel and carboplatin maintenance letrozole. In other words, as you can see, the patient gets carboplatin and paclitaxel for 6 cycles and then continues on letrozole until they progress. So that's the more sort of standard arm. The experimental arm is no chemotherapy, just letrozole. And this is really a hugely important trial because this could eliminate chemotherapy completely from treating patients with low-grade serous carcinomas. And that's a big deal for a patient. Instead of losing her hair, instead of having neuropathy, she could just potentially go on letrozole. So this trial is about halfway accrued, and stay tuned. We will have the interim analysis at the July NRG meeting. So we'll have some information about this very soon. There are some other trials that we've looked at in the recurrent setting. So for recurrent low-grade serous carcinomas, the very first trial that showed effect of a MEK inhibitor was this one with selumetinib. This trial showed a 15% response rate, which in and of itself is not that great. However, there was an additional 65% of patients who had stable disease, so long-term stable disease on this drug for a progression-free survival of almost a year and an overall survival, median overall survival that was not reached. Interestingly, response did not correlate with a KRAS mutation. This, however, paved the way for the MILO trial, also called ENGOT-OV11. This was a different MEK inhibitor which is binimetinib, which was compared with physician's choice chemotherapy. And this is really interesting. You can see on the waterfall plot the extent of response, and there were a lot of responses. So what we saw in this trial was that the progression-free survival was 10.4 months in binimetinib arm compared to 11.5 months in the chemotherapy arm, which, as you can see, is not statistically different. So, but why is it not statistically different? It actually doesn't mean that the MEK inhibitor didn't work. What it means is that the chemotherapy arm worked much better than anticipated. So on the right, you can see that there were 24 patients in each arm who had a complete or partial response to both binimetinib and chemotherapy. So this did demonstrate activity. And interestingly, there was a post hoc analysis that was done that separated out what happened specifically in patients who had that KRAS mutation. In other words, a patient who has a KRAS mutation should respond well to a MEK inhibitor, and in fact, that's what the investigators saw, that the efficacy may be related to the KRAS status, and that's the change you see in the curve. So it's an interesting situation. This trial, at face value, would show no difference, right? So we wouldn't pursue binimetinib, but actually it does have activity. At the same time the Milo trial was going on, GOG 281 was also ongoing. And this trial did show a statistical improvement compared with chemo or hormonal therapy. In fact, the MEK inhibitor, the trametinib arm, was substantially improved over both chemotherapy and letrozole for a hazard ratio of 0.48. And this led Dr. Gershenson to conclude in his paper, trametinib should be considered a new standard of care option for progressive or relapsed low-grade serous carcinoma. There are some active trials that are ongoing, the FRAME and the RAMP trial, and basically these are looking at these combination RAF-MEK inhibitors with a FAK inhibitor, and the preliminary data is really, really interesting on this. So stay tuned looking for the RAMP 201 and the FRAME trial. Hopefully they should be published fairly soon. I always think it's helpful to see like how does this actually work, and this is a patient of mine. So she's a 55-year-old female with a stage 3C low-grade serous carcinoma who recurred after surgery and paclitaxel and carboplatin. She progressed after letrozole, and until we had these trials with MEK inhibitors, we would have just gone through chemo after chemo that likely would not have worked. But here you can see she was very symptomatic. She came in with a lot of ascites. She was having to have paracentesis every other week. And after she started on a MEK inhibitor, she was dry. So no longer any need for paracentesis. And this is an oral drug, so it really didn't affect her quality of life much at all. So she is now 2 years, not quite 2 years, year and a half, no evidence of disease on a MEK inhibitor. Okay. So let's go back. We're done with low-grade serous carcinomas. Let's still stay in the epithelial grouping, but we're going to look at mucinous carcinomas. Now, we don't have as much information here. So primary mucinous ovarian carcinoma is pretty rare, primarily because it is a rare ovarian tumor, but it's also confused with GI tumors, with breast cancers, and with pancreatic cancers. So it's challenging for the pathologist to make sure that what they think is a primary mucinous ovarian cancer truly is a primary ovarian cancer. And as the treating physician, we need to make sure that we do an exhaustive search to make sure that the patient doesn't have a colon cancer or a gastric cancer. So every patient who has an ovarian mass where the pathologist thinks that it may be a primary mucinous ovarian cancer, they should get an endoscopy and a colonoscopy to ensure that it's not actually a GI primary. To further complicate this diagnosis, these are often very, very large tumors, and you can have areas of low malignant potential or borderline tumors confluent with cancer. And so the pathologist has a very hard time giving you an answer on frozen section. The pathologist really has to completely section the tumor, and sometimes that takes a while. There are actually two types of invasive cancer that are mucinous ovarian cancers, and those are expansile and infiltrative subtypes. The infiltrative subtype is much worse. Interestingly, these tumors also have a specific molecular profile and tend to overexpress KRAS. About 18% are also positive for HER2, and these are not typically associated with BRCA mutations. Now, the surgical approach is to remove the adnexa without rupture. We do not have to include nodes in our staging procedure for these patients. We do want to perform an omentectomy, peritoneal biopsies, and biopsy any suspicious areas, but essentially we've showed that there's a 0% risk of lymph node involvement, and that whether you take out nodes or not at the time of staging, it does not affect outcomes. We do recommend an appendectomy with these tumors, and fertility-sparing surgery is an option. Please keep in mind that fertility-sparing surgery does not refer to an ovarian cystectomy. It refers to the removal of the entire involved adnexa. In addition, staging is included in any fertility-sparing surgery. You can simply preserve the normal-appearing uterus and contralateral ovary. What we see is that patients with primary mucinous ovarian cancers do worse when they receive taxanes and platinum agents compared with other subtypes. And you can see, based on Will Winter's detailing, that the red line is mucinous. It does substantially worse. And so we looked for other options. We looked to see if we could use a colon regimen for better outcomes in these tumors. But unfortunately, the answer was that we couldn't get an answer. Unfortunately, this trial, which was GOG 281, accrued quite slowly, and the majority of the patients who were enrolled on the trial did not have a primary ovarian cancer. Most were actually colon, pancreas, or breast. And so this trial closed, and I think the most important lesson that we learned from this is that central pathology review with rare tumors is essential. We'll talk briefly about clear cell carcinomas, also epithelial cancers. Now, clear cell carcinomas look different, beautiful under the microscope. These tumors tend to occur earlier than patients with high-grade serous carcinomas in the 40s and 50s, and they are associated with endometriosis-associated cancers. These patients often have an early stage, and in fact, early stage clear cell carcinomas tend to have a good prognosis with treatment. So much so that you can consider fertility-sparing surgery if the tumor appears confined to an ovary. However, these are all high-grade tumors, so even stage 1A clear cell carcinomas require treatment with platinum and a taxane. This yields an overall survival of over 95% in these patients. However, that's very different in late-stage patients. So late-stage patients tend to have platinum-resistant tumors, and these patients do not do well. PIK3CA mutations are quite common, as are ARID1A mutations, and that has informed our clinical trial work. Unfortunately, our clinical trial work has been very disappointing, and I'm not going to go through the details of each of these trials, but suffice it to say that you can see with 0 responses in multiple trials, many of our targeted therapies have not been useful. There are a couple of possibilities, however. The ANNIE trial was recently positive, and so this is enlotinib, which is an oral tyrosine kinase inhibitor, and niraparib, which is a PARP inhibitor. This gave a 50% response rate a 9.2-month progression-free survival and a 15-month overall survival, which is better than anything else we've seen. The other bright spot is immunotherapy, and this is a patient of mine who, she is over 5 years out on nivolumab now. So immunotherapy may play a big role in clear cell carcinomas of the ovary. There are currently 18 ongoing trials, so hopefully we'll have some more information about clear cell carcinomas of the ovary in the future. One of the things that I think is most exciting, and I am biased here because this is my trial, but the Bouquet trial looks at a different way to study rare tumors. So instead of what you've seen before where we pick a drug and that's the option based on the histology, the Bouquet trial is a platform study. So we profile any patient with platinum-resistant rare epithelial ovarian cancer. So basically, anybody who doesn't have a high-grade serous ovarian cancer, we profile and then place them on the arm that corresponds to their mutational profile. And this is what we call a plug-and-play trial. In other words, when one arm fills, we take that arm out and put a new arm in. So hopefully with this structure, we can continue to rapidly study a number of different drug combinations in rare tumors. And the first 2 arms we're just submitting for presentation now. So fingers crossed that'll be accepted. The next thing, we'll switch now to germ cell tumors. So remember, 3 big categories: epithelial, germ cell, and sex-scored stromal. Now we'll talk about germ cell tumors. And here what we're talking about is dysgerminomas, yolk sac tumors, and immature teratomas. These tend to occur in young girls and adolescents, and therefore fertility preservation is extremely important. Typically, we remove 1 tube and ovary and perform staging in these patients, and again, very important, this does not refer to a cystectomy only. There is no data about ovarian cystectomy. This refers to removing the entire abnormal tube and ovary and performing a staging, which for adults with malignant ovarian germ cell tumors does include a lymphadenectomy. This has been omitted in children with germ cell tumors, but we do still include it in adults. There have been a lot of patients studied and reported on now who have conceived and delivered healthy babies after malignant ovarian germ cell tumor treatment with chemotherapy. To drill down a little bit on the different types of germ cell tumors, so dysgerminoma is the most common. These are chemosensitive. Please do not bivalve the other ovary if it looks normal. There's really no need to. The LDH is the best marker for this type of tumor. And the majority are stage 1, so fertility-sparing surgery is definitely reasonable. As long as the patient is fully staged, if they are stage 1A or 1B, they do not need chemotherapy, and this yields a 100% overall survival. Now, they still need to be followed. 15% will recur, but those patients are cured with BEP chemotherapy, and that means that you can spare 85% of these early-stage patients exposure to chemotherapy. Patients who have dysgerminomas that are stage 1B through 3 and are incompletely resected, or if they're stage 4, they require 4 cycles of BEP, and even then, typically, they will be cured. Patients who have completely resected disease that's more advanced, so 1 stage through 3, those patients need 3 cycles of BEP. And all in all, as long as we're able to completely resect these patients, BEP yields a 98% cure rate. Now, this is different. Yolk sac tumors, also called endodermal sinus tumors, these are the patients where the alpha-fetoprotein is elevated, and you can see from the Kaplan-Meier curve that this is different from other germ cell tumors. So if your AFP is elevated, if your pathologist is able to identify endodermal sinus tumors, these patients have a worse prognosis, and they all require BEP unless they are 1A completely staged with a normal AFP. Immature teratomas, these are derived from all 3 layers, ecto, meso, and endoderm. The grade relates to the amount of primitive neuroectodermal tissue. Often there will be a benign dermoid in the other ovary, and so even though the other ovary may look abnormal, typically it does not need to be removed. Simply the dermoid in that ovary can be shelled out. The amount of neuroectodermal tissue does correlate with prognosis and determine therapy. These patients do usually respond to treatment, and if they recur, we need to be aware that it's not always immature teratoma. These patients can recur with benign teratoma or gliosis. Once in a while, you'll see a patient who is seen by a gynecologist that does not do staging, and so they will be an incompletely staged non-dysgerminomatous malignant ovarian germ cell tumor. So what do you do when you see this patient in your office? Well, rather than having to necessarily take the patient back, we have guidelines on this where we can obtain tumor markers and we can obtain imaging. And you can see the recommendations here. It varies a little bit based on the guidelines that you follow. The NCCN states that observation is acceptable for all stage 1, grade 1 immature teratoma as long as the markers and imaging are normal. ESMO states that anybody who has higher risk disease, so stage 1A, grade 2 to 3, or stage 1B, 1C, not properly staged non-dysgerminomas, do require chemotherapy. Anybody else requires chemo, even if it's confined to the ovary. All of our work now, and this is just a summary slide because honestly, I would look at this and I would keep this lecture, and if you see one of these patients in your office, refer back to these slides because it summarizes everything. And it's very difficult to go to the literature and look all of this up and try and synthesize it. I've done that work for you. So just keep this in your office. The majority of the work that we're doing now is in scaling back our treatment in these patients, trying to identify who's going to be cured even without BEP chemotherapy. So there's some ongoing trials looking at that, so stay tuned for that. The third big bucket of tumors we'll look at is sex cord stromal tumors. These include granulosa cell, both adult and juvenile, and Sertoli Leydig cell tumors. Adult granulosa cell tumors are 95% unilateral. They can recur many years after initial treatment. They tend to be indolent, so that is, they tend to sit around and not do much most of the time. So sometimes people will confuse those with being benign, but they're not. They are definitely still cancer. They're characterized by a very specific FOXL2 point mutation. And it should be noted that juvenile granulosa cell tumors are different. It doesn't just refer to the age at which a patient is diagnosed. These tumors can be more aggressive. Sertoli Leydig cell tumors are different. And again, I would hang on to the slide because the detail is in determining who to treat is different than patients with any other histology. So here you want to treat anyone who has a Sertoli Leydig cell tumor who has stage 1C or greater, who has a poorly differentiated tumor of any stage, including stage 1A, and who has heterologous elements of any stage, including stage 1A, because those characteristics give patients a much worse prognosis. One additional note, Dicer1 mutations, are present in 70% of these tumors, and they correlate with an infantile syndrome called pleural pulmonary blastoma syndrome. The reason this is so important is because if you can detect PPB in an infant, and you can resect the pleural pulmonary blastoma lung mass, and those patients have like over a 90% survival rate. Whereas if you miss it, because you're not going to be looking for a lung tumor in a baby, by the time they're diagnosed with a lung tumor and it's widespread, that's almost always fatal. So when you see a patient with Sertoli Leydig cell tumor, test them for Dicer1. If the Dicer1 is positive, their whole family needs to be screened, and any baby has to be surveilled for PPB. So who would think that it would go along with a lung disease in baby, but it does. There are a couple of highlights to take home from everything we've learned about sex cord stromal tumors, and Dr. Naumann's going to cover some of this in his tumor board. But regarding surgery, fertility-sparing surgery is important in these patients. You can omit routine lymphadenectomy from surgical staging. We have a lot of new information that's about to be published on upfront chemotherapy. So GOG 264 was what I've worked on the majority of my adult life, which is BEP versus paclitaxel and carboplatin in upfront setting. And basically, we saw no difference in the arms, but the paclitaxel and carboplatin was much better tolerated. So this is the standard of care. For recurrent disease, we have a lot of different options, and those include BEP, so bleomycin, etoposide, and cisplatin, or bevacizumab with or without weekly paclitaxel, or hormonal therapy. We're looking at Notch inhibitors and immunotherapy and some other options currently. So, to summarize the whole talk, low-grade serous carcinomas, think KRAS mutations, think MEK inhibitors, and specifically trametinib, think letrozole, and look out for GY019, soon to result. Clear cell carcinomas, think about enlotinib and niraparib that may show promise, and potentially immunotherapy. Mucinous ovarian carcinomas, make sure you exclude a colon primary. You do not need to do nodes. Think about capecitabine or oxaliplatin plus or minus bevacizumab, a colon regimen. For germ cell tumors, always remember fertility-sparing surgery. BEP is what you use if you need to, but again, we try to minimize treatment in these patients. And for sex cord stromal tumors, think about fertility-sparing surgery, eliminate lymph nodes from your staging. Paclitaxel carboplatin is frontline in these patients, and again, there are many options for recurrent disease. So thank you very much. I appreciate your attention. This is my home family and my work family. Thank you.
Jubilee, thank you so much. It was really wonderful overview. So it was fantastic. So maybe you have you should have some questions. I mean, it was so interesting that we're waiting for questions.
Dr. Jubilee Brown, thank you for your report, for your great report. I have one question regarding germ cell tumors. What about if we replace in first line of chemo BEP to paclitaxel or carboplatin? Is there any big mistakes if we start from paclitaxel and carboplatinum regimen?
I'm so glad you asked that. Thank you. Yes, that is a big mistake. So, and this is something that I think almost everybody really, I don't want to say confuses, but wants to do, right? Because we're used to using paclitaxel and carboplatin. And now we've just shown that we can do that in stromal tumors, right? Not germ cell tumors. BEP is curative in these patients. And you know, we reach almost 100% cure rate in patients with germ cell tumors, but that's only because we use BEP. I don't think anyone would want to change BEP to paclitaxel carboplatin because we would only potentially hurt patients, right? Because we know that BEP is curative. And so, yes, it's a lot to go through, but if we withhold BEP from patients and instead give them something that we don't know works, we don't know that we can salvage them with BEP later. So take-home message is germ cell tumor, BEP. Anything else, Taxol carbo.
Okay, thank you.
Thank
but
you.
Sometimes we started from BEP for granulosa cell tumors and have to go to paclitaxel carboplatin regimen due to high toxicity of first regimen.
Yes, and so to your point, stromal tumors, so granulosa cell tumors are very different from germ cell tumors. And so granulosa cell tumors, the standard of care is now paclitaxel and carboplatin chemotherapy. It does not need to be BEP any longer. And that's great news because you're right, BEP is much more toxic than paclitaxel carboplatin. That's in fact why paclitaxel carboplatin is the standard of care now for granulosa cell tumor treatment.
Thank you so much.
Thank you.
questions? I guess your overview was so full that nobody has no more questions. So let's move to next speaker. So Dr. Wendell Neumann, New Advanced in the Management of Gestational Trophoblastic Disease.
Thank you. Sorry. You notice I was in both her work family and her home family picture, so fortunately. Can you get my slides on the monitor? There. So I was asked to talk about gestational trophoblastic disease. Much of what I'm going to tell you is coming from this manuscript. I often have to refer back to it. This is Dr. Brown was the first author. And this was in conjunction with Michael Skeckel, who was at Charing Cross, and Skip Schenck, who was at Northwestern, at two big trophoblastic centers. So this was released in 2016, but it's still pretty relevant with the exception of some of the new data I'm going to give you. So as we know a lot about the gestational trophoblastic spectrum. Most of these are molar pregnancies, which will resolve without treatment. And they range from invasive moles, choriocarcinoma, and placental site tumors, which are the most aggressive. Lymphatic metastasis is rare. And we know the initial treatment for these is surgical with a DNC. I think we have to be really careful when the uterus is very large, and these patients can get some transient pulmonary insufficiency when these are evacuated. Fortunately, now with the early use of ultrasound in pregnancy, we don't see the very large patients with uterus full of tumor anymore. So after DNC, we want to follow the HCG levels until they have 3 consecutive weekly normal levels. That usually occurs within 8 weeks. Now, about 20% of patients will have elevated levels for more than 14 to 16 weeks. We need to monitor the complete moles for 6 months because they do have a fair amount of malignant potential. For partial moles, we used to follow those for 6 months, but we now know that the risk, if you have HCG normalization, the risk of recurrence for a partial mole is very low, and so most centers require only 2 normal values before going back to no surveillance. Obviously, we follow these patients with HCG, and we don't want to have these patients become pregnant, so we do recommend contraception. Now, again, with the risk profiles that we see, it probably needs to be about 6 months. IUDs can perforate the enlarged uterus, so usually this is with oral contraception. So again, if you have 2 levels that 3 values over 2 weeks that are rising or plateaued, then that is a criteria for considering treatment. Or if you have a biopsy that shows choriocarcinoma, those patients need to be treated. In the UK, if the beta HCG is more than 20,000 over 4 weeks after evacuation, they consider that a criteria for treatment. Also, if you have hemorrhage that is not caused by retained placental tissue, you need to think about placental site tumors. The HCGs that are produced by trophoblastic disease can be unusual. You need to use a good quality commercial test, and even then they don't pick up all of these isoforms. But I would recommend against using a home pregnancy test. We'll skip that. The FIGO scoring system is sort of helpful in terms of classifying metastatic versus non-metastatic and where the tumor is, but really what we concentrate on is the WHO prognostic scoring system. And this really informs us of both the prognosis and how to treat these patients. And every time you retreat, I would rescore. So the old metastatic, non-metastatic, it's really all about the WHO score. So you can have non-metastatic disease that's very aggressive, or you can have metastatic disease in the lung that's actually a very low WHO score. So typically we score these with the WHO score after the Roman numeral for the FIGO staging. So for example, a stage 2-5 is a WHO score of 5 with metastasis to the lungs. So there are some risk factors that are potentially predictive of who's going to develop malignant disease. Obviously, if your HCG level is very high, over 100,000, very large uterus, large thicoludian cysts, patients who are over 40, and the type of antecedent pregnancy. This is a flow diagram, and this is in the paper, so I'll go over that just a little bit. But obviously, in addition to the history and physical and quantitative HCG, we do want to get imaging. I used to get CT scans on all of my patients, but now we get a pelvic ultrasound and a chest X-ray, reserving CT scans for patients with abnormal chest X-ray. So if they have an abnormal chest X-ray, get a scan. If they have lung disease, then you probably need to do an MR of the brain. Otherwise, they're at low risk for cranial disease. I think the flow sheet has changed just a little bit. So once we do our workup, if the patient has a WHO score of 6 or less, there is new data to suggest that a repeat DNC may be curative, and I'll show you that data. Now, if they're greater than 6, you go to the EMICO regimen, the high-risk regimen. But if they're less than 6 or 6 or less, then you can consider a repeat DNC. And then if you do a repeat DNC, you can follow the HCG titers. And this was a GOG trial. They did these repeat DNCs on 64 patients, and 38% of patients resolved without chemotherapy after a second DNC. So it's probably reasonable to do this to avoid having to give chemotherapy. What's interesting, too, is that they found 4 placental site tumors out of 64 patients that probably would have been missed. And because these don't always produce high levels of HCG, they can be missed in follow-up. Low risk disease regimens. There are really several options. You have the 8-day methotrexate regimen. You have the 5-day methotrexate regimen. Both of these are relatively inconvenient. There is the actinomycin D regimen, which is a pulse regimen. So you get 0.5 milligrams every 14 days. Obviously, the downside of this is you do have a little bit of hair loss, and it is a vesicant, so you have to be really careful when you're giving this with peripheral IVs. For very low-risk patients, you can consider the weekly intermuscular methotrexate at 50 milligrams per meter squared, but only in the very low risk, and I'll show you that data. So that actually comes from the GOG trial that looked at the comparison of weekly methotrexate versus pulse ACT-D. Now, this trial was criticized a little bit because the methotrexate dose was 30 milligrams per meter squared as opposed to 50 milligrams per meter squared, which is sort of a more standard type of dose. And the ACT-D was 1.25 milligrams per meter squared every 2 weeks. So if you had a WHO score of 0 or 1, the methotrexate worked 70% of the time, and the ACT-D worked 80% of the time. And you can see as the WHO score goes up, both of these regimens become less effective. But really, when you get to a WHO score of 5 or 6, your weekly methotrexate is only 13% effective. So again, in low-risk disease, you can consider a hysterectomy if childbearing is complete, but you would still need to consider chemotherapy in these patients. This was a trial looking at a more modern regimen of methotrexate compared to the actinomycin D regimen, the 1.25 milligrams every 14 days. And this trial was originally planned for 384 patients But as you can see on the right, the accrual was very low, and after several years, they had only accrued about 60 patients. And overall, the response rates were similar. The more modern methotrexate regimens had a little bit higher response rate at 88%, and really there was no suggestion of a difference between the 5-day regimen and the 8-day regimen. But the methotrexate had more stomatitis and some ocular toxicity and was certainly less convenient. And particularly when you're given the folate rescue, a lot of centers couldn't do this on the weekend, and so you had to bring them into the hospital. So that was part of the inconvenience. I think a lot of people now use Act-D in the sort of intermediate low-risk patients. So it's very important that you treat 3 past normal. If you don't, the rate of recurrence doubles. Now that is if you use 5 as a cutoff. If you have a more sensitive HCG and your cutoff is 1, you can do 2 past normal, but the cure rates should approach 100% with these treatment regimens. You can have false positive heterophile antibodies. That's an antibody that actually reacts to the antibody where you're using your ELISA. And you can actually filter these out, so you can actually do a quantitative HCG on the urine, and that will filter out the heterophile antibodies. But also be careful, particularly if you have a patient that you treated with Emico, because particularly if they're in their 40s, they can go into ovarian failure and the HCG can go up, their FSH can go up, and occasionally you'll get cross-reaction with your beta HCG, and so you need to be careful that that's not a false positive for your HCG. So again, always rescore, always rescore, always rescore. Every time you treat, rescore. The score will change because some of the scoring is based on the prior treatment. So again, here's just a brief case. A 43-year-old had some bleeding. Her HCG was 90,000 after she delivered 6 months ago. Had a chest X-ray of 4 lung metastases, largest of which measured 4 centimeters. Other imaging is negative. Do you biopsy this mass? No, absolutely not. If you see a mass in the vagina, don't biopsy it. The last case I was involved with that somebody biopsied a vaginal mass like this, they lost 100 units of blood. So this lady has a WHO score of 9, so she's at high risk, and she would be treated with the Emico regimen. And it's very important to maintain the dose intensity of this regimen, even if they're neutropenic. So you do need to give them growth factor support and push through even when they're neutropenic. There are some alternatives. I haven't used this regimen, the FAEV regimen, which is, has a complete remission rate that's fairly significant. There has been a randomized trial between this and Emico, where you had about 40 patients in each arm. There's really no difference between the arms or the toxicities, but the outcome was no different. The relapse rate was no difference, and the myelosuppression was a little higher in the FAEV arm as opposed to Emico, but they were not treated with GCSF. Again, for vaginal metastasis, avoid the temptation to biopsy this. You can embolize these. We've had to pack patients and, in fact, put them on a ventilator and paralyze them because of bleeding issues. But you can get patients through this without resecting these. Now, fortunately, we don't see a lot of very high-risk disease. This is usually something that I refer to a trophoblastic center. These patients do have a high risk of early mortality. In the Charing Cross experience, it was 7.2%. They were able to reduce that to 0.7% with low-dose EP. Who has got this? High-risk disease, patients with brain mets, patients with large lung mets. These patients can be particularly troublesome when you start treatment. And this is the paper that looked at the EP induction. And again, they showed the very low early mortality with the etoposide and cisplatin at those doses. Again, I haven't had to deal with CNS metastasis very often. But again, these are patients that would probably benefit from induction EP and neurosurgical consultation. We used to use radiation up front. I think some people have advocated using radiation after chemotherapy, particularly with targeted radiation like gamma knife. But again, if I have a patient like this, I'm usually on the phone to one of the experts at a trophoblastic center. There is some salvage therapy. We know that about 25% of patients with high-risk metastatic disease will recur. Surgical resection can be undertaken, or a platinum-based chemotherapy regimens for salvage. Probably the most common regimen we use is EMA-EP, which is a platinum-based regimen, and there's also TETP, which is a platinum-based regimen with paclitaxel, but it's probably unlikely to respond if they failed EMA-EP. Now, obviously, with the nature of trophoblastic disease, there's a lot of interest in immunotherapy. I know at Charing Cross, they started using immunotherapy rather than the high-dose chemotherapy in many of their patients because of the pandemic, because these patients get very, very neutropenic with EMA-CO. So these tumors all express PD-L1, and so they are very good targets for immunotherapy. Probably the most experience is with pembrolizumab. Most of this is case reports because fortunately this is fairly rare. But if you look at a summary of the literature, 72% response rate overall, 50% response rate, high-risk histology. So something to consider in a salvage setting. Again, this is another report of 49 patients. The CR rate was 68%, and 10 of the 11 poor prognosis had a complete response. Now, placental site tumors, fortunately these are rare, but they can be chemo-resistant. They can have lymphatic metastasis, but most often they have lung metastasis. They can secrete placental lactogen and small amounts of beta-HCG, but the beta-HCG may be negative. The histology shows basically intermediate trophoblastic cells with oval nuclei, abundant eosinophilic cytoplasm, and no chorionic villi. There are no syncytio or cytotrophoblastic populations, so that's why you have low HCG levels. Lung mets present in up to 30% of cases of placental site tumors, and 10% more will develop lung mets. They usually, we wind up having to do hysterectomies on these patients because they are chemo-resistant. The time between the initial pregnancy and the development of the placental site tumor is very important. The survival is very good if it's less than 4 years and very poor if it's greater than 4 years. There is some role of surgery in terms of resecting the disease, but you need to, in our experience, remove all of the disease to get a benefit. So patients who had an R0 resection in this series had a 91% PFS versus a 3.3-month PFS if it was incomplete resection. Similar data for overall survival. And these were the types of surgery that were done. Most were hysterectomies. And you can see there were a large proportion of placental site tumors or epithelioid trophoblastic tumors that are very similar to placental site tumors. And these are the survival curves, the PFS and OS. Similar data for the placental site tumors. As you can see, the prognosis is not as good. For high-risk GTN, it's generally recommended that you follow them longer. Some sources recommend up to 2 years. And this is the follow-up for placental site tumors because they don't secrete HCG. You might want to consider a CT scan every 6 months during a follow-up for the first 2 years. I think there's some concern about second malignancies, especially when you have a topside-based regimens. And this was a paper that actually addresses that. I think this was good data to counsel our patients on. What they showed was The single agent methotrexate, the odds ratio of a second malignancy was not increased. With Emico, it did increase with the number of cycles, and it was related to age. That risk was small. It was about 10% in this study overall, but there was a significant increased risk of oral cancer, melanoma, meningioma, and leukemia. Particularly leukemia is troublesome. Again, if you look for people who got 13 or more cycles, the increased risk was about doubled of second malignancies, or if they were less than 19, the increase in the malignancy rate was just over 2 as well. Most patients do have fertility preservation unless they have to have surgery to remove the uterus for resistant focus, particularly the placental site tumors. So anyway, so that's an overview. Again, I'm happy to provide that article. If you would like to contact me, I'll send you a copy of it. But it's a very useful reference, and I actually have to go back and look at it every time I treat somebody with gestational trophoblast disease. Thank you.
Professor Naumann, thank you very much for your presentation.
I'm sorry, one more time?
Again, thank you very much, Professor Naumann, for your presentation. What we're supposed to do if HKGS is dropping, however, we have metastasis in lungs. Did you hear me? Hello? HCG?
I would, if the HCG is dropping without lung metastasis and normal, or with lung metastasis and normal function, I would follow them. Wouldn't you follow them? Now, unless they had choreo, I would probably treat them.
If they have metastatic lung?
If you have known lung metastasis that are getting better?
I would probably treat them. I mean, or ACT.
Yeah, you know, it's a very interesting question. There's a lot of sort of immune response that you get to these. So I guess it depends on how fast the HCG was dropping. But usually, if they have lung metastasis, I would probably treat them before I knew that the HCG was falling. But I guess is the question.
Because in the WHO grid, right? Then they would have some number, right? They would have something that you want to treat.
Yeah, well, lung metastasis doesn't give you a. I mean, you can have lung metastasis that are 0.
Yeah, that's true. It's an interesting question.
So, again, I would do a WHO score on them, and if their WHO score was, and they had, so I'm assuming they had rising titers to begin with, and then had lung metastasis, and it started to go down. Is that the scenario? Yeah, I probably would score them and then treat them appropriately. Yeah.
Good afternoon. Thank you for your interesting presentation. What we're supposed to do when patients came after curettage, however, HCG is lowering, but a very small pace, in a very small pace. After curettage, it has 900 HCG, and next week it is 850 HCG. In other words, after curettage, HCG is very slowly declining. What we have to do under this circumstance?
I think as long as the HCG is going down, that's okay. But obviously that patient's going to be at high risk for failure. So again, I would continue to follow them closely. And sometimes they'll go down slowly and then they'll eventually get better. But again, that may be a place where you want to use a second curettage.
Thank you.
I find that trophoblast disease is always more difficult to treat than you think it is. So.
If there is no more questions, so we'll give the stage to Jubilee again. Please, molecular biomarkers.
Great, thank you. I'm much shorter than Dr. Naumann. To bring that down. Great, so I will chat with you for a few minutes about molecular biomarkers. This is a very broad category, broad topic, but let's talk about the role of molecular testing in gynecologic cancers. We'll talk about the different platforms that are available for testing, and then I think most importantly, incorporate molecular testing into practice. Can I ask, how many people have access to molecular testing, whether it's Foundation or Caris or Tempus or some other type of testing? A few? Some? Well, this is why it's important. And I think, you know, even a few years ago, not many people used molecular profiling. And now it's really become a standard part of how we treat patients in the United States. And I would encourage you to look into this in your centers. There are a number of different tests that can be used and different companies that do this. Some people can even do it in-house. We do not, we outsource. But here's why it's important. This is my patient who had a clear cell carcinoma of the ovary. And you can see that she had extensive metastatic disease, including a big golf ball size mass in her supraclavicular lymph nodes, very FDG avid. And before I treated her with nivolumab, she had failed multiple chemotherapies. After nivolumab, gone. She has 5 years, no evidence of disease. And the only reason that I knew to treat her with immunotherapy is because her molecular profiling showed that she was PD-L1 positive. Had I not had that information, this patient would have died, guaranteed. That's why it's important, because molecular profiling allows treatment based on genomic drivers of tumorigenesis, and that is better than generic treatment that we just base on light microscopy, how the tumor looks under the microscope. We get, as you saw, dramatic responses in treatment refractory disease, and so this kind of broad panel testing really specifically measures genes or gene products. And that's what we mean here when we're talking about biomarkers. Biomarkers are things that we can use to predict response and prognosis, so whether they're predictive or prognostic biomarkers. So I want to make sure that we all speak the same language, if you will, and talk about the difference between germline and somatic mutations. So germline mutations are inherited. These we get from our parents. They're in the DNA of every cell in our body. And so specifically when we look at ovarian cancers, high-grade serous carcinomas of the ovary, 18% of ovarian cancers have a germline mutation. Consider that that's different from somatic mutations. So somatic mutations are acquired alterations in DNA that occur after conception. They're in the DNA just of the tumor cells, not of every cell in our body. But we don't want to forget about these. Specifically with ovarian cancers, these are present in 7% of ovarian cancers. And so just with germline and somatic testing, we can identify BRCA or BRCA-related mutations in 25% of patients with ovarian cancer. And that's just ovarian cancer. We'll get to the other kinds. When we talk about molecular profiling then, we usually mean somatic testing. Basically, this molecular profiling gives us a deep dive into specific regions of certain genes. And most of the current platforms, whether it's Foundation or Caris or Tempus or others, usually test about 500 genes. And a lot of times these can indicate the therapeutic options that are eligible for a patient. And in fact, some FDA approvals require companion diagnostics of this molecular profiling. Typically with patients, say with ovarian cancer, we can send molecular profiling, and it may indicate germline testing in some patients. People have suggested that we use this as triage, but even when we see those potential germline abnormalities, it requires confirmation from normal tissue, because remember, somatic mutations are only present in the tumor, germline are present everywhere. I want to talk for a minute about the techniques that we are talking about when we talk about molecular profiling. This all started with Sanger sequencing, which was used to sequence segments of DNA, but it is so time-consuming that it took years to sequence the genome this way. It's very expensive, and the results are, in fact, limited. What we talk about in practice refers to next-gen sequencing or next-generation sequencing. So this phrase is actually a very generic phrase that encompasses a lot of different techniques. It's faster, it's automated. You can sequence the genome in days to weeks with next-gen sequencing. It's much more cost-effective. And we can be more specific even than that. We can talk about select gene sequencing. So this only looks for very specific genes. It's faster, it's directed, but it misses some genes. We can expand that select gene sequencing to whole exome sequencing. And here, as you can see from the figure, we're talking about all DNA that encodes for proteins, mapping about 1% of the genome. It also is pretty fast and pretty cost-effective. Whole genome sequencing looks for all the DNA encoding for proteins and more. And so this will catch all mutations, but it's very expensive and it's very slow, and we're not quite there yet to really use whole genome sequencing in broad practice. There are some other things. People may come in with ancestry-based testing, so you can go on the internet and you can order a little test, right? It comes in a box. You spit in the little vial and you send it in, and they'll run your DNA, right? Well, what is that? Basically, this is just microarray-based SNP testing. It is not validated for clinical use, and there's no quality control. So there is potentially a lot of error in this, kit testing that you can get off the internet. So if a patient comes in and brings you a piece of paper from some company that they get, beware of that. Don't use that to guide your clinical management, because it's full of errors. There are also research studies that some patients have been involved in, and so those results are variable. But why this all matters in gynecologic cancer is that many of the types of cancers that we treat have a high mutational burden that can help guide us. And this is true for ovarian cancers, for uterine cancers, for sarcomas, and specifically for germ cell tumors as well. To dive into each type of cancer that we treat, so let's start with ovarian cancer. I've mentioned a little bit already. It's really important to test for BRCA. Now, when we use somatic testing, so again, that's not inherited testing, right? That's not looking for germline mutations specifically. Somatic testing detects mutations that could also be germline, but again, that requires confirmation from normal tissue to see if it is in fact germline. Some somatic mutations can be germline mutations. So if you see, like, say, TP53 in your somatic testing in the tumor, that's pretty common for somatic, but it's a very rare germline mutation. If somebody has a TP53 mutation in their germline, they have Li-Fraumeni syndrome, and that's rare and bad. If you run your somatic profiling and you see one of the mutations like MSH2, MLH1, MSH6, PMS2, or EpCAM, these are fairly common as somatic mutations in the tumor. About 25% of the time, they correlate with hereditary mutations, and that we would classify as Lynch syndrome. BRCA1 and BRCA2 mutations refer primarily to germline mutations. They're much less common in the tumor only. They're much more common in the germline, and that's the hereditary breast ovarian cancer syndrome that we're used to seeing. So if you run your somatic profiling, whether it's Caris or Foundation or Tempus, you should reflex to do germline testing to see if this is an inherited mutation or not. Because when we look at serous ovarian cancers and we profile the abnormalities that we see, this is what we see. We see that about 8% of patients have BRCA1 germline mutations, about 6% have BRCA2 germline mutations, about 4% have somatic BRCA1 mutations, about 3% have BRCA2 somatic mutations, and so on. So there are a variety of different genes that we see. In addition, there is sometimes deficiency in homologous recombination. We'll get into that in a minute, but basically about 50% of patients with ovarian cancer have a targetable mutation because they have germline mutation or a somatic mutation or homologous recombination deficiency. And so if you send your profile off and it becomes, and you get your result back, should you do germline testing too? And the answer is yes, because molecular profiling fails to detect about 10% of these actionable germline variants because they're outside of the hotspots that are selected in the somatic panel. You can miss large-scale deletions or duplications, and that's true for both ovarian and uterine cancers. And why does any of this matter? Well, it matters because it lets us cure our patients. So the death rate is very, very different. I should say the cure rate is very, very different now that we have PARP inhibitors. And so this is the SOLO-1 trial. Basically, you can see, anybody can see the difference in these curves, right? And so we can see that patients who have either germline or somatic BRCA1 or 2 mutations with ovarian cancer who were treated with maintenance olaparib experienced an incredible improvement in their outcome. So the hazard ratio of disease progression or death was 0.3. That's something we've not seen in another trial. And in fact, we just last year got the 7-year follow-up data that confirmed the benefit, and you can see that those curves, they never come together. This is a forever benefit that our patients get if they're treated appropriately. And so the thing is, you have to test in order to know how to treat your patients. Do we give PARP inhibitors to everybody with ovarian cancer? No. We only give PARP inhibitors to patients who have a germline or a somatic mutation in a BRCA or BRCA-related gene, or in patients who have homologous recombination deficiency. And the PRIMA trial showed us that using PARP inhibitors in these patients was also effective, as you can see from the curve on the right. And when we talk for a minute about homologous recombination deficiency, basically this is a defect in the ability to repair double-stranded DNA breaks, as you see here. There are typically 2 ways that we can normally repair those errors that just happen on a day-to-day basis as our DNA divides. The way that we normally repair that is through either the PARP enzyme or the gene BRCA encodes for that, right? Well, if BRCA is knocked out, homologous recombination doesn't work, and so you can prevent repair with a PARP inhibitor. It's called synthetic lethality. It knocks out both of our repair mechanisms. So these tumors that are dividing and accumulating these double-stranded DNA breaks, they die. They can't fix themselves. And so that's why PARP inhibitors work. And so knowing all this information, it triages our patients with ovarian cancer up front. If we find a pathogenic mutation in a patient with in BRCA, then we know that we give maintenance therapy with a PARP inhibitor. And if we don't, if they're not HRD, then we might want to give maintenance therapy with bevacizumab. In addition, in the recurrent setting, knowing this information about mutation status allows us to determine if we can use a PARP inhibitor in patients at the time of recurrence. It's not just limited to PARP inhibitors, though. Now, this molecular profiling allows us to personalize therapy with targeted therapy. So the presence or absence of folate receptor alpha determines response to the antibody drug conjugate mirvetuximab. And so we know that mirvetuximab works really well, as you can see, but the response rate really correlates with the percent positivity of folate receptor alpha. And again, we have to test to know this. This is true in uterine cancer as well. And so you've seen this, picture multiple times, so I'm not going to go through the details of it, just to remind you that the molecular characteristics determine the outcome and determine how we treat our patients with uterine cancer now. It allows us to identify deficient mismatch repair, so we can identify the mismatch repair machinery and identify which patients are mismatch repair deficient, so we can target those patients potentially with immunotherapy. We can utilize our testing to determine that MMR status, and then we can bring in immunotherapy in those patients. We know from all of these studies, initially starting with these single agent trials, we can see this incredible response rate, overall response rates of over 70%. And as you know, now we can utilize immunotherapy to target PD-1 and Keynote 158, as you've heard before, targeted MSI-high advanced endometrial cancer and gave us an incredible response rate, right? A 57% response rate. We saw the same story in the Garnet trial, which used dostarlimab in advanced endometrial cancer. That gave us an overall response rate of 44.7% in the mismatch repair deficient patients and 13% in mismatch repair proficient patients. I mean, this really is groundbreaking work because it allows us to treat patients with targeted therapy, really immunotherapy, compared to chemotherapy that just didn't work as well. And again, we have to know the MMR status. We know immunotherapy works in our mismatch repair deficient patients, but if a patient is mismatch repair proficient, we're going to add in lenvatinib. We see even long-term overall survival benefits that continues over 42 months in follow-up. And for the win, GY018. So as I think Dr. Naumann shared with you earlier, these trials that were just published within the month have really changed the standard of care for how we take care of patients up front with advanced stage or recurrent endometrial cancer by adding in immunotherapy. And again, you need to know the MMR status in these patients in order to know if the patient is going to benefit. You can see, this is the slide from the SGO presentation where this was shared with us, that the progression-free survival is markedly different when immunotherapy is included in this population. And also the Ruby trial with dostarlimab, also immunotherapy, showing similar improvements in DMMR and the mismatch repair proficient, but to a lesser degree. Other important details for uterine cancer involve HER2. So serous carcinomas that test positive for HER2, we're going to incorporate trastuzumab in these patients. Patients who are estrogen and progesterone receptor positive, we would include hormonal therapy. And as you've heard, we may omit therapy in patients who are polymutated. Don't forget germline testing in your patients who may have Lynch syndrome, because the benefits both to them and their family with cascade testing is really important. You've heard from Dr. Naumann about cervical and vulvar cancer, and that PD-1 and PD-L1 status truly determines therapy. Since you've heard that, I'm not going to go through the data again. You heard from me just a half hour ago about the Milo trial and how our KRAS status determines if a MEK inhibitor is appropriate in low-grade serous carcinomas. And you've heard that even in clinical trial design for rare tumors, the mutational status determines what may benefit a patient the most. The future, I think, one piece of the future is with circulating tumor DNA, and this actually functions as a biomarker. This may be prognostic in patients with gynecologic cancers, and we already know in colon cancer that it tells us when we can discontinue immunotherapy. In addition, that may signal recurrent disease, as some early studies have shown us with ovarian cancer. And so in summary, I think the summary is that molecular profiling is really essential for evaluation and treatment planning for gynecologic cancers. It's a piece of what we have to offer our patients, and I'm hopeful that all of that will make its way here in the very near future. So this is just a wonderful memory from 2017 when we were here in your wonderful country just a few years ago. So thank you so much.
Thank you for your presentation. You know, there was such a big difference. I mean, most of the time we can just use HAP inhibitors well. We can offer BRCA testing, for example, but they have to pay for everything. I mean, at least in Georgia. Yeah, so I know that in Kazakhstan they are changing a lot of things now. That it's available for patients. They can use HAP, and it's so nice, and they include so many efforts in it, and it's so good. But unfortunately, well, on the so much different levels. I mean, so I understand that that's the future, and we have to move towards that, and we will. Yeah. But it might take some time, you know. So.
Yeah, I think that's a really good point, and it just makes me think that we have so much work to do on a worldwide stage to make all of these. There shouldn't be any difference where you live.
Absolutely.
You know, and it makes me think that we need to do a better job of talking with pharma and really showing cost effectiveness, bringing prices down of these drugs and these testing platforms. You know, when you talk with the molecular profiling companies, they want to expand here, and they'll actually scale their price down. I've had some of those conversations with them. But of course, if you're going to scale the prices down, you have to be able to get the drugs that you're going to use.
Absolutely.
Yeah. So
this is a chain, like you need everything, but well, that's the future, and we are moving toward it. But it's a quite slow process, and if it could be speed up somehow, it will be really nice. Maybe some questions. No questions. So thank you once more.
Thank you.
And our next speaker is Tina Kurdiani with the cervical cancer and pregnancy. Please.
Good afternoon, dear colleagues and chairmen. I would like to extend my gratitude to all on this summit and welcome of this summit. It's a great pleasure to attend this summit, and today my presentation dedicated cervical cancer in pregnancy. Cervical cancer is the fourth most common in the worldwide, and in Georgia it takes fifth most common malignancy. 322 new cases of cervical cancer was reported in 2019 in Georgia, and it constitutes 5.6 all of cancer types. And right now in Georgia, what happens? 2016, 2018, it decreased. The tendency was noted in the incidence of cervical cancers, but unfortunately, in 2019, it's increased again, and it was 5.6 per 100,000. The mortality rate is also increased, and it was 8.5 per 100,000. The overall prognosis for 5-year survival rate of patients in Georgia is 60%. And map main gaps and recommended actions plan. There is screening, diagnostic, treatment. Every patient should be treated by well-coordinated multidisciplinary team, including gyno-oncologist, medical oncologist, radiation oncologist, and of course nurse. And what about diagnostic workups? Diagnosis is based on histological verifications that includes pap smears, cervical biopsy, and biopsy of suspections lymph nodes. And very important also stagings. Stage is very crucial because on base of stagings you have to plan treatment of patients. And right now I want to say that also staging is also changing. FIGO updated his staging on 2018, and the 9th version of TNM classification was published in March on 2021 by the American Joint Committee of on Cancer. And right now, our remark about cervical cancer in pregnancy, it's one of the most common malignancies in pregnancy, and the estimated incidence starts of 0.8 and 1.5 cases per 10,000 births. And for 2% of women diagnosed with cervical cancer are pregnant and postpartum. At this time diagnosis, approximately 1/2 of these cases are diagnosed prenatally, and half of them diagnosed after delivery. And the most patients are diagnosed at the early stage of the disease years, probably as a result of routine prenatal screening, but it's also possible that have advanced stages. And also I want to say that the prognosis of stages not differs with pregnancy. It's the same such cervical cancers. And every woman diagnosed with cervical cancer must be consulted by a multidisciplinary team, which also included gynecologic oncologist and obstetricians. The treatment plan should be based on tumor stage and gestation age and pregnancy at the time of cancer diagnosis. Preferred imaging should be magnetoresonance imaging and ultrasound. And there is several treatment options based on the tumor stage and gestation week of the fetus, and the risk of benefits of each treatment should be very carefully discussed with the patient. And I want to stress right now two procedures which you have to perform during the cervical cancer pregnancy. Cervical biopsies can be performed during pregnancy without a significant increase of excessive bleeding. But if you have bleeding, it's also no problem. You can to resolve this by the Monceau solutions. And I want to stress that endocervical curettage is not performed in pregnancy. Women, because of the cancer, they may disrupt of pregnancy, but also there is no evidence providing increases risk of pregnancy disruption. And right now about stages. 1A and 1B, cervical cancer with negative lymph nodes and diameter less than 2 centimeters. Conization of cervical or simple cervical resections are recommended. Delay of treatment until the second treatment may be also acceptable alternative. And about conization. Optimal time for prenatal conization, second trimester, preferable between 14 and 20 weeks of pregnancy. Conization should not be performed within 4 weeks before expected date of delivery. And right now, cervical cancer in pregnancy before 24 weeks. In patient with lymph node positive, stage 1B1 and less than 2 centimeter tumor, termination of pregnancy is recommended. If the patient wishes to continue pregnancy, neoadjuvant chemotherapy during pregnancy and postpartum chemotherapy are carried out. In patient with stage 1B1 cervical cancer with diameter greater than 2 cm, pelvic lymph node dissections or neoadjuvant chemotherapy are recommended. If the lymph nodes are negative or patient desires to continue pregnancy, neoadjuvant chemotherapy are recommended. And preferable medication is in neoadjuvant chemotherapy is cisplatin 50, 100 milligram quadrat every 3 weeks. And duration of treatment is she have to receive this cycle of chemotherapy. And what about after 25 weeks? Neoadjuvant chemotherapy can be used to stabilize diseases while awaiting lung maturity, and neoadjuvant chemotherapy is not recommended after 33 weeks of gestation due to the high risk of preterm birth. And also, I want to stress that the mode of delivery is sections. And about prognosis. There is no data from a large randomizable trial with the base recommendation for care a pregnant patient with cervical cancers. There is a few study of this, and one of the studies shows that the median of follow-up for 2 years survival stage was reported as stage 1B1, 84%, stage 1B2, 70%, and stage 1B, 70%. And I wish you health and sex for your attentions.
Thank you, Dina, but I have one question. So, do you consider for a radical trachelectomy during the pregnancy? I mean, we talked about neoadjuvant chemo or something.
No, radical trachelectomy you have to perform after delivery. It's not indicated during the pregnancy.
But unfortunately, here Sultan is missing. But I've been in Hungary and I have seen such a live surgery. I mean, Dr. Latsonga was doing it. There was a twin babies, so they made it like radical trachelectomy during pregnancy, and they have very good results. I mean. So you can consider this too, so why not?
I have just, I stress about base of medicine, up to date of base of medicine, that's for this stages you have to do conization. And after delivery, if marriages are positive, it's also no problem with 1A. You can do again after delivery, 6 months, 6 weeks, again conization. And also radical trachelectomy.
I'm not talking about 1A, so I'm talking about the 1B.
1B also will be treated by after the during the delivery. You can do radical hysterectomy or trachelectomy. I have not data about this one.
Okay. Questions? There was a question here, or no?
Добрый день, отличная лекция была. У меня один вопрос. Сколько в год радикальной трахеолектомии вы проводите? И после этой операции
many times a year radical trachectomy is used and whether pregnancy could
Я
happen
лично
then.
трахеолектомию не делаю. И статистика очень низкая по поводу беременности после этого. Просто трахеолектомии.
Я
лично сама не делаю
trachelectomy. I am not performing this myself. That is why I cannot say you specifically about the statistics.
It's very nice presentation, and let's move to the last. As I know, we have. It's possible. Yeah, it's recorded, so we can show it. Yeah. So.
Great. And actually, you know what? I left my glasses up there, so I'm going to ask you to do that.
There is a last speaker, and we have recorded it. It's applying immuno-oncology lessons learned from breast applying to gene and other targets. So, Dr. El Ghazali from Egypt.
morning. Thank you very much for inviting me for this very important conference. I hope one time to come and visit your beautiful country and to have a very good collaboration between Egypt and Kazakhstan, and to have a good networking for the work in breast and gynae malignancies. Thank you very much for the organizing committee, Professor Diryara and Professor Maya, for inviting me for this important conference. We will talk about the applying immuno-oncology lessons learned from breast cancer, applying it in the gynae cancer and on the other targets. And we all know that we are depending on, in the management of cancer, firstly on the chemotherapy and those broad spectrum activity on the cells in the DNA, and then going to the target to define a target inside the cells to go for what is called the targeted therapy, then going to what is called the immunotherapy. A lot of trials on different decades about enhancing the immune system or affecting the immune system to enhance the response and to enhance the efficacy on the cancer cells. As you see from long time before, till the great discovery of the checkpoint inhibitors by our great Nobel Prize winners. So it is a great discovery that leading to improvement in the outcome of the cancer overall, especially the going to assessment and understanding the microenvironment. And we all know that breast cancer burden worldwide is huge. We know that is almost about 2.3 million women diagnosed with breast cancer and almost about 700,000 deaths globally. And as you know that almost about a lot of patient women alive, more than like about 8 million women alive with breast cancer worldwide, making it the most world prevalent cancer. So it is important also to know that we have different types of breast cancer, luminal disease, the HER2-positive breast cancer, and triple-negative breast cancer. And we know that triple-negative breast cancer, which is diagnosed with the immunohistochemistry, that estrogen receptor negative, progesterone receptor negative, and HER2 negative tumors are the most aggressive breast cancer subtypes, accounting about 10 to 15% of breast cancer cases. And there is no definite target before, till the recent advances in assessment and genomic assessment and molecular assessment, that we find and can classify according to the ISMO into 3 different subtypes: the PD-L1 positive and the CBS score more than 10%, and those patients with the mutated BRCA genes, and others who are not BRCA mutated and not PD-L1 positive or wild type BRCA and PD-L1 negative. And every algorithm affected by these different factors, leading to different pathways in the management strategy. And also the immunotherapy in breast cancer, firstly, is tried multiple times with different clinical trials, as we see in the clinical trial that go more than 450 trials dedicated for breast cancer, inspired breast cancer known as a cold tumor, not a hot tumor. As you see here, multiple clinical trials with the checkpoint inhibitors in breast cancer. So immunotherapy can be used as a single agent in triple negative. What is the most hot cancer or the most hot breast cancer subtype is the triple negative breast cancer subtype. And this is the first trial as a monotherapy in breast cancer using the pembrolizumab, showing anti-tumor activity and the manageable toxicity in the Keynote 012 published in June 2017. and provide long-lasting responses in heavily pretreated patients with metastatic triple-negative breast cancer. And here is the results of the Keynote 012 and the use of it, assessing the outcome according to complete response, partial response, or progressive disease, showing improvement in the progression-free survival and overall survival. And shifting from the monotherapy to the combined modality of the immunotherapy, combining with chemotherapy in metastatic triple-negative breast cancer in the famous Keynote 355, showing the improvement in the dual primary endpoints, the progression-free survival and in overall survival in patients with metastatic triple-negative breast cancer whose tumor expressed PD-L1 with the CBS score is equal or more than 10. And you see here how beautiful the results. This is the clinical trial comparing the Pembro with the chemotherapy, whatever chemotherapy, and this is the beauty in this trial, whatever the chemotherapy use either gemcitabine, paclitaxel, nab-paclitaxel, with compared to the placebo with this amount of chemotherapy. And you see here how beautiful is the results improvement in the overall survival in the population with the CBS score equal or more than 10. But not all the immunotherapy is the same. So in the same trial, using the atezolizumab with nab-paclitaxel, so no other types of chemo, so failed with other types of chemo, and atezolizumab with nab-paclitaxel, in spite improvement in overall survival in the PD-L1 positive patient, but not improve the overall survival in intention to treat population. And here is the trial of the inpatient trial using the atezolizumab, which is approved by the EMEA, but not approved by the FDA. Going from the metastatic setting to the new adjuvant setting. So, and you see here the beautiful study, the Keynote 522 by Professor Jan Schmidt, using the combination of immunotherapy with the chemotherapy in the neoadjuvant setting, using the anthracycline and then taxane with or without the pembrolizumab in the neoadjuvant setting, leading to a favorable trend into improvement of the overall survival with hazard ratio of 0.7 and the pathological complete response achieving in more than 60% in the Pembro group compared to only 50% with the p-value of 0.001. And you see here is the trial comparing the chemotherapy, including carbotaxol, with the doxorubicin or eberubicin, with Pembro or without Pembro, and going for adjuvant Pembro for 9 more cycles after the surgery, improvement in the probability of being alive with the using of the pembrolizumab, leading to improvement in possibility of pathological complete response in 64% of cases. Again, the combination. So the combination is a great thing within the immunotherapy because the combining material, either the chemo or, as we will see now, the PARP inhibitor, leading to more warming, more hotting the tumor, leading the cold tumor to be more and more hot. And then another rationale of combining the immunotherapy with the PARP inhibitor. So here in the triple-negative breast cancer, the phase 1 and 2 trials are showing that the response rate was promising in 2 phase 2 trials evaluating the combination of durvalumab and the olaparib or pembrolizumab when the niraparib in the first line or pre-treated patient with germline BRCA1 and BRCA2 mutations. And the rationale behind this is the PARP inhibitors can lead to DNA damage and genomic instability, which could increase the cancer immunogenicity and enhance the sensitivity to the immunotherapy. Another combination approach, but not in the triple negative breast cancer, moving to the luminal breast cancer. So in even luminal breast cancer, which is a very cold tumor, the addition of CDK4/6 inhibitors to the immunotherapy may lead to better improvement, with the rationale that the CDK4/6 enhances the antigen presentation and decreased the Treg proliferation, modulated the T cell activity, and reducing the expression of inhibitory receptors as PD-1. Even in the HER2 positive metastatic breast cancer, the combination of trastuzumab with pembrolizumab leading to improvement in some patients who are resistant to the trastuzumab and PD-L1 positive. So it is subgroup of the population which is PD-L1 positive and the HER2 or resistant to the HER2 therapy. There is improvement of combination again in those patients with the addition of the pembro to the anti-HER2 treatment. So what are the lessons learned from the breast cancer treatment? In spite it is called the tumor, that the early data suggests that breast tumor are immunogenically cold and immune checkpoint inhibitor could not be effective therapy, but this changed and dramatically changed with the more studying of the microenvironment analysis justifying the use of immunotherapy and paved the way for further trial to increase the immunotherapy efficacy in breast cancer. The combination modality is the solution. It is very effective approach. In addition of the immune checkpoint inhibitor would enhance the anti-tumor activity of chemo, and also the PARP inhibitor leading to DNA damage, more hotting of the tumor, more genomic instability, increase the cell immunogenicity, and enhancing the sensitivity of immunotherapy. Also, the CDK4/6 inhibitor enhance the tumor antigen presenting cells, decreasing the Treg proliferation and the modulated T cell activation by reducing the expression of inhibitory receptors such as PD-1. Going to the gyne malignancy, again is huge burden, about 3.6 million, and maybe the mortality is also very high, exceeding 1.3 million, and this cancer accounting for about 40% of the cancer incidence and more than 30% of all cancer mortality in the woman cancers. And here is the classifications, different classifications of the ovarian, cervical, and endometrial cancer, and this is different by geographical distribution. So cervical cancer is more and more in Africa. Endometrial cancer is more in Egypt, and ovarian cancer is more in Egypt. So it is different according. There is a geographical distribution of the gyne malignancy according to the human papillomavirus infection and different factors. Going to again the keyword, the microenvironment. And here is the endometrial cancer with the Cancer Genome Atlas, showing that there is different molecular classification for endometrial cancer into what is called the POL mutation or polymerase epsilon mutated endometrial cancer subtypes, the P53 abnormal endometrial cancer subtype mismatch repair deficient subtypes or MSI high subtypes, and no molecular profile or no specific molecular profile. And you see that it is complete different and may lead to different survival according to this classification, and may also have a different treatment strategy in those different populations. And do you know that the POL mutated endometrial cancer type is rare, is almost 5 to 10%, with excellent prognosis, high mutation burden, and associated with increased expression of PD-1, PD-L1, and additional T cell marker. And this is the microarray of the different endometrial cancer subtype, the BOL, the MSI hypermutated, the copy number low or the endometrioid, and the copy number high, the serous-like. And this is the MSI endometrial carcinoma is more frequent, more responsive to the immune checkpoint inhibitor. And you see here in the graph how the progression-free survival in different types, the highest probability of survival in the BOL subtype, and the lowest in the serous-like subtype. In the cervical cancer, we know that the human papillomavirus is the main factor of, or the mega factor of causing cervical cancer, with production of proteins, the E6 and E7, and this inhibit the critical tumor suppressor gene B53 and retinoblastoma, respectively. The majority of cervical cancer express the PD-L1 positivity, which is down-regulating the host immune response. Here also a graph or a photo of how the inflammation and the microenvironment be affected by different factors, by infections and other, leading to making the microenvironment more hot. In ovarian cancer, it is we have an immunosuppressive microenvironment, increasing number of activated regulatory T cells, and the production of interleukin-10 and the transforming growth factor B, and also contribute to the overall immunosuppression. The vascular endothelial growth factor showed to inhibit the dendritic cell maturation and function and upregulate the PD-L1 expression on myeloid dendritic cells. Escape mechanisms such as decreasing major histocompatibility complex expression of the antigenic loss. Again, this cold tumor or the cold environment in the ovarian cancer can be more warmed and more hot by different maneuvers, including the cancer vaccines, the PAM repolarization inducer, the antigen-presenting enhancer, bispecific T engager, the immunogenic cell death inducer. Another rare malignancy that we heard about different types of approaching the treatment, and which is the GTN or gestational trophoblastic neoplasm, showing that different study that showing that high expression of PD-L1 in normal placentas and in different subtypes of GTN disease. Beside those factors, contribution, other factors contribute non-classical class 1 HLA-G, HLA-E, and HLA-F, and the classical HLA-C and CD1D that can elicit allogenic immune response and immune tolerance mechanism. Here is also a graph showing how the maybe the effect of different immune checkpoint inhibitors in the GTN cells. Going to trying using of checkpoint inhibitors in gyne malignancy, the first and very promising basket trial or huge trial in the MSI high tumors, showing a great and beautiful outcome from the use of pembrolizumab and the MSI high advanced endometrial cancer. The objective response rate was 48%. Median duration of response was not reached. So this is the classical great benefit of the immunotherapy, is the plateauing or the improvement and maintain responses for a long time. And we all see this in the real life. And the median progression-free survival was 13.1 months, and the median overall survival was not reached. Here is the updates of the Keynote 158 of the use of the Pembro in the MSI high advanced endometrial cancer, and you see how beautiful is the maintained duration of response with the use of immunotherapy. not only the Keynote 158, but other types of immunotherapy or checkpoint inhibitor, like the dostarlimab, the durvalumab, and the avelumab, with, as you see, a beautiful overall response rate ranging from 30 to about 60%. Not only the endometrial cancer, but also the cervical cancer, which usually have PD-L1 positive, or the PD-L1 positivity is high, with improvement in the overall response rate. As you see here, the Keynote 158, which is a basket trial showing in the advanced cervical cancer improvements in the outcome. As you see, improvement in the response rate. They have complete responses, overall response rate of about 14.3%. It is in the PD-L1 positive cancer. In the GTN, as we listen from our previous speaker, that the NCN clinical practice guideline recommending PD-1, PD-L1 inhibitor, either Pembro, Nivo, or Avelumab as options for the treatment of the GTN resistant to chemotherapy. And we know that, and we will discuss this later, that the Trophimum trial preliminary outcome suggests that Avelumab might be effective and better tolerated than standard chemo in the patient with resistance to single chemotherapy. And here, some of the clinical trials assessing the use of the pembrolizumab in GTN tumors in the choriocarcinoma. And here is the responses, the beautiful responses, as you see, the complete response, and partial responses. Going to the combination. So it is not only single modality, but the details is important, and the secret is in the combination modality. The Keynote 775, with the addition of pembrolizumab to targeted therapy, the lenvatinib. And you see here that, and those patients is not in the MSI high, it is in the proficient mismatch repair. So it is in the cold tumor. So the hot tumor, we can use the single agent, and even in the cold tumor, we try to make it hot by the addition of lenvatinib. So the addition of lenvatinib to the pembrolizumab, showing improvement in the overall survival with the hazard ratio of 0.65, and improvement in the progression-free survival and overall response rate by using lenvatinib and pembro. And this is the clinical trial here, the randomization to go for pembro, lenvatinib versus chemo. So it is not versus placebo, it is versus chemo. And you see here the beautiful improvement in the progression-free survival with the hazard ratio of 0.56, and the improvement in the also in the progression-free survival in those patients with the deficiency in mismatch repair, much more higher, reaching with hazard ratio of only 0.36, and the improvement in overall survival in all patients in those population with hazard ratio of 0.62. Going to a very another great achievement in the just published in the ELAST-ISMO with our colleague and friend Professor Mansour Riza in the RUBY trial, showing that improvement in overall survival at 24 months in the whole study population from 56% with the only chemo to 71.3% with the addition of the dostarlimab with carboplatin and paclitaxel, and published in the New England Journal. And this is the study showing this improvement in the progression-free survival and overall survival in the proficient mismatch repaired or the MSI stable population. In the combined modality in the cervical cancer, so we go for the Keynote 526, which is the phase 3 trial showing addition of chemo, again, to the pembrolizumab in the recurrent and metastatic cervical cancer. This is the randomization of this trial, and again, improvement in overall survival with the addition of pembro to the chemotherapy in those disease, showing that it is the combination modality making improvement in the microenvironment, leading the cold tumor to be more hot tumor. Phase 2 tobacco trial in the ovarian cancer, assessing very importantly those patients with BRCA. How can we add the PARP inhibitors like niraparib to pembrolizumab in ovarian cancer, and very promising results in those populations who usually resistant ovarian cancer. So overall response, you see how beautiful is the result. Overall response, 25% in platinum-resistant ovarian cancer, and it reached to 45% in those with BRCA mutated patients. So it is another opening the gate for those very hard to treat population with resistant ovarian cancer. And this is the tobacco trial phase 2 design. And from this, we reach that very important take-home message, is that our patient deserving the best. It is very, very important to go deep and to try not to just to say that it is a cold tumor, but the combination is very, very important to make the tumor change it from cold tumor to hot tumor by using different agents. So the immunotherapy era is a landmark in cancer treatment history with promising results regarding response rate, survival benefit, and tolerability. No more one size fits all. So it is very important to enhance and use the science and research activity and precision medicine to achieve the best results of the immunotherapy. And thank you very much, and I hope to see you soon.
Well, fantastic. Do we have any questions or points of discussion before we break? All right. Well, why don't we take about a 10-15 minute break, and we'll come back for our master session on ovarian cancer and tumor board. Thank you very much.
Наша цель ясна. Она не изменилась. Мы расширяем границы науки, чтобы предоставить лекарственные препараты, способные изменить жизнь. В наши дни наука развивается как никогда быстро. Не отставать и держаться на равных – непростая задача. Мы должны продолжать добиваться новых результатов. Оставаться лидером. С помощью нашей коммерческой деятельности, с помощью нашего бренда. Вот из чего мы созданы. Сила научных достижений.
Мы Янсен. Каждое утро мы просыпаемся для того, чтобы сделать возможным то, что еще вчера казалось невероятным. Мы прокладываем путь туда, куда другие боятся смотреть. Изучаем и воссоздаем сам код жизни, чтобы лечить, помогать, исцелять. Мы открываем двери для сотрудничества, а умы и сердца для пациентов, чтобы наши успехи в лабораториях спасали жизни. Мы создаем инновации в лекарственной терапии и делаем их доступными для всего мира. Мы Янсен, фармацевтические компании Johnson & Johnson. Это наша жизнь и мечта, в которую мы верим. Мы будем использовать науку для борьбы с заболеваниями, изобретать, как помочь тем, кто нуждается в помощи, исцелять безнадежность человеческим теплом до тех пор, пока самые тяжелые заболевания не останутся лишь на страницах истории. Янсен. Создаем будущее, где заболевания останутся в прошлом.
It is the future that calls us, our history that forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift: life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science, from despair to hope. In 2021, we come together to celebrate where we have been, what we're doing, and where we'll go next. To celebrate 125 years. To celebrate all of us. To celebrate the future. We come together to celebrate life.
We are here together to celebrate life.
Каждые 2 секунды у кого-то в мире диагностируется рак. Это не просто статистика, это близкие нам люди. Поэтому нет ничего более срочного или более личного, чем наша цель – найти способы излечения от этого смертельного заболевания. Но мы знаем, это чересчур грандиозная цель, чтобы справиться в одиночку. Мы сотрудничаем с научным сообществом, чтобы открыть новые методы лечения, используя силу реальных доказательств для более точного действия наших препаратов. Сотрудничаем с группами защиты прав пациентов для поддержки и расширения прав и возможностей людей, которые живут и борются с раком. Взаимодействуем с организациями здравоохранения для предоставления доступа к нашим лекарствам тем, кто в них нуждается. Вместе мы достигли значительного прогресса, но наша работа далека от завершения. Рак забирает миллионы жизней каждый год. Чтобы превратить истории потерь в истории надежд, мы все должны объединить свои усилия. Чтобы найти способ победить рак, мы все должны объединиться.
Караганда. Индустриальный центр и магистральный узел железнодорожных и воздушных путей. По своему экономическому и научному потенциалу она по праву занимает одно из ведущих мест в республике. Именно здесь было создано первое в Казахстане предприятие, производящее современные, высокоэффективные биотехнологические препараты. Карагандинский фармацевтический комплекс. В создании завода было инвестировано более $100 миллионов. Мы первое предприятие в Казахстане, производящее препараты в асептических условиях, соответствующие международному стандарту надлежащей производственной практики.
В Казахстане были созданы благоприятные условия для привлечения инвестиций в отечественную фармотрасль, и в результате чего и было создано наше предприятие.
Карагандинский фармацевтический комплекс. Мы осуществляем трансфер технологии производства биотехнологических лекарственных препаратов для лечения таких социально значимых заболеваний, как онкология, гемофилия, ревматоидный артрит, сахарный диабет и других редких болезней, которые ранее здесь не производились. Впервые в Казахстане внедрена технология производства препаратов в преднаполненных шприцах.
Все наши производственные цеха спроектированы и построены в соответствии с международными стандартами надлежащей производственной практики. Цех оснащен современным европейским оборудованием, позволяющим производить препараты высокого качества.
В 2015 году у нас основана испытательная лаборатория отдела контроля качества. В нее входят физико-химическая лаборатория, микробиологическая лаборатория, и единственная в республике биохимическая лаборатория, выполняющая анализы биотехнологических препаратов.
Мы производим биотехнологические инъекционные лекарственные средства, требующие особых условий при хранении, производстве, транспортировке и контроле качества. В связи с этим нами выстроена фармацевтическая система качества на требуемом уровне для обеспечения населения качественными, безопасными и эффективными лекарствами.
Наш современный фармацевтический склад оснащен холодильными камерами для хранения лекарственных препаратов со специальным температурным режимом и морозильными камерами для хранения активных фармацевтических субстанций и вакцин. Датчики контроля взаимодействуют с центральной диспетчерской службой. Это позволяет осуществлять круглосуточный контроль температурного режима, мгновенно реагируя на любые изменения. Транспортировка наших лекарственных средств осуществляется валидированными авторефрижераторами. Мониторинг безопасности препаратов ведется и после его доставки.
Процессы производства поддерживаются инженерными системами мирового уровня. Системы электроснабжения, теплоснабжения, водоподготовки и воздухотехники обеспечивают безаварийную работу предприятия.
В нашей компании работают высококвалифицированные специалисты. Для повышения уровня профессиональной подготовки сотрудников на предприятии реализуется четко организованный план по развитию и обучению. Мы взаимодействуем с крупнейшими медицинскими вузами страны для подготовки молодых кадров.
Миссия нашей компании – обеспечение населения нашей страны безопасными, эффективными и доступными лекарствами.
Наша приоритетная задача – это сохранить и приумножить здоровье нации, создавать рабочие места и быть активным участником развития своей страны. Быть лучшими не только в Казахстане, но и за его пределами.
penumbra and greater dose optimization than traditional pencil beam scanning systems by shaping or blocking any spot at any depth, while eliminating the need for manual apertures and adjustments.
We could talk about our company using key facts and figures. We can tell you that today we're around 5,000 people worldwide, with 4 production and 4 research and development sites. And that we sell our medicines in over 100 countries. We could also tell you that our annual turnover is over 3 billion euros. And that last year, we dedicated more than 445 million euros to research and development for new and innovative treatments. While these are all important and illustrate how strong we are, the quality of our research, the efficacy of our treatments, and our global footprint, they don't capture what's really important to us. It's patients who inspire us to get up every morning. Patients living with cancer, rare diseases, and neurological disorders. It's Ronnie, Janice, Diana, Nadine, Misha, Yugan, and Steve. Working in partnership with the healthcare community, we aim to support them and their families throughout their entire journey. That's what's really important to us. Improving patients' lives. We are relentless about making a difference. At Ipsen, we focus together for patients and society.
Hello, dear users. In this video, you will learn about the CAS-CS mobile application. Next, we will tell you how to use this application and what features it provides. The application is available for download in the App Store and Google Play Market. To use the application, you need to complete the registration procedure. In the window that opens, you need to enter your registration data, such as email address, mobile phone, last name and first name, city, organization and position. For security purposes, you must create your own unique password containing at least 9 characters. After registering, you will be taken to the main page of the application, which consists of the following sections: upcoming conferences, past conferences, and the other resources section. In order to take part in the upcoming conference, you need to click on the banner you are interested in, and in the window that opens, confirm your participation by clicking the Participate button. If you closed the registration offer and later decided to join the conference, then when you click on the conference banner again, you need to click on the button with a heart in the upper right corner of the screen. By going to the conference you are interested in, you can see the list of speakers and event organizers, as well as find out of the number of participants. In the speakers section, you can find out date and time of the speech of the specialist you are interested in. You can get acquainted with the conference program when choosing the day of the conference and specific hall. Also, by clicking on the video camera icon, you can go to the online broadcast of the selected hall. When you return to the main page, at the bottom of the screen you will see a set of icons which we will discuss in more detail. In the icon with hearts, you will find a list of conferences in which you are already participating. After clicking on the conference window, you will see a section with a personal QR code by which you can attend the conference in person. In the icon with doctor, you can find the necessary specialist, information about him, and contact him in a way convenient for you, via instant messengers, social networks, email, or by phone number. In the icon with document, there is a current news feed. By clicking on the profile icon, you will enter your personal account, where you can add or edit information about yourself, which will be displayed when searching for your profile in the specialist section. Here you can edit profile photos, links to social networks and instant messengers, as well as block access to them. In the profile section, you will be able to change the language and the ability to delete your account. CAS-CS application version is updated automatically. Turn on the auto-update feature in your mobile phone settings. We hope that this information was useful for you and the experience of using our application will be simple and convenient for you. Thank you for your attention.
thank you so much, Dilara, for asking me to be part of your great conference. I'm going to talk about the role of genetic encountering in ovarian cancer, which is a very important topic and very emerging topic that is affecting us all, regardless the country and the cancer center we are working and acting. So we know that ovarian cancer is still a rare disease. It's much more rare than, for example, some other types of cancer. Only 1 in 75 women was thought to have to be diagnosed with ovarian cancer. We now know it's more around 1 to 50, around 1 to 53, and it's more due to the better diagnostics and also better definition and understanding of the disease. I have sent you here, I have given you here like a small overview of the cancers of cancer, of the types of cancer and numbers of cancer worldwide. We have around 5 million cases annually, which is a massive number. In the UK alone, we have 116,000 cases annually, and 50% of the women's cancer will be ovarian cancer, together with breast cancer, endometrial cancer, and colorectal cancer. So it belongs still to the most common types, even though if we compare, for example, to breast cancer, which is 1 in 8 women, 1 in 10 women, it's much more rare, and therefore studies and any analysis are much more difficult to get. The ovarian cancer, the problem is that because of it being a chameleon, and especially the symptoms being a chameleon, 75% of the patients will be diagnosed in advanced stage 3 and 4 disease. And we know even that this is the case in most patients, regardless of the family history. And the 5-year relative survival, even though it has increased over the last decades, the actual cure rates have remained the same. The symptoms are with abdominal bloating, loss of appetite, weight loss. The symptoms resemble very much IBS or even perimenopause or postmenopause. And that is why for many years, ovarian cancer used to be called the silent killer, just because it started creeping up with symptoms that nobody really recognized and identified correctly as ovarian cancer, and therefore the patients went undiagnosed for months. There is an older Australian study that shows that the average number of months between onset of symptoms till diagnosis, set of diagnosis around 6 to 8 months. So it's a significant number of delay and amount of delay for a cancer patient. So the problem with ovarian cancer is that it's a disease of many diseases. We just call it ovarian cancer, but at the end we know it's a fallopian tube / ovarian / peritoneal cancer. And depending on the final histology that the cancer will have, we have a different origin of the disease. For example, in endometrioid and clear cell cancers, we know it's mostly from patients with endometriosis. High-grade serous actually fallopian tube cancer, and that is why it is very tricky to actually try to diagnose early those diseases, just because we still have not really understood well neither its origin nor its pathophysiology. We think, and there are theories, that in primary ovarian cancer, the high-grade serous comes from the fallopian tube, from the sticks, and that we have small cancer cells. I'll try to explain to patients. It's like a small precancer cells that sit at the end of the fallopian tubes and then get blown to the entire patient, to the entire tummy. And this is called the serous tubal intraepithelial carcinoma, or else stick. We know that in patients with a genetic mutation at prophylactic BSO with a BRCA1 or 2 mutation, the rate of sticks may be up to 7-8%. And this is something that the patients need to know, and therefore we have, and I will have in my clinic once a year, patient with ovarian cancer who will have been after prophylactic surgery years ago. The genetic pathways are still to be explored. We have gone many miles and ahead of how we were a few years ago. Still, there are many things that we have not yet understood, and that has led to the fact that many immunotherapy and targeted agent factors are not really as targeted as we thought or as we would like them to be. Even the PARP inhibitors, which are targeted agents, they actually work in all ovarian cancers. And even though we call them targeted agents, they're not really as targeted as, for example, is the immunotherapy in melanomas. The problem with genetics in ovarian cancer is that even though something like around 25 to 30% of patients with high-grade serous ovarian cancer will have a BRCA mutation, half of those patients will have a negative family history. Therefore, the old concept of just asking the patient whether anybody in their family had cancer, and then this tailoring necessity and type of genetic treatment, genetic diagnostics is completely outdated. And now in most countries in Europe and in the UK, it is financed by the government, by the state, by the local national guidelines, that all patients with high-grade serous or high-grade ovarian cancer get a genetic testing, just because otherwise we would miss patients who have a mutation but have a negative family history. The issue also, the further issue with ovarian cancer is that there is no effective screening. And that is why a genetic testing of the right patient will lead, and also of the family, will lead to earlier diagnosis, just because the screening modalities so far have been proven to be completely non-effective. You know, all of you, these curves that are from years and years ago, the UK study, American study, absolutely identical curves, no benefit of screening in the normal population. And therefore, the only way to really prevent this type of cancer is to do an adequate genetic screening to the right population. There has been some approaches in patients with uterine lavages, in tampons, where they're collecting the fallopian tube discharge, and all of us have had patients with very early ovarian cancer who have started as first symptom having increased vaginal discharge that is full of cancer cells that then can be detected in uterine lavages or tampons. And this is something that has been seen as promising for years, but it's not something that has been established in the clinical routine yet. So let's go to the actual patients with a genetic risk. We know that patients with the increase of the incidence of ovarian cancer in the BRCA mutated population dramatically increases from the age of 45. Therefore, any prophylactic surgery should be done by then. There are some research groups, including mine, Imperial, that we try to detect precancerous cells in the fallopian tubes before the age of 40, and like we do, for example, with colonoscopy, with various bioengineered methods where we try to go into the fallopian tubes to detect these ticks. Is technically very difficult, especially if a younger woman wants to preserve her fertility and not to affect her tubes. It's actually very, very tricky. Where we have however, gone very far, and I'm not sure whether you can do it in Kazakhstan, but there are many centers and countries in Europe that do it, is the pre-PGD diagnostics, so the pre-implantation diagnostics. This is that the only embryo without the BRCA mutation are being implanted, so that the gene is not eternalized to the children and grandchildren of the patient. There is no discussion that Hollywood stars and VIPs who have the gene themselves have raised awareness of the genetic background of ovarian cancer. Breast cancer, saying it again, is a much more common disease, and the public and the awareness of the public around this disease is much more common than for ovarian cancer. Angelina, I remember when Angelina first had her bilateral cyclingophorectomy, all patients in clinic, they were coming to me and they wanted to have a genetic mutation. And it was back then in times where the NHS would not fund the genetic testing routinely yet. So let's go into some concrete pathways of how to do genetic testing in ovarian cancer in our clinical routine. So we have the mainstreaming of unselected genetic testing strategy. Currently, we do not select patients as long as they have a high-grade histology. And the reason for that is to better identify the risk groups without missing any, to have a better prevention and risk management, and at the end, reduce cancer cases and deaths. On the other hand, we know nowadays that it's not just important for the family, but also for the patient herself. We use the genetic mutation as a status of, as a surrogate marker of response to treatment. We know that BRCA mutated patients have a higher platinum sensitivity, have improved survival, are more eligible to some drugs compared to others, and have eligibility for some clinical trials. So it's not, the genetics testing is not just important for the family, but also for the patient herself, with crucial clinical implications. Just as an examples here, survival comes from the SOLO, Ariel 3, the NOVA trial, and many, many more other trials where you see a huge gap between the two curves. And you see that the BRCA patients, they benefit more from the new age, from the new generation of the PARP inhibitors. And that is why it is crucial that we can guide systemic treatment with an early genetic testing for our patients. And this difference is something that gets maintained over years and years and years. We know that even after 7 years, this is a very important SOLO-1 study, even at 7 years, almost 70% of patients who were on olaparib were alive, as opposed to less than half of the patients who were on placebo. So the question is, how can we combine the benefits of the genetic testing, of early genetic testing in ovarian cancer, with the challenges? We know that there is a very difficult game and play interaction between family dynamics, emotional impact and anxiety, confidentiality, stigmatization. It's something that is very, very important, especially in specific ethnic groups. And of course, we can't forget the cost effectiveness. We have the pathogenic variant carrier, which is the beginning, and then we need to talk with this carrier, but also with the family, about surgical prevention, medical prevention, screening modalities, lifestyle changes, PGD, and even when it comes to medicamentouse treatment, there are and screening modalities. We have to go from mammogram and colonoscopy to prophylactic surgery, routine ultrasounds, etc. So there is a big Pandora box that is being opened that we need to discuss with the patient before proceeding to any genetic test. So let's go and talk about the actual terminology. We have the germline variant, the tumor variant, and the somatic variant. Many people use many of those as synonymous, but actually let's go and have a look what are the differences. So germline variant is a variant in the blood of the patient, the blood sample or saliva. Tumor variant is a variant detected in the actual tumor, so it's a tumor testing. And without reference to the blood or germline sample, a tumor variant could be either germline or somatic. And then we have the somatic variant, which is a variant detected in the tumor sample, which however is not presented in the germline or blood sample. So yes, it might be in some cases that these two are synonymous, but are not always synonymous. The guidelines currently, nationally and internationally, are very coinciding. BGCS, ESMO, ASCO, SGO, they all say that all patients with a newly diagnosed ovarian cancer should be having a BRCA mutation testing for the non-mucinous ovarian cancer, and this is coherent in all guidelines. And what is very, very important is that all guidelines state and emphasize that it's not only the case for patients with family history. Regardless of the family history, these patients deserve a testing. So how do we test? There is a traditional method where you send the patient to the genetics team, the genetic counselor. There is the traditional counseling, face-to-face or virtual. Then the patient gets consented, tested, and gets the result. That is the traditional approach. However, what we more commonly now follow in ovarian cancer is it's a different pathway. It's the counseling of the patient is being done by the cancer team, not by the geneticist. We have even nurse clinical nurse specialists, surgical oncologists, medical oncologists who counsel the patient. They consent the patient. They do the testing. And only if the result is positive, the patient will go to a genetic counselor. So the genetic counselor is here at the end of the key chain instead of the beginning, which of course has massive implications for the less burdening of the system, because it's much more tricky to send a newly diagnosed patient to another team, to a geneticist, instead of just sorting everything within the team that they're already being treated. There is a massive impact and implication on the genetic profile of the genetic profile on the patient's journey, depending on the actual status of the patient. The patient will be eligible for PARP inhibitors, for anti-angiogenetic treatment, for a combination of both, or monotherapy. So it is important that we know the genetic results from the beginning so that we can tailor systemic treatment even better. So let's have a look at the timing of this testing. There is a very nice study from Ranjit Mahandra, who I have to thank also for this presentation, because he has shared with me some of his slides, and he's a pioneer in the UK in the genetic testing. He has implemented and introduced the signpost study. The signpost study is a very good approach, according to which a parallel testing, somatic and germline, is introduced. The findings of this study favor a prospective parallel panel testing to be the most clinically efficient strategy to maximize variant identification so that we don't lose time. And the UK genomics test directory criteria should be expanded to include a panel of ovarian cancer genes. So not just BRCA, but to have a broader panel of ovarian cancer. We see here the experience that has been published by Ranjit and his team on the example of 303 germline and 232 tumor tests, was that there is an LGR rate of 11%, and the causes of discordance in germline and somatic testing were in the reporting. There was a retrospective analysis that identified another additional 35% of pathogenic variants, and doing only somatic BRCA would miss 20% of pathogenic variant carriers. So these are huge numbers that we have to consider and we can't ignore in our routine practice. The somatic analysis failure rate was almost as high as 10% of samples sent for analysis, with a fragmented DNA and low neoplastic context. And this is something that we have to consider, especially after chemotherapy, neoadjuvant chemotherapy, which is the case in many patients with advanced disease currently, just because of tumor necrosis, extensive inflammation, where the genetic testing is simply not good. So beyond that, we have to consider, when we have a newly diagnosed patient, the logistics, the turnaround time. We in the UK currently need approximately, within the NHS, almost 2 months. So the patient is already more in the middle of her chemotherapy. Psychosocial factors, impact on the family, insurance, counseling, these are all things that we can't ignore. And we as gynecology surgeons need also to consider and need to be trained to be able to talk about. The sequence of testing needs to be, as we have said, parallel. Why is it parallel, and why do we all have to fight for that in our countries? Is that if we do a germline only, we may miss somatic mutations. If we do tumor only, we'll miss large genomic rearrangements. So it is a fact. So the ideal is the parallel, and therefore, especially in fora like today, where many people, international speakers and audience from all over the world is present, we really need to advocate the parallel testing for our patients. When it comes to somatic testing, there are some challenges. Again, having said, especially after neoadjuvant chemotherapy, the pathologists need to confirm more than 20% of tumor content. And in patients with a very good response, which are the BRCA patients, very often we operate them after 3 cycles and we see no disease, or extensive necrosis. So these patients will have missed, and they need a blood test in order to have their mutation diagnosed. So Yes, we talk about BRCA, but of course we can't forget the HRD. We know that approximately 50% of all high-grade serous ovarian cancers will have molecular aberrations that have the potential to confer to HRD. These are the most important genes. That's why we're talking about panels of genes and not just concrete, not just isolated genes anymore. And therefore, currently, this testing beyond the pure BRCA mutation is the way to go in our ovarian cancer patients. Yes, indeed, we need better HRD assays needed. We need tests with a better negative predictive value, and especially we need higher reproducibility and cheaper tests, especially in countries of not very high infrastructure or financial capacity. The very high costs of all this extensive panel testing is an issue that we cannot ignore and we can't close our eyes to. So health economic implications are very important. The comparative analysis of alternative courses of action in terms of cost and consequences need to be seen. And of course, we need to calculate the tests of the HRD, BRCA testing, of the PARP inhibitors, with the cost that we have of a patient relapsing sooner, needing more chemo, being more in the hospital, losing a workforce. So these are all things that we need to consider. And that is why internationally the consensus is that, yes, the way to go is to know more, identify the high-risk patients better, so that even though in the beginning it appears to be more costly, at the end it's more beneficial for the entire society. So all these are things that have to be put together and not to just see isolated the higher costs of an HRD test, because this would be very, very short-sighted. The benefits, again, in a very nice slide, all together summarize: surgical risk reduction, PGD, targeted treatments, embryo developments, genetic analysis, eligibility for clinical trials. All these are things that we can now offer our patients, which we could not do before. So what are the key messages of today? Is that the parallel unselected germline panel and somatic testing is the way to go in patients with ovarian cancer, independent of their family history. Testing should be considered and undertaken as soon as possible in the beginning of the journey of the patient and not at the end, just because of its massive implications. Cascade testing is offered to women with germline pathogenic variants, and this is something that we have to all fight to be in our package of care. Unaffected family members with PV or LPV variants should be offered screening and preventative options as per the national guidelines, and it's their choice how they wish to proceed, but at least they need to have the offer, they need to be offered this, and they need to have the option. Women with pathogenic variants in germline/somatic testing or HRD, they can be offered PARP inhibitors for maintenance treatment. There are still countries that rely heavily on that, where patients with a non-BRCA mutation, they would not have access to PARP, which, as we all know, is not the way to go, but it's still the case. So it is something that has opened many, many more doors, not just in the diagnosis and prevention of the disease, but also in its actual treatment. I'm open for questions. Thank you very much.
Okay, so the second talk is by myself, and the title of my talk will be the surgery and systemic therapy for the ovarian cancer. My first slide, please. Oh, get it. Yep. This is my disclosure. So when you talk about the ovarian cancer treatment, the basic concept is that the first step is that the identification whether the disease is early stage or advanced stage. And the definition of the early stage cancer, ovarian cancer, is the tumors are remained glossally confined to the ovary. And the definition of the advanced cancer is a tumor spread to the pelvis and the abdominal cavity or more the distant metastasis. So for the early stage cancer, which is the tumor glossary confined to the ovary, it's the role of the surgery is determination of the staging. Because there's the good number of the chance of the microscopic dissemination can be found by the comprehensive surgical staging. So I will show you why. What surgical procedure should be completed for the early stage of ovarian cancer later. So if there is a microscopic dissemination is detected, that means that the patient will be upstaged from stage 1 to stage 3 or 2, 3 or 4. And those patients need a chemotherapy. So the fundamental staging surgery contains that the simple hysterectomy, bilateral saphenophorectomy, infracolic omentectomy, and pelvic and periaortic lymph node dissection, plus peritoneal washings and peritoneal biopsy to the suspected region for the upper abdominal cavity. For the advanced ovarian cancer, the tumor has already spread to the pelvis and the abdominal cavity, so we really need a multidisciplinary treatment with the surgery and the chemotherapy is required. So, for the surgery, we say that it's a debulking surgery, but if it's not possible for the primary, the frontline setting. So sometimes we need to give the chemotherapy first, then do the interval debulking surgery. So the most important thing is that the chemotherapy is always required. So the timing of the surgery and the chemotherapy will be summarized as this: the maximum debulking effort followed by the chemotherapy, which is defined as an adjuvant chemotherapy, and the chemotherapy first to shrink the tumor as much as possible before the surgery. This was defined as a neoadjuvant chemotherapy. Then perform debulking surgery, which is the interval debulking surgery. So there's a lot of possible sequence. So you don't have to memorize, but the blue characters are the surgery, and the red characters are chemo. So when we look at the history, the trajectory of the ovarian cancer treatment advancement, the first one is surgical therapy. So the maximum debulking effort was not in a concept when I was the resident in 1980s. So this becomes possible because there is the technique of the surgical treatment, like a bowel resection and anastomosis is very, very, very easy now, quick. And it is now, you can do the diaphragmatic resection or the peritoneal the stripping without having the massive bleeding. And hepatectomy, it was disaster 40 years ago. It's the blood spread a lot, and you cannot safely resect the part of the liver, and also splenectomy becomes very, very easy. And also we had the benefit of the advancement of the anesthesia. 40 years ago, the general anesthesia in Japan was a kind of one of the most dangerous medical the procedures. So it's now you can do the surgery like 10 hours, 12 hours, very, very safely. It's very, very good. And also advances of the post-operative management using the ICU. So the circumstances dramatically changed from the 5 years ago. So primarily, so when we do the debulking surgery, this is very, very important, the concept. So primary debulking surgery is the gold standard. If you think that you can do it, you have to do it, okay? If the primary debulking surgery is deemed too invasive, so you can give the chemotherapy first, and then you can do the interval debulking surgery. But the most important thing is that targeting zero residual tumor at the end of the surgery, so is the most important, whether you are doing the primary or secondary or interval debulking surgery. The reason of this is if the residual tumor is not reduced to the zero, there is no differences in the prognosis of the patients from not performing the surgery. Okay. Let's look at the advancement of the anti-cancer therapy. So cisplatin was the first drug that make the situation of the chemotherapy for the ovarian cancer changed. And the carboplatin was developed in the 1980s. So this was mild for the side effects regarding the nausea, the vomiting, and the nephrotoxicity was much, much less, and the neurotoxicity was less. And it was found by the multiple clinical trials that regardless of the milder side effects, the carboplatin, the anti-tumor effect of the carboplatin is as same as cisplatin. Then, 1990s, paclitaxel was developed, and it was found to improve the prognosis when combined with cisplatin first. Then, even in the combination with the carbo, they found the equally favorable prognosis, and the side effect was reduced. So the current standard of the chemotherapy for the ovarian cancer is now the carboplatin plus paclitaxel as the backbone of the combination. So after that, it was established in 1999, and the development of the new treatment has been investigated, like a development more effective dosing method, like adding the third or fourth cytotoxic agent, or the Japanese investigator tried to find the dose-dense weekly paclitaxel dosing trials, and also intraperitoneal chemotherapy has been investigated. And also the development of new drugs, such as the bevacizumab, the PARP inhibitor, are the investigated. So I'd like to highlight first the developing the more effective dosing method. So adding another new anti-cancer drugs to the paclitaxel carbo did not improve the prognosis. It was shown by GOG 182 study in the mid-2000s. And the weekly dose-dense paclitaxel improved the progression-free survival and overall survival in Japanese patients, but it was not proven in the Caucasian patients. It was really unfortunate. And the IP chemotherapy, I will come back later. For the bevacizumab, the PARP inhibitor, the bevacizumab for the first-line treatment, prolonged progression-free survival was observed, GOG 218 trial and the ICON 7 trial, and OS was extended in the high-risk group in the ICON 7 trials. However, bevacizumab did not have the biomarkers to predict efficacy, so it has not become the absolute standard of care. And when we look at the efficacy of bevacizumab in ovarian cancer for the recurrent cases, platinum-sensitive recurrence was investigated by the GOG 213 and the OCEAN trial, showed the prolonged PFS. And the platinum-resistant recurrence, Aurelia trial, also shows the prolonged progression-free survival. Let's move to the PARP inhibitors. Probably you all may know, but I'd like to explain how the PARP inhibitor works for all the DNA injuries and the recoveries. So when we talk about the DNA injury, there is two injuries, single-strand break and double-strand break. So single-strand break is easily done when you're walking under the sunshine. The ultraviolet will damage your DNA on the skins. Okay, so single-strand break can be repaired by the basic excision repair, so that the cell survival can complete it. If the repair did not occur, double-strand break happened. So double-strand break is a little bit more, serious injury for the DNA. But there is another repair mechanisms called homologous recombination. And if it's not work, cell will die. So this will happen in the cancer cell too, okay? So for the basic excision repairs, once controlled by the PARP, the enzyme, and the homologous recombination is controlled by the BRCA protein. So thanks to the PARP and BRCA, DNA damage is being repaired. Okay. If the tumor cells have the BRCA mutation or the variant, the repair of the double-strand break does not occur. So if you give PARP inhibitor here, there's no way to the cancer cell to survive. This is the mechanism of the PARP inhibitor to kill the cells which has the BRCA mutation. So as Dr. Paolo has mentioned, approximately 50% has the HRD, which is homologous recombination deficiency. Among that, the germline BRCA mutation is about 15%, and germline plus tumor BRCA mutation is about 30%. And so the rest of them is, as Christina said, there's some genes that will they produce the homologous recombination deficiency. Okay, so let's look at the clinical trial results of the PARP inhibitor in ovarian cancer. Probably you have already know the Kaplan-Meier, so I just summarize what's happened. So for the frontline setting, in the SOLO-1 trial, which used the olaparib, was only tested in the germline mutation population. And for the PAOLA-1, olaparib plus bevacizumab was tested in the germline plus tumor BRCA mutation and HRD plus and HRD minus. However, the PAOLA regimen olaparib plus bevacizumab did not work for the HRD negative population. For the PRIMA trial using niraparib for the high-risk patients, they showed that the niraparib worked germline plus BRCA mutation and HRD positive and negative, so both population, all comers. So if I summarize for the frontline treatment, well, as I said, the top is a paclitaxel carbo, which is a backbone. And you can add the bevacizumab combination plus the 1 year bevacizumab, the maintenance. Or you can use the paclitaxel carbo for 6 cycles and the PARP inhibitors for 2 to 3 years as a maintenance. Or you can use the PARP inhibitors, the PAOLA-1 regimen combining bevacizumab and olaparib for 2 years when the patient has the HRD positive. Okay, so let's go back to the IP chemotherapy. Well, it is really my great honor that this IPOC trial has been published a couple of days ago in the New England Journal of Medicine Evidence. So, thank you. So this is my first talk talking about the publication of our IPOC trial results. That's why I wear this the traditional formal wear to show my respect to this Congress. Thanks so much. Okay, so in the summary, IPOC trial, I will show you why we said IPOC trial later. IPOC trial shows the long-term progression-free survival benefit of the IP chemotherapy for more than 5 years compared with IV chemotherapy. And the patient's population is not just for the optimal debulked, which is the classical the patient's population for the IP chemotherapy, but also for the large residual tumors, and without combining bevacizumab. These are the very important point. So this is the showing the evidence of the publications, and so IPOC trial is the randomized phase 3 trial of intraperitoneal versus intravenous carboplatin with a dose-dense weekly paclitaxel in patients with ovarian fallopian tube or primary peritoneal carcinoma. So the IPOC trial, that it means the intraperitoneal chemotherapy for ovarian cancer with carboplatin. So this is the trial schema. The eligible patients was the ovarian cancer, fallopian tube, or peritoneal cancer, stages 2 to 4, including bulky residual tumors. So those patients received the surgery up front and randomized, either after the surgery, randomized giving paclitaxel dose dense, plus carboplatin IV or IP. So this is only one variant. So, and primary endpoint it was the progression-free survival. Secondary endpoint included overall survival, toxicity, and the quality of life. And our accrual target was 645, and we needed a 511 events to analyze. And this was the international collaboration trial, including the Singapore, Korea, New Zealand, the US, and Hong Kong. So we have randomized 655 patients, and the 328 patients was randomized to IV arm, and 327 patients was randomized to the IP arm. So those patients are ITT populations. And after the the randomization couple of months or a year ago, later, we did the pathological central review, and we excluded the some of the patients because of the wrong histological type. So the MITT is a modified ITT, which means that the patients only has the eligible patients. Okay. So 299 patients in IV arm and 303 patients in IP arm. So if we look at the patient's characteristics, as you can see, the population was well balanced, and the figure, when we look at the figure stage, the almost 85% was the stage 3 or 4. So stage 4 patients was 80% for the both arms. So it's pretty interesting. Also, if we look at the size of the residual tumor, the 55% was more than 2 centimeters. So this is a very, very distinctive differences from the previous IP trials. When we look at the Kaplan-Meier curve for the ITT population, which is left-hand side, the hazard ratio was 0.83 and p-value was 0.041. And if we look at the right-hand side, the hazard ratio, which is the modified ITT, which is eligible patients, the hazard ratio was the better, and 0.878, and the p-value becomes 0.009. And the important findings is that after 5 years to 10 years, there's no effect of the so-called banana effect. So long we were able to obtain the approximately 7% more patients who achieved their long-term survival without recurrence. So I'd like to emphasize this, the result. However, unfortunately, the OS was not different. The IP is a little bit better, but probably this is because the secondary treatment worked well. And this is the forest plot. And as you can see, all the patients' population was in favor of the IP chemotherapy, regardless of the staging and regardless of the size of the residual tumor, and regardless of you're doing interval debulking surgery or not, and regardless of the histological time. So the IP chemo was beneficial for all the patient population we have tested. And for the safety, the table was so busy, so I just quoted the summary of that. There was the toxicities, like a vaginal anesthetic leak or other the port-related the toxicities. Those other than the AE noted earlier, that means the port or IP related toxicity. Adverse events excluding those related to the peritoneal port or catheter were similar in the IV or IPR. So when we look at the GOG 252 trial, which was published by Dr. Walker, JCO, the upper 2 arms are exactly the same as the IPOC trial, except for except for having the combination of bevacizumab. So there's no differences of the progression-free survival in the GOG 252 trial. And so I schematically draw the differences of these two trials. And as you can see, the differences are just having the bevacizumab or not. And another difference was that the proportion of the patients who were residual tumor larger than 1 centimeter in IPOC trial, 60% was larger than 1 centimeter. In GOG 252 trial, this was 6.9%. So if you look at the forest plot, the larger tumors a little bit better. So maybe this one is one component, but it's not the likely. We will say that the bevacizumab combination maybe screw up the IP trials effect. So how can we incorporate IKP chemotherapy? So IP carbo can be given for every ovarian cancer patient, regardless of after the primary debulking or the next setting, and regardless of the HRD status, probably, but not with the bevacizumab. What is the most appropriate PARP inhibitor? So everyone knows that PARP has a greater effect, probably depending on the approval status of the olaparib or niraparib, but for the all comers, so we can only use the niraparib. So probably my choice with the niraparib. So what's happened to the bevacizumab? We just rejected the bevacizumab for the first line. So when we look at the benefit of the bevacizumab in ovarian cancer, so this is a little bit busy slide, but if you look at the differences of the progression, the median progression-free survival month, first line, platinum-sensitive recurrence, platinum-resistance recurrence, the number itself is about same, like between 2.4 to 4.0. But if you look at the hazard ratio, you can see the benefit of giving bevacizumab is much larger in the recurrent setting comparing to the first line. So probably timing of the bevacizumab, I would say that considering the hazard ratio, the benefit from the bevacizumab is likely to be greater for the treatment at relapse than the frontline setting. And based on the EPOCH trial data, about 30% of the patients are cured with the first-line IP carbo, and taking into account that the result of GOG 252, the use of bevacizumab is not recommended. So it will, I would say, it would not be too late to use bevacizumab at relapse. We can preserve the bevacizumab. This is a great, good drugs, but we can preserve it just in case when the patient recovered from the IP. So the summary for the near future prospect for the advanced ovarian cancer chemotherapy, based on our trial, IP carbo plus weekly paclitaxel is recommended as the first line. It is effective in the adjuvant chemotherapy after the initial surgery or in the next setting. And a nearly complete cure in 30% without expensive drugs such as bevacizumab or PARP inhibitor, about 70% better than IV therapy. And combining bevacizumab is probably contraindicated for the first line, and the effectiveness of the combination with the PARP inhibitor to be studied in the future. And bevacizumab does not need to be used in combination with the first-line therapy and can be preserved in case of recurrence. The choice of the PARP inhibitor should be made logically. Well, thank you for your attention. If you have some questions. Okay, so if not, I'd like to move on to the next speaker. So, record it? Okay, so the next speaker will be Dr. Flor Beggs, talking about the borderline ovarian tumor.
Hi, I'm Flora Backus. I'm a professor and gynecologic oncologist at the Ohio State University Wexner Medical Center, James Cancer Hospital Comprehensive Cancer Center in Columbus, Ohio. Today, I'll discuss with you about ovarian borderline tumors. Thank you to the organizers for allowing me to present on this topic. Here are my disclosures, and none are related to this talk. So for the objectives today, I'd like to discuss the definition and evolution of borderline tumors, tumor characteristics, risk factors, treatment, recurrence, and surveillance. So how do these borderline tumors develop? So there's this phenomenon of papillary tubal hyperplasia, which is characterized by small rounded clusters of tubal epithelial cells and small papillae that can be with or without associated stroma bodies that are floating in the tubal lumen. We think that tubal epithelium can shed, lands on the ovarian surface. Then there's invagination of the tubal epithelium, like seen here, and that results in a cortical inclusion cyst that is lined by the tubal epithelium. If phenomena like these happen outside of the ovary, so when these kind of cells, these cells from the fimbria invaginate and lands on somewhere else, it's called endosalpingiosis. If we see chronic inflammation that leads to tubal hyperplasia, then can lead to papillary tubal hyperplasia. These areas then shed and implant on the tubal epithelium, like we see here with this regular cortical inclusion cyst, and can develop into a variety of low-grade serous proliferation. So when we look at that here, and this is a schematic of that serous tubal interepithelial carcinomas, or borderline tumors. So we see that cells from the tube lands on the ovary. If there's a tumor suppressor 53 mutation, we can see high-grade serous ovarian cancer developing. If we have these tubal hyperplasia cells or papillary tubal hyperplasia cells land on the ovary. These form an inclusion cyst on the ovary. If there's then that can then develop in an atypical proliferating serous tumor. And if there's a KRAS or BRAF mutation, that can happen and can then further develop into a low-grade serous ovarian cancer, which is quite rare. And it's even more rare to go from a low-grade to a high-grade tumor. So if this mechanism, which we think is true, basically means that all of the ovarian tumors, the low-grade tumors, high-grade tumors, and borderline tumors all originate from this fallopian tube epithelium. So let's talk a little bit more about these borderline tumors. They are about 10 to 15% of all epithelial ovarian cancers. They're also called atypical epithelial proliferation, or defined by atypical epithelial proliferation without stromal invasion. They're also called atypical proliferative serous tumor, or APST, or tumor of low malignant potential, or LMP. They're oftentimes diagnosed in early stage, but 70% are in early stage, and oftentimes in younger women. 30% up to 35% is diagnosed at age less than 40. The incidence is 5.5 per 100,000 women years. And overall, these tumors have a good prognosis with 5-year and 10-year overall survival rates of 95 to 97% for early stage. That does drop off a little bit for more advanced stage, like a 5-year overall survival rate of 77% for stage 4, for example. Most of these recurrences occur in the first 2 years, but there's also a risk of late relapse and up to even 15 years later. So these patients need long-term follow-up. The diagnosis is oftentimes just incidental. Either patients may present with new symptoms, or they have an ultrasound for abdominal pain, and that may show a cyst with papillary excrescences. These cysts can be solid or cystic. There's not really a true pattern to it, but if there are those papillary excrescences that may look like a cauliflower or coral, that can be indicative of a borderline tumor. Tumor markers sometimes are useful, most times are not, especially because a lot of these patients are in premenopausal women. So you can check a CA-125 or a CA-19-9, but it's only elevated in about less than half of the patients. Risk factors for these tumors are sometimes quoted as infertility drugs. So in the data really varies. In some studies, they have quoted an odds ratio of 1.86 for patients that have association with or have used infertility drugs, but most often it's with aberrant ovarian function. They're less associated with BRCA than invasive tumors, and it's really unclear if hormone therapy increases the risk. The majority is separated in 2 types, although you can also see some endometrioid or clear cell borderline tumors, but these are extremely rare. The majority really is serous or mucinous. So serous is about 50 to 70% of the borderline tumors. These are bilateral and about 15 to 25%, and have peritoneal spread in 15 to 40%. The risk of recurrence depends on fertility-sparing treatment, for example, also, but is quoted to be somewhere between 7 and 34%. Mucinous tumors are about 11 to 50% of the borderline tumors. They're more commonly unilateral and oftentimes large size. Peritoneal spread, however, is very uncommon, but there's higher risk of invasive disease if these patients relapse. We can also see patterns of microinvasion. This can be really confusing. So microinvasion is defined as foci of single cells, nest, or papillae that are infiltrating the stroma of the tumor, each focus measuring less than 3 millimeters or 0.3 centimeters in maximum dimensions. But there's also other criteria that are being used, such as a maximum dimension of 5 millimeters and a maximum area of 10 millimeters. The presence of microinvasion probably does not need to be reported, and lymph node involvement by these cells should not be diagnosed as metastases to avoid overtreatment or upstaging. So what do we do for treatment in these patients? Fertility sparing is very important, as a lot of these women will be diagnosed under age 40 and still of childbearing age and have an interest in future fertility. So we have certainly an option. So ovarian cystectomy is a very good option for serous borderline tumors. The alternative is a unilateral salpingo-oophorectomy. Definitely recommended if the ovary is massively involved or there's mucinous involvement with uterine preservation. The risk of recurrence with fertility sparing surgery is 7 to 30%, and it really depends on if you did a complete salpingo-oophorectomy or unilateral salpingo-oophorectomy or cystectomy. And if they recur, they mostly recur as a borderline tumor again and not as invasive. For postmenopausal women or women who have completed childbearing, not interested in that, a unilateral or bilateral salpingo oophorectomy is indicated with or without hysterectomy. And of course, removal of all peritoneal implants. All patients, whether they have definitive therapy or fertility sparing therapy, they should have a staging with an omentectomy, peritoneal biopsies with or without lymphadenectomy, plus or minus appendectomy if they have a mucinous tumor. And upstaging is seen in about 12 to 40% of the patients with a serous borderline tumor, but is quite rare with patients with a mucinous borderline tumor. Then a big question remains, should you do a completion hysterectomy with BSO after childbearing is completed? Well, there's a lot of factors that weigh into that. Certainly it's recommended for patients who were initially diagnosed with invasive implants but desired fertility sparing. And then a second factor is how long has it been since the patient was diagnosed? If the interval is short, maybe a couple of years, completion hysterectomy may be reasonable or advised. But if the patient was diagnosed at age 18 or 20 and is now 40 and still hasn't recurred, there's probably little benefit of still removing the uterus and tubes and both ovaries at this age. Also, we have to think about the data about the importance of ovarian preservation with healthy ovaries, that it's early or premature menopause is associated with shortened life expectancy, increased risk of increased cardiac disease, osteoporosis, symptomatic menopausal symptoms, and other risks. So this has to be carefully weighed. What about when you do a staging, should you include a hysterectomy or not? For those women who have completed childbearing, yes, a hysterectomy is oftentimes done and should be included here also, because the uterus can have some serious implants, which certainly I've seen in my own practice. There is a retrospective study that was done by Raimondo and was published this past year. And they looked at postmenopausal women that had a BSO with or without hysterectomy. They found no difference in disease-free or overall survival, and they had no uterine recurrences. There is an increased risk of recurrence with fertility sparing, but this is likely due to the ovarian preservation, such as with the cystectomy, rather than the uterine preservation. Thus, hysterectomy is not necessarily a part of the staging like that was mentioned in this particular study. However, as I said before, I certainly have had patients who we took to surgery and did a hysterectomy and found serous implants, not necessarily inside the uterus, but on the uterine serosa. So in a postmenopausal woman, I would still consider this. These are the NCCN, National Comprehensive Cancer Network guidelines that were published just in January of this year for ovarian borderline tumors. So oftentimes we see a borderline diagnosis not right at the time of surgery when we're doing it and maybe expecting it, but it may be found when a general gynecologist has taken the patient to surgery, removed the cyst with either cystectomy or oophorectomy, and then received the final pathology. So in these cases, there would be an incomplete staging or incomplete tumor reductive surgery or exploration. In that case, considering imaging, if it wasn't previously done, to evaluate for metastatic disease. If there is no residual disease remaining after the first procedure or on imaging, you could consider observation. If there is residual disease suspected after the first procedure and or on imaging, definitely want to proceed with a completion surgery of the contralateral ovary and uterus and resection of residual disease. But if the patient desires fertility, then fertility sparing surgery with unilateral oophorectomy, if there was just a cystectomy, but keeping the other ovary and tube, as well as the uterus in place if possible, but resecting or staging the residual disease. or you could consider no surgical intervention for select patients. Then you take a look at the pathology. So if it's final pathology and borderline, you would proceed with monitoring or follow-up. There's no further treatment or chemotherapy indicated. If low-grade serous ovarian cancer is found, you would go down the path and treatment for low-grade serous ovarian tumors. And if high-grade is found, of course, you go that direction. So how about recurrence risk? This is a little bit different between serous borderline tumors and mucinous borderline tumors. This is a meta-analysis, probably one of the better studies of 120 articles. And what they found after looking at 120 articles, 50 of these had qualitative and quantitative follow-up and qualitative and quantitative data, that the risk after conservative treatment was mostly related to stage. There was an unclear association with the micropapillary pattern and also with stromal microinvasion. The risk of recurrence of this was 15% when there was stromal microinvasion, and of those 15% that developed a recurrence, 35% had invasive implants at the time of recurrence. Again, most of these recurrences are in the first 2 years after diagnosis, but can be up to 15 years. And a progression to invasive carcinoma, that risk is low, about 2 to 3%, with a median time to progression of about 75 months. We've mentioned this a couple of times that the recurrence risk is higher after fertility-sparing surgery versus definitive surgery, but again, this has no effect on overall survival. Recurrences also appear to be happening earlier if you do a cystectomy versus a complete salpingo-oophorectomy. But an invasive recurrence that risk is very low, but 0.5% with early stage, whereas it is 2% for patients who have peritoneal implants. So still quite low. A little caution here for mucinous borderline tumors. There's a frequent coexistence between benign and invasive lesions in mucinous borderline tumors. So several experts have recommended to do a unilateral salpingo-oophorectomy rather than a cystectomy for mucinous borderline tumors. Also because they're frequently very large and may have other areas hiding in that very large ovary. Mucinous borderline tumors that also have intraepithelial carcinoma, those have a higher recurrence risk, about 6%. Of those, 2% are invasive and are associated with an increased risk of death when recurrence occurs. So to summarize it, and this is from the Dara and Maurice, a French paper that was a meta-analysis that we looked at earlier also, and they give very good guidance. So they propose, if we start at the top of the algorithm here, for a borderline tumor in a young patient who wishes to preserve fertility, if there are bilateral tumors, at frozen section, then do bilateral cystectomies if that's feasible, and peritoneal staging. If not feasible, you may have to do a unilateral salpingo-oophorectomy and then an ovarian cystectomy at the contralateral side, CC. For unilateral tumor and USO with peritoneal staging. And if there's a unilateral tumor, but it's not confirmed on a frozen section, then do a cystectomy if feasible and a USO if not. If the final histological results then show confirmation of the borderline tumor that is reviewed by a senior pathologist, and then we take a look at if there's high-risk features. And so they call those high-risk features, also listed here on the left side. So micropapillary patterns, stromal microinvasion, intraepithelial tumor or peritoneal implants. If none of these are present and there's no residual disease in stage 2 or 3 and no other risk factors, then we proceed with follow-up. If there are invasive implants or this high-risk borderline tumor, thus the serous tumor with invasive implants, serous tumor with micropapillary or micro pattern or stromal microinvasion, or a mucinous tumor with bilateral that's bilateral with intraepithelial carcinoma and stromal microinvasion. In that case, we want to consider a BSO or a USO with uterine preservation, and then considering fertility sparing options such as cryopreservation of oocytes or assisted reproductive during surgery or assisted reproductive techniques before completion surgery. Now, if there is a borderline unilateral tumor after initial cystectomy, then discuss a unilateral salpingo oophorectomy, particularly in a mucinous tumor, as we discussed, and staging if that hadn't been done according to the risk factors. So especially those patients with a serous micropapillary tumor who had an incomplete exploration or a mucinous tumor of intestinal type, we want to take back for an staging procedure. And in this last category, also for a mucinous tumor of intestinal type, we want to make sure that an appendectomy is completed. So what does follow-up or surveillance mean? This would be studies every 3 to 6 months for 5 years, then annually. A pelvic exam should be included, a pelvic ultrasound for those patients who had a cystectomy or fertility sparing surgery, where we take a look at the ovaries if there's any suspicious findings. Tumor markers can be considered, especially if this was a marker prior to surgery and was elevated prior to surgery. IVF for in vitro fertilization and assisted reproductive techniques are safe in early stage, but there's lack of data in advanced stage. And then hormone therapy in borderline ovarian tumors, that role is still clear, but appears to be safe. So in conclusion, this is a very rare tumor defined by atypical epithelial proliferation without stromal invasion. They're mostly asymptomatic, found as a cyst ultrasound, and fertility sparing for younger women is recommended with definitive surgery for postmenopausal women. Surgery is really the mainstay of treatment, and overall these patients have an excellent prognosis. Thank you so much for your attention, and this concludes my presentation.
Okay, thank you. So the next the presentation will be also the video, right? Dr. Chagatai from the Turkey will discuss about the HIPEC. So the video, please. Online? Oh.
Good afternoon, KG. I am here.
Oh, yeah, sorry. I thought it's
I am live,
video.
not video. Okay, no problem.
Yeah, go ahead and do your presentation.
Thank you. Thank you very much. And it is really a great honor for me to attend this nice meeting. And thank you very much for Dilyara Kaydırova and the organizing committee for inviting me. I will be there physically, but my patient on Tuesday had a brain emboli, a little bit problem. Because of it, I couldn't left her. Actually, cytoreductive surgery, and then HIPEC was planned. When we are passing to the HIPEC, we had an emboli. It is a life and a real life. Okay, I will try to cover and a little bit worse on the IP chemotherapy and the role of HIPEC. And we will discuss a little bit the HIPEC philosophy, the molecular and immunologic mechanisms behind it. And of course, we will do a critical review of the literature, especially covering the phase 3 articles and some meta-analysis. The ovarian cancer is really a peritoneal disease mainly, and most of our patients have a peritoneal spread, peritoneal recurrence, and they die of disease in the peritoneum. Of course, in some patients, we may have some extraperitoneal disease. Some of them die of a lung disease, but most of them, in general, die of a peritoneal disease. It is so important. And how we can deal with this local regional disease, we can do an important cytoreductive surgery, and together with a good chemotherapy, it could be even in the intravenous chemotherapy, but on the other hand, local regionally, we can apply an intraperitoneal chemotherapy or heated intraperitoneal chemotherapy, the HIPEC. Actually, when we give the chemotherapy intravenously, and there are some problems to reach the tumor sometimes, but if we apply the chemotherapy directly on the tumor, and there is no significant and the peritoneal barrier and the concentration of the chemotherapeutics within the tumor may be higher. And when we look to the IP chemotherapy literature, and Dr. Keiji Fujiwara summarized a little bit, but in the past we had a very significant studies. As a last time with Georgia 252, there is no significant advantage for the IP chemotherapy by using bevacizumab. And actually, after the publication of the GOG 172, there was a great increment in the word. NCI give a clinical alert, but never widely adopted in the US, even in the Europe, because of some problems related with the catheter and in some side effects. And when we finally came to the GOG 252, and after this huge study, including 1,500 patients, and by giving the bevacizumab, no advantage was seen with the IP chemotherapy. Of course, the IPOC study is so important, and we will learn many things. And when we dissect this article some more, and it is published in April 21 in the New England Journal of Medicine, again, Keiichi gave the details. When we put all together them, in IPOC study, there is a significant advantage for progression-free survival, but not for the overall survival. When we came to the story of the hyperthermic chemotherapy, what is the rationale behind it? First of all, it targets the peritoneal disease at the end of the operation. There is no barrier of postoperative adhesions, and there is no interval between the cytoreductive surgery and the chemotherapy. We don't wait at 3 weeks, 4 weeks, just at the same time, and during the operation we give the chemotherapy and the higher concentration at the disease sites. Therefore, it a little bit has a lesser amount of toxicity, and it may cause and achieve several different mechanisms on the tumor by DNA cross-linking. It may cause apoptosis. It may activate heat shock proteins, also inhibits DNA repair, and it may help a little bit more in the BRCA wild type patients. Dr. Keiichi showed you the mechanism of how PARP inhibitors, how BRCA works, and also it increased cytokine release, antigen presentation cells, T cell activation, increased blood flow to the tumor region, and promotes the perfusion. Actually, the hyperthermia have a very significant anti-tumor effect. When we combine the temperature and when we check the cell death, in general, it is the 41, 42 degrees are a good, and after 42, the toxicity increased too much. On the other hand, our cell death remains constant. Because of it, in general, it is we suggest to use at a 41 degree, 42 degree. After HIPEC, and the memorial group showed the cisplatin DNA adduct formation within the cell, and it is so important because they have a little bit synergistic effect, the chemotherapy and the HIPEC, and we see that there was a vasodilatation, immune cell response, which is very important, impaired DNA repair. This transient impaired DNA repair especially may help to the patients, BRCA wild type patients, without BRCA mutation patients, because we have many choice now in the homolog recombinant patients, BRCA mute patients, but on the other hand, the other patients, the PARP inhibitor effect is a little bit low, and the HIPEC may help for these patients. Also, we see an increased drug uptake. There are very important and the recent articles evaluating the mechanism and behind the HIPEC. One is that the Memorial Sloan Kettering group showed the transcriptomic changes when you apply the HIPEC, and they showed the heat shock related effect, and increment in the immune response, gene induction, etc. It is very important. In one another, and the very important murine model, mice model, and the cancer stem cell effect is shown, and they showed the cancer stem cells, and they decrease the effect continues for 2 weeks when you apply the HIPEC. And in one another study, again, in patients who are good responder to HIPEC, they showed very significant and the immune pathway upregulation and the DNA repair downregulation. It is very important findings. And the 1 month ago in SGO, again, very important murine model, the experiment and the equivalent group showed that the CD4 and the CD8 lymphocytes increase. This immune infiltrates persists for at least 2 weeks during the treatment, and the hyperthermia has no measurable impact in an analogous immune deficient models. The mice should be the immune prominent, and it is very important. If the mice is immune competent, the system works, but if it is immune deficient, the system doesn't work. Therefore, the hyperthermia has a very important immune effect, and it works on the by increasing the CD4, CD8, the immune presenting cell effect. Which one is the ideal chemotherapy for the HIPEC? Many studies, and mainly the cisplatinum is a very ideal chemotherapeutics, and also carboplatin has a very good effect, and when you use as a HIPEC drug. And in ovarian cancer setting, of course, we should discriminate the patients with respect to primary debulking, interval debulking, in recurrence setting, resistant and the sensitive disease, and also the palliative setting. And also the recording of the cytoreductive success is very important. The R0 disease, R1 disease is so important, and most of the HIPEC disease are mained on all these issues after the operation. The main goal is maximal cytoreduction without any residual disease. And also the drug selection, the standardization of the drug is very important. The type of the drug, the dosage of the drug, duration, and the temperature. When we are checking and analyzing any HIPEC articles, we should take care about all these issues in my previous slide, and the setting of the ovarian cancer, and what drug we use. When we check the literature in the RCTs, and we have especially main RCTs on the interval cytoreduction. The OHIPEC-1 is a very important RCT, the newly and the published Korean study, and the one close study, the Spanish study. These solid rectangles show you the RCTs, and there are 2 other important studies that I want to cover. First of all, I want to cover the OHIPEC-1 study, and which is the very basic and the important study, which is published in New England Journal in 2018 by the Wandriel et al., covering the stage 3 patients after 3 cycles of the neoadjuvant chemotherapy by using cisplatin together with the sodium thiosulfate to protect the renal function 90 minutes, and in the patients with no residual tumor. Actually, when we checked the patients, they were well balanced with respect to histological type and the dissemination of the disease and the achievement of the cytoreductive success, and the 70% of the patients do not have any residual, 20% of the patients have residual less than 2.5 millimeter, and the bowel resection between the 2 groups, and the well balanced. And when we check the time to the first adjuvant treatment, just 3 days more for the HIPEC group, and the hospital stays is 2 days more, and these are not a big numbers, and also the number of cycles are very similar. At the end, this study showed us a significant recurrence-free survival and overall survival advantage. Even overall survival advantage was more prominent. And when we check the adverse events, it is very important because when we are giving a new treatment to any patient, there should not be increment in the adverse events, and it is well balanced. And when we compare the grade 3 and the 4 complications, overall, they are very similar to each other. Before the OHIPEC one, there were several problems. There were several articles in the literature, but so complicated articles, and with respect to standardization, setting of the cytoreductive surgery, drug temperature, and the techniques, the numbers, so many problems. But this was a first good, well-designed article, and the NCCN in 2019 put the HIPEC into its guideline. It could be considered a given in the setting of the interval cytoreduction after 3 cycles of the neoadjuvant chemotherapy. When we check the PubMed, the articles exploded within the last 10 years. In the US, after this article, the usage increased, HIPEC usage increased dramatically. Of course, there are several articles, editorials criticizing these publications. They listed their criticizing points and the several questions, but most of them answered within the last 5 years. First is this small size, but especially it is a significant trial. And the GOG also announced their RCT in interval debulking setting with nearly with the same protocol, nearly with the same number of the patients. And the BRCA mutation study of the OHIPEC one published previous year, and the pool population is well balanced. And we learned one more thing from this article, that in BRCA1 like BRCA wild type group, as you see here, and the effect is more. It is very important. As we discussed in the mechanism, and the hyperthermic chemotherapy may cause a transient homolog recombinant in the wild type group, and this may increase the effect. Also, the Gemelli group published their article showing that if you don't use HIPEC, the survival curves of the patients with BRCA mut is better. But if you use HIPEC, there is no survival difference between the BRCA mut and the unmute patients. This effect is very important. And the HIPEC may convert the patients who are BRCA wild type behaving like a BRCA mut. It could be. Of course, we should have some more and the articles and the studies. The hyperthermia, therefore, may cause a increment in the BRCA1, 2, and the mutations. Quality of life is very important. This study is very questioned on that one. And when we look to the literature, OHIPEC 1 published their quality of life without any significant difference. Also, Korean group in their RCT, randomized control study, they didn't detect any difference in quality of life. Again, a month ago in SGO, in another phase 2 study, no quality of detriment and was shown. Therefore, we have 3 level 1 evidence that the quality of life for the patients after HIPEC don't worse. It is not worse. And also ERAS Society published their article on the hyperthermic chemotherapy area. And when we check the adverse events in OHIPEC 1, no difference. In Korean RCT, and there is no difference. And also in daily life, the Gemelli group compared their patients who are taking HIPEC, no difference. The time to start the adjuvant chemotherapy does not lengthen, and this is also very important. And also in phase 2 study of the Memorial Sloan Kettering, we don't see any difference. Therefore, we have now several different level 1 evidence that the adverse events also same. It is also very important. This is our article and the consecutive 100 patients. Again, the grade 3, 4 complication rates is around 11%, which is very parallel to the standard cytoreductive surgery. Again, this is our article, and it can be used in the COVID-19 era, and we continue to use HIPEC without any problem. One important issue that the HIPEC can be repeated. HIPEC after HIPEC. The Italian group published their 25 patients without any increment in the complication rates. Also, in our center, we have 9 patients and the HIPEC after HIPEC, 2 times who used the HIPEC and without increment in any complication rates. One another problem, and some group says that if you do a HIPEC, if you do a bowel resection, you should open a stoma. And in the OHIPEC one, we see that the stoma rate is a little bit high. But when we look at the literature, if we get together many articles, including us, and the stoma rate is around 10%, 20%, not high, even the Cleveland Clinic published their anastomotic leak rate article without any protective ileostomy, and they showed no difference when they compared the HIPEC and the without HIPEC groups. Therefore, of course, you can open ileostomy or the diverting stoma in the 10 to 20% of the patients, perhaps, but it doesn't. You don't have to open a stoma when you are using the HIPEC. The hospitalization is 2 days more, and not too much, and the cost effectiveness also one another issue that we know that today the bevacizumab PARP inhibition treatment 1 year more than 60,000 euros, and HIPEC equipments of course add some cost, and it is around 15,000 euros. And in United States setting, and when you make an cost effectiveness analysis, and there is no significant increment when you use the HIPEC in the numbers and the cost prices when you're using the memory slow and catering. Of course, if the HIPEC is used to decrease the peritoneal recurrence, we should see this effect in our articles. In the OHIPEC 1 trial and the consequent and the one another article, they showed that the peritoneal recurrence rate decreased in the HIPEC group. In the Spanish phase 3 study, which was closed prematurely, but we see that the peritoneal recurrence rate decreased 1/3. And the newly published in the IGCS New York meeting and the presented study Korean group also showed the peritoneal recurrences decreased 1/2. All these clues are very important. When you use the HIPEC, the peritoneal recurrence rate decrease. Therefore, when we get together all the criticisms of the first written against the OHIPEC 1 trial, now we have much more publications, much more, and the data and the answering all these questions. When we look at the second, very briefly, the Korean study, and this study including the primary debulking patients together with the interval debulking patients using cisplatin, again 75 milligram per square meter, 90 minutes, and the stage 3 and the 4. And when they checked all patients, there wasn't any survival advantage of the HIPEC. In the primary setting, no advantage for both the progression-free survival and overall survival, but for interval cytoreductive surgery group, they found a significant advantage for the progression-free survival and overall survival. The numbers were very parallel to the OHIPEC 1 findings. This is the second RCT level 1 evidence for the advantage of the HIPEC in interval setting. In the Korean group also published and they presented their study. This is multi-center prospective cohort study, not randomized. And again, in the interval setting, in the IGCS New York meeting recently, and again, they show the important advantage for survival. It is very important for PFS and the OS. And in the prematurely closed and the Spanish study, very few number of the patients actually, and they didn't show any survival advantage, but on the multivariant analysis, the patients with a HIPEC have a better survival rates. And when we check the primary cytoreduction, we are waiting some other studies. The Korean study didn't show advantage in primary debulking setting, but there is one very large and the Chinese study, case control study, showing advantage in this setting. Of course, this is not an RCT. We should wait the RCTs. When we came to the recurrent cytoreduction setting, and actually all the RCTs started with these studies. It was published in 2015, but it was not recorded to the clinical GO-TR, and the patient groups, including the platinum sensitive, resistant numbers are not too high. Actually, this study showed a significant survival advantage, but so many questions remained the study. The study findings getting popularized. But on the other hand, the Sloan Kettering performed an excellent, well-designed phase 2 study by using the carboplatin in platinum sensitive recurrent setting, secondary cytoreduction by using carboplatin, and they did not show any survival advantage in this setting. This is the first good, well-designed study in recurrent setting. And when they compared the complication rates, they didn't show any important difference between them. So many reviews and the meta-analysis was performed because the HIPEC is a very, very hot topic in the literature. And in the first meta-analysis, Luis Chua group did not show any survival advantage. But after that, we have many meta-analyses, and the very recent umbrella review of 6 meta-analyses showed that significant advantage for both the progression-free survival, overall survival for both the primary setting and the secondary setting. And of course, we should wait the other studies. And again, very recent meta-analysis showed a significant advantage. And the Christina Fotopoulou, Rob Bristow, Korean group, and the Lim, and they made one another meta-analysis. They showed that if there is recent exposure to the chemotherapy, and there is a survival advantage, as you see in these figures. If there isn't any recent exposure to chemotherapy, there is no difference. And also our recent study, we showed that the HIPEC don't work in the platinum resistant setting, and if the disease relapses several times, if there is too big ascites, and its advantage is much less. Of course, all these are not RCTs. The HIPEC usage in rare ovarian cancer is one another issue, especially for the mucinous cancer. There is no too big literature, but the French group published their experience on more than 70 patients with mucinous histology. As you see here, they published nearly the 70 months of median survival, which is very good, I think. And they also very recently, the MD Anderson group report a case report by using 200 and the milligram and the cisplatinum per square meter, very high dosage, and they used this usage and they didn't give additional chemotherapy. They have an excellent survival advantage. There are several ongoing studies. First of all, this is very important, OHIPEC-2, and this is for the primary setting with patients more than 500, again, directed by the Dutch group, and the GOG interval debulking setting group. They have started and launched this study. Many ongoing studies. Some of them are closed. We are waiting the results, the pink ones, and some of them are ongoing. We will learn many things within the following years. We are also in Turkish group, and they collected our more than 400 groups and the patients. We are analyzing and these patients, and we will see. In conclusion, first of all, again, today, the current NCCN guideline still put a place for interval setting for the HIPEC. This is very important. Now, as you see here, the solid rectangles, we have some clues for its advantage, especially for interval cytoreduction setting. And we are learning many things from the experimental studies, human studies, and within the last 5 years. And when we look at the adverse effects, again, we have several level 1 evidence. There is no increment in complications, no delay of subsequent chemotherapies, no increment in stoma rate and the leak rate in our patients. to whom we can give the HIPEC. Now in interval disease setting and the interval debulking setting, we can use it. But of course, we will learn many things in the setting of the bevacizumab, PARP inhibitor, immunotherapy settings, and with the very, very new RCTs which are ongoing. Some of them are closed. Thank you very much for your attention, and we are waiting you to the ESCO meeting in Istanbul. Thank you very much.
Thank you, Dr. Chagatai. We have the number of the questions, but unfortunately, we are behind the schedule. So I'd like to discuss it either in the ESGO or the IGCS in Seoul. Okay, thank you so much.
Thank you. Thank you.
Now I'd like to welcome Dr. Jubilee Brown. So the title of her talk with the complications after surgery and the chemotherapy. Sorry.
Thank you, no worries. Great, fantastic. Thank you all so much. Again, thank you for to the organizing committee. This has really been just such a fantastic conference and such a wonderful time. So I'm pleased to speak with you now about complications after surgery and chemotherapy. It's a lot to put into 20 minutes, so there's no way I can be completely comprehensive with this. But I'm going to review surgical complications as it relates to urinary, bowel, vascular, and neurologic complications, understand complications after chemotherapy, and examine preventive strategies for both. So there's so much information in this topic that this will be almost like a snapshots of complications kind of talk. So let's start with surgical complications, and we'll start with urinary complications that can happen. Of the urinary complications that can happen, I would choose bladder over ureter. So we'll start with bladder. The incidence of injury during laparoscopic hysterectomy ranges, it's pretty rare now as we've gained more experience. So overall in the literature, there's less than a 1% risk of injury during laparoscopic hysterectomy. When we split it out, bladder for ureter, that can go up to 1.8% for the bladder. It does not appear that there is an increase in the rate for cancer-related surgery. Most often, these injuries are due to cystotomy, but can also be due to devascularization or to intravesical suturing. The most important thing is to identify the injury intraoperatively. You should suspect this if you can directly see the injury, or if you see the Foley balloon, that's generally a bad sign, or if you look at the Foley bag or your anesthesiologist or circulating nurse notes that there is air or blood in the Foley bag. Air in the Foley bag means that your laparoscopic carbon dioxide has found that path of least resistance through the bladder and out into the Foley bag. So generally speaking, if you see your Foley bag blown up like a balloon, that means you have a bladder injury. If you see urine in the surgical field, also you should look for that. And how do we look? Well, typically we can do cystoscopy for bilateral ureteral jet efflux. Some people give peridium beforehand so that they'll see any injury. The other thing that you can do is basically retrograde fill the bladder, and you can use any kind of dilute methylene blue or indigo carmine that you instill into the bladder. Some will use sterile milk as well. I don't tend to do that. Things that have been reported, but I think I may have done one intraoperative IVP ever, that you can use that. However, you can use retrograde ureteral dye with fluoroscopy and also place stents in order to evaluate the extent of your injury. Once you identify the injury, if it's in the bladder dome, a very tiny, less than 2 millimeter injury, you can simply manage that expectantly. It doesn't require a suture, though if you see it, I usually close it. It's pretty easy to throw a suture. If the injury is less than 1 centimeter, you have the option of a repair or a Foley for 7 to 10 days. This always sounds like, why would you not repair this? But considering that suprapubic catheters, when we remove that catheter, we don't routinely repair that small injury, and this is the same principle. Anything over 1 centimeter definitely requires repair. When we repair any type of bladder injury, it's done with 2 layers of absorbable suture. Typically, we use a 3-0 as a first layer and then a 2-0 absorbable suture like Vicryl or Monocryl. You can also use PDS, though I never have. I've always used a more rapidly absorbable suture. Barbed suture actually is fine, and laparoscopically, that can make it much easier. You can also, after you do this, do a retrograde fill to ensure that the repair is intact. There's very limited evidence for postoperative antibiotics, so these are not absolutely required after repair. Now, a ureteral injury is, of course, more challenging. These can happen due to crush, kink, ligation, laceration, transection, a thermal injury, or devascularization. And so I think identifying where your ureter is located is always the key. So I think the prevention is, again, always find the ureter. And I talk to all of my residents about this. You absolutely, every case, even for easy cases, you must identify the ureter. And the easiest way to do this is to open the retroperitoneum, look on the medial leaf of the broad ligament, and typically the more cephalad you go, the easier it is to identify the ureter. The other important thing to avoid injury is whether you have a uterine manipulator or a sponge stick in, push up on the uterus at the time of hysterectomy. Also, be aware of your degree of thermal spread depending on the instrument that you're using. If a ureter gets clamped, the first thing to do, of course, is remove the clamp. Then inspect it for integrity. Most injuries, you will want to place a stent for somewhere between 2 and 6 weeks. If there's been significant injury to the ureter, one would place a drain for at least 1 week. And if it really looks like the ureter has been devascularized, you may require reimplantation. I will say that ureteral injuries are remarkably rare, but I actually had one about 2 months ago, and this is that patient. You can actually see with her CT, you can see the dye as it's coming, you can see that little arrow, the dye coming out of the ureter on scan. And this was actually a patient who had just a terrible amount of an ovarian carcinosarcoma, massive dissemination of disease, and I think her ureter just got devascularized because this was a delayed injury. So let's switch to bowel complications. If you have a bowel injury, of course, it's important to identify these intraoperatively. If these go unrecognized, the mortality is significant, between 3 and 21% in the literature. Bowel injuries usually occur during adhesiolysis and rarely during a trocar insertion. If a patient comes back, and literally if there's any phone call that you receive from a patient after laparoscopy, you should see that patient back in your office and have a very low threshold for imaging. That's our policy in our office. Any phone call wins them an appointment. So we suspect injury if there's pain, fever, obviously peritonitis or sepsis. Bowel injury, even that you identify at the time of surgery, you repair with a 2-0 interrupted suture, typically a 2-layer repair, perpendicular to the axis of the length of the bowel. You want to avoid constriction, and that's the best way to do that. If it's a substantial enough injury, then you may wish to resect and reanastomose the bowel. Typically, we use stapled reanastomoses. And if this is a large bowel injury, there's evidence certainly for antibiotics and a diverting proximal ileostomy. Vascular complications. So beware at the time of your trocar injury, keep the table flat. If the patient is thin, we typically go in with a 30-degree angle with your trocar. Or you can certainly do an open entry like a Hassan technique. Even if you're going to use a small trocar, you can do an open entry. In the very unlikely and unfortunate setting that you would have an injury to one of the great vessels at the time of injury, that really requires an emergent laparotomy. Hold pressure immediately, give fluids, call for blood products, alert anesthesia, have excellent IV access, and call for help with vascular surgery. Some may have the ability to repair this, and that's fine. If it's a venous injury, I'll repair that. But the issue is you don't want to get behind because mortality can happen extremely quickly, especially with an arterial injury if there's an aortic injury. Several people have proposed algorithms, and so I included one here, but I think the bottom line is those steps that I've listed. Typically, the repair of an injury should be with something that's small, like 4-0 or 5-0 proline. Neurologic complications have been documented in less than 2% of cases, and these can most often be compression injuries due to positioning. So we're very, very careful to position and pad in order to avoid stretch or compression. And the hip and knee flexion and abduction are extremely important, as you can see. Also extremely unlikely, but it happens occasionally, is an obturator nerve transection. I've had one in my career of 25 years, and it happened because I deviated from the plan. Never deviate from the plan. Always use central midline imaging when you look for your structures, and always, always identify the obturator nerve when you're in the obturator space for a nodal dissection. Identify the nerve before dividing any tissue. If you do transect that nerve, you can use something like a 5-0 proline to reapproximate it. Each of those patients will require physical therapy and pain control, but most patients do have full recovery of function. And hopefully this will play. So to prevent injury, you have to know your anatomy. So this is a patient of mine where we were on the right side of the patient. We did a full dissection so you can see her uterine vessels, the pararectal space, and medially there on the left, you'll see the ureter peristalsing, vermiculating. Here you see the paravesical space with a superior vesical artery there and the obturator nerve laterally in that obturator space. So identify all of these structures all of the time. So we're going to switch away from surgery, and now we'll talk about chemotherapy. So hypersensitivity is something that we see sometimes from paclitaxel. That typically happens with a first cycle, whereas platinum is delayed with a median of 7 prior cycles. I've included in the slide set the algorithms and the mechanisms to treat hypersensitivity reactions, as well as to desensitize patients. That can be done orally with the pre-medications that you see, and with chemotherapy escalation. Whether it's paclitaxel or carboplatin, we use a very dilute solution and over time escalate up. This typically takes many hours, but is remarkably successful with over a 96% ability to get the chemotherapy in. We also see myelotoxicity, and there are very specific rules for when you should administer growth factors. So you can use prophylactic colony stimulating factor if the patient's risk of febrile neutropenia is over 20%. Typically, if neutropenia occurs, first we'll dose reduce or delay, but you can use prophylactic CSF in subsequent cycles. We do not treat neutropenia with growth factors, if the patient is afebrile. But you can see that we do use growth factors to treat febrile neutropenia if they're at higher risk. Thrombocytopenia requires platelet transfusion only if the patient is at less than 25,000 or is bleeding, but does require a decrease in dose and delay of therapy. Nausea and vomiting is perhaps the most common complication that we see from the chemotherapy that we use in gynecology. Cisplatin especially is highly immunogenic. And there are a number of different options that we have for treatment of and prevention of nausea and vomiting. I've added here the doses and the options for immunogenic control. We typically use moderate immunogenic agents such as ondansetron and dexamethasone in our patients who receive chemotherapy. Neuropathy is also very common, especially with paclitaxel that we use, and this is chemotherapy-induced peripheral neuropathy. This occurs in up to 68% of our patients, and so we ask every single time if the patient has a loss of sensation. There are a number of different things that have been looked at, but really not a lot works. For chemotherapy-induced treatment, you can give duloxetine, and actually there's an article out there about photobiomodulation. I have one patient that has actually used this, and it's actually helped her. We also use glutamine. I use glutamine as a supplement for patients with this. And there's very little evidence actually for anything else. Now, immunotherapy-related neuropathy is different. If you have a patient on immunotherapy, they can have a neuritis. You need to hold immunotherapy and give steroids. Cardiotoxicity, we can see with some of the occasional agents that we use. We follow these patients with echocardiograms and typically discontinue therapy until their cardiac function recovers. Again, immunotherapy is different. We want to give steroids, immunosuppressives, until that cardiotoxicity resolves. And it's a little scary to re-implement immunotherapy after cardiotoxicity. In the literature, people have, I have not. I've included some different sort of summaries of the types of cardiotoxicity that you can have with the different agents. And some of the targeted agents that we use do have significant cardiomyopathy that we need to look out for. Immune checkpoint inhibitors actually can affect the heart in many different ways, as you can see, including a pericarditis. Now, dermatologic complications also can happen. We see stomatitis with many of the things that we use. Allopurinol and vitamin E have been utilized in the literature. We routinely utilize Magic Mouthwash, which is a combination of lidocaine, diphenhydramine, and aluminum hydroxide. And it's very soothing. There have not been any articles that have actually been able to show an improvement, but it does seem to help patients feel better. Other dermatologic issues can occur with some of the MEK inhibitors, and you can see this papulopustular eruption. This was a patient of mine who went to see our dermatologist for this. Things like sunscreen and moisturizer help with photosensitivity. Prophylactic steroids can be useful, including topicals, and prophylactic doxycycline is really essential. We start every patient who receives a MEK inhibitor on prophylactic doxycycline. It's been noted that patients can take dilute bleach baths, though I've never had a patient utilize this. GI toxicity, you can see here, this is findings at the time of colonoscopy. Anti-CTLA-4 drugs appear to have more intensive GI colitis. And the diagnostic workup is listed below. We want to exclude things like Clostridium difficile, and we want to perform endoscopic evaluation if a patient has grade 2 or higher toxicity. Most patients do respond to corticosteroids when these are immune related, and we just need to be very careful because significant colitis can actually be mortal. Checkpoint inhibitors can cause these other types of rashes, and these are all my patients. These are serious side effects, so we want to make sure that we withdraw the agent, administer steroids, and give oral antihistamines as well, and with time, these do resolve. Endocrine issues are significant with thyroiditis and hypophysitis, also diabetes and primary adrenal insufficiency, so we need to be aware and screen with appropriate testing, then replace thyroid hormone and corticosteroids as needed. Hypertension occurs with a number of treatments, but especially with agents like bevacizumab. Up to 22% of our patients have grade 3 to 4 hypertension, but this resolves in about 82% with treatment. Bowel perforation is the scary one, and that can happen with bevacizumab in up to 3% of patients. We avoid utilizing these drugs in patients who have significant bowel involvement because then the risk can go up to 15%. These have about a 12% mortality if this occurs. PRES is very rare, can occur from bevacizumab, and you see headache, seizures, altered mental status, and visual loss, and about 15% of patients do have some permanent disability and mortality. Basically, therapy is supportive care. Ocular toxicity is new with mirvetuximab and tisotumab vedotin. We see blurred vision, ocular pain, and the actual pathology is different. But typically, the regimen of topical steroids, lubricants, and vasoconstrictor drops with cooling masks can be useful in prevention and treatment of these issues. Each of the inserts has detailed guidelines on how to prevent and treat these findings. The other thing to be aware of is a motor neuropathy that you can get with tisotumab vedotin. It's different from the peripheral neuropathy that we see with paclitaxel, and about 8% of patients do have some degree of motor neuropathy with tisotumab vedotin. I know that's a ton of information, but I'd like to thank all of you. And I don't think you've seen a place of where we come from. This is our place in Charlotte, North Carolina, along with the bottom right, which is going to be our new medical school and EarCAD location. So we'd welcome any of you there anytime. Thank you so much.
That's great. Thank you so much. This is a great summary of the surgical and chemotherapy complications. So now the time of the tumor board. I'd like to welcome the best tumor board organizer in the world, Dr. Wendell Naumann, and also I'd like to call the Yellen Cookback-Cliff. No? Oh, Wendell is the only person to come.
Is he not going to come up? And we have our pathologist, yes.
Okay, good.
Come on up. Come on up. You can come up, yes. Yeah. Can we have the slides on the monitor? Thanks. Can we get the slides on the monitor? Thank you. All right, so our first case, and I'm going to put you guys on the hot seat since we don't have ARS, so you guys get to answer the questions. So this is a 48-year-old woman, and she presents with ascites and a pelvic mass. Her CA-125 is 287. She has a normal CEA. She has an 8-centimeter mass with omental caking. And an omental biopsy shows a low-grade serous cancer, and you can see the pathology there. And again, this is a little more than the borderline tumors that that you see on the left. This is a true low-grade cancer. And do you want to comment on the pathology here, on the low grade? Distinguish it from the high grade?
Indeed, on the right, we have high-grade SOC, we have nuclear A-type and A-type mitosis, and we see the nuclear non-typical structure, which is typical for low-grade SOC.
So yes, so the cancer is low grade. These are generally driven by mutations other than P53. For many years, these were included in all of our studies of ovarian cancer, just as grade 1s, and we find that they're very different entities and respond very differently to other agents. So as our high-grade cancers come from P53 lesions and stick lesions, these lesions come from the same mechanism that borderline tumors come from, we believe, with increased mutation and invasion into the tissue. But they're real cancers. So is this somebody you would give neoadjuvant chemotherapy to, or would you take them to primary debulking? Yeah. Yeah, so
Primary debulking will be an option.
Yeah. So I don't think this is a candidate for neoadjuvant chemotherapy. So she has a debulking surgery, and all visible disease greater than 1 millimeter is removed, but she does have some peritoneal implants that are less than 1 millimeter. So here are your treatment options. So no treatment. So you can treat her with chemotherapy. You can treat her with chemotherapy followed by an aromatase inhibitor, or you can treat her with an aromatase inhibitor alone with very small volume disease. What would you do? No treatment?
Maybe carboplatin and paclitaxel 6-followed course with inhibitors of aromatase.
Yeah. So yeah, I think this is going to change. The standard of care is probably toward chemotherapy, but we'll talk about the data on that. So she was treated with chemotherapy, standard of care, and this was followed with an aromatase inhibitor. She does well with the treatment. CA-125 comes down to 15. 38 months later, her CA-125 starts to rise, and the CT scan shows multifocal recurrence, not amenable to surgical resection. So after 38 months, now what do? She's already had chemo. Do you give her chemo, just platinum-based chemotherapy with bevacizumab alone, or hormonal therapy? She's already seen an aromatase inhibitor. Thoughts on that?
So I guess it wasn't due to this talk, so maybe hormonal therapy would be fine for her.
Mm-hmm. Dan, what would you do?
Maybe it's the second variant, platinum-based chemotherapy.
Yeah. Back to chemo with the bevacizumab? Yeah. There are no right answers here, sir. We'll find out. So, when we think about the carcinomas, we now have a dichotomous view of these, the high-grade serous carcinomas and the low-grade serous carcinomas. We know that low-grade serous carcinomas are in the 5 to 10% range, so they're relatively rare. And generally in the old system, if you look at the literature, the grade 2 cancers were generally higher grade cancers and P53 driven. And the median PFS and OS are generally different, but the low grades will progress and can be fatal. So they tend to have a lower mitotic index and they look different under the microscope. If you look at the natural history of low-grade serous ovarian cancer, you can see these curves. Our patient went out 38 months. You can see for somebody with minimal residual disease, the median survival is about 30 months. For R0 resection, many of those patients go very long and probably are cured. So we do cure a significant number of the low grades. So I think maximal surgical effort is important in this case. Dr. Gershenson did a retrospective analysis of the cases at MD Anderson. And this was, the patients were all treated with chemotherapy because that was the standard of care at the time. And whether they had R0 resections or R1 resections, the PFS was better in the blue line when patients were treated with the hormonal therapy afterwards. They found the same for the overall survival. So it did appear that hormonal therapy following chemotherapy did improve overall survival. This was the vast majority of these people were treated with letrozole, although some received tamoxifen and some other types of hormonal therapy, including GRNH agonists and progesterone. So we know that these chemotherapy is less effective in terms of response rates. In low-grade serous carcinomas, the response rate has, to chemotherapy has ranged from anywhere from about 6% to 30% in clinical trials compared to 80 to 90% for the high-grade cancers. So one of the questions we are asking in the GOG is chemotherapy necessary? And as Dr. Brown mentioned, this is GY019. We actively are recruiting patients. It's about halfway recruited, where we are looking at a non-chemotherapy regimen with hormonal therapy alone. And we've used this occasionally, particularly for people with very low volume disease, although we need to confirm that that is a reasonable approach. And so hopefully we'll have this information soon. So what are our regimens that, as was mentioned, we talked about bevacizumab. Bevacizumab alone has a reasonable response in low-grade serous cancers, and these are two relatively small studies that have shown that the response rate to bevacizumab is in the 40 to 50% range, and many patients will have stable disease. So the median PFS is in the larger study was about 10 months. Median OS was just shy of 3 years. We know that these are driven by mutations in the PI3K pathway, particularly KRAS. And all of these can be targeted now, so we have medicines to target, although RAS is a little bit harder to target. All the downstream mechanisms are targetable. There is a report of letrozole and everolimus, a combination that we use in endometrial cancer with similar mutations. This was in high-grade cancers. It was 16%. We don't have anything published in low-grade cancers, but we know that it's effective in ER-positive endometrial cancer cases with a response rate of about 46%. So it'd be interesting to see what this looks like in low-grade cancers. There are a few case reports of CDK4/6 inhibitors with anastrozole, so that would be a combination, a hormonal combination. Dr. Brown talked about the MEK inhibitors. Again, there is some response to low-grade serous cancers with MEK inhibitors. Although, at least in the MILO trial, it did not beat standard of care chemotherapy. Because the patients responded fairly well to chemotherapy. There's no difference in the PFS or the OS between these two groups or overall survival. But you see the waterfall plot, the blue represents the MEK inhibitor, manitinib, and the orange is the chemotherapy response. So you do have some responses for patients with these agents. But again, as was pointed out earlier, the patients had with KRAS mutations didn't have a difference in terms of outcome with chemotherapy, but did have an outcome with the MEK inhibitor. 281, again, this was already discussed, but again, trametinib is a reasonable option for these in terms of a MEK inhibitor, but they do have a fair amount of rash, and it's not particularly well tolerated. And again, this effect was really across all of the different groups that were in the sub-analysis group. So I won't go over this. But again, if you look at the trametinib group, the MEK inhibitor, and you look at the overall response in the right lower portion of the slide, compared to standard of care in KRAS mutated patients, the response rate was 15 times higher than in the chemo group. So how can we overcome resistance? One of the problems with the PI3K pathway is that if you inhibit something, you get a compensatory response, and it's very difficult to block this. And so if you look at the targets here, if you inhibit MEK, what happens is you get an increase in expression of RAF, which increases the downstream effects. So there is a compound that's being tested. This only has a number right now that blocks both MEK and RAF. The problem is when you block both MEK and RAF, you get an upregulation of an enzyme called FAK. FAK is a non-receptor tyrosine kinase, and it does have immune function and downstream target in the PI3K pathway, but we have a blocker of this called defactinib. So one of the interests is going to be combining both of these agents in terms of preventing growth. So we're very excited about this. In the initial trial, they had a 52% response rate with this combination, and then the RAMP 201 trial is going to be our confirmatory trial with the combination, and that's going to be a randomized trial to look at this, particularly in the KRAS mutant patients. Dr. Brown mentioned the Bouquet trial, so we have some other trials looking at other agents based on the mutations in the pathways. So anyway, let's, since we're behind, I'm going to move on to the second case. So this is a 39-year-old woman, left ovarian mass, ascites. She has a hysterectomy. The mass is leaking at the time of surgery. There are some inflammatory changes, but the biopsies of the peritoneum are negative, and all gross disease is removed. This turns out to be a stage 1C3 granulosa cell cancer. And this is the gross. You can see it was leaking at the time of surgery, and there was a very inflammatory change in the mesentery. Would you like to comment on the pathology for this? It's a little atypical for a granulosa cell.
Single lateral tumor, granulous cell, trabecular composition consists of more or less monomorph cells without expressed atypia. In stroma, there are fibrous layers, and I think this histological pattern is characterized by a granulous cell mature type of
So first of all,
tumor.
In the surgery, do you do a lymphadenectomy routinely with granulosa cell cancers?
Well, if those are not epithelial tumors, then...
I'm sorry?
I mean, if they are not epithelial tumors, we're not doing systemic lymphadenectomy.
Yeah, but so the cancer was limited to the ovary, it was leaking, so it's a 1C3.
1C3 cell.
No?
No.
No? Okay. Would you observe her? Would you give her BEP? Or would you give her carboplatinum and paclitaxel? Yeah.
Yes, carboplatin.
Okay. So we talked about that a little earlier. I think that's certainly a better choice, and we'll talk about the data on that. So she does well for a long time, as many of these patients do. She was actually treated with carboplatin paclitaxel. She did well. But after 42 months, her inhibin starts to rise. And a CT scan shows a lesion in her liver. And at the left UVJ, you can see on the CT scan. So her PET was actually, if you look at the PET, it was not active on the PET, which I thought was interesting. So would you observe her, since you can't biopsy this? Would you surgically resect it, or would you give her a systemic chemo?
Well, maybe I'll try to resect it. And then
Yeah. How do you do the liver lesions? How would you approach the liver lesions? Would you try to do a partial hepatectomy, or do you RF?
So it depends on the.
Yeah. Do you use RF if you can't resect them? Ablation? Yeah.
Ablation is available.
Yeah. Yeah. So I think that's certainly reasonable. So we were actually able to resect this laparoscopically, and we at our center use microwave ablation as opposed to radiofrequency ablation. So we got her down to R0. We did washings at the time, but they were positive. So what would you do with the positive washings? Would you observe them? Would you give her chemo, bevacizumab, chemo and bevacizumab, hormonal therapy, or like a GRNH agonist?
Maybe chemo, my budget would be fine.
Platinum-based chemotherapy.
Yeah, okay. So we actually wound up putting her on letrozole. She did not want to go on chemotherapy. She was noted to have an increasing inhibin from a nadir of 12 to 43. And this was 14 months later. And her CT scan is negative for recurrence. What do you do now? Same choices.
Maybe observation, so and we'll do something when something appears.
Yeah. So she's very nervous, I can tell you that. But Darren, you agree?
You can understand her well.
All right, so we observed her, and so I talked her into no treatment, and then we did another CT scan, and she's got a recurrence in the pelvis. Her inhibin is up to 164. We actually were able to resect that, but at the time of surgery, she did have unresectable miliary disease. So now she's been treated with chemo and letrozole. What would you choose here? You got non-measurable disease.
Actually, it's a real difficult question for surgeon. I don't know. I understand that by oncologist.
Any thoughts?
Maybe we must provide that chemo.
Yeah. So we actually, this lady went on bevacizumab, and that's what she's on now. She's had stable disease, so we don't see anything on her scan. She's about a year out. So, if you look at the metastasis, we talked about the lymph nodes. This is actually Dr. Brown's paper. They looked at 257 patients. 111 had staging, with half of those having lymph nodes removed. And none had positive nodes. So really, I think it speaks to the fact that lymph nodes are probably not involved. There were some later cases where the patients had about a 5% lymph node involvement, but that was a secondary event. So I think it's reasonable to omit lymph node dissection, but you probably need to do omentectomy. And maximal surgical effort is probably important. We know rupture. This was 160 patients. 104 of these were stage 1A, and about a third of them were 1C, with most of these being ruptured intraoperatively. This was a little different from our patient, but the 5-year PFS was 85%, 5-year OS 94%, but the relapse rate was higher in stage 1C, almost doubled, and the time to relapse was shorter in stage 1C. So tumor rupture is prognostic, but there have been some studies that looked at treating patients with chemotherapy with rupture with a lower risk of recurrence. If you look at the current NCCN guidelines, basically you can choose to observe this patient, or you can consider platinum-based chemotherapy, which is what we did. These are the guidelines. It is recommended that between 0 and 2 years, the physical exam, as indicated based on stage, testing is, if indicated. This patient had a tumor marker which was very good, so we don't get routine scans on these patients. In terms of systemic therapy, both of you chose carboplatin and paclitaxel, which is the new standard. We know that BEP was the older standard. There was a report of BVP, but BEP has a 83% response rate. Some of these are durable, but it has a fair amount of myelotoxicity, so about 60%. And we've had, particularly in adults, deaths on our clinical trials from pulmonary toxicity from the bleomycin. We have to cut the bleomycin down. Again, this was mentioned. This is Dr. Brown's trial of carboplatin and paclitaxel versus BEP. This was a retrospective analysis, and there were 37 recurrences. So for the patients with measurable disease, it was a 42% response rate with carboplatin and paclitaxel. So we've already talked about if you don't use platinum with the paclitaxel, the response rate is much lower. So this was GOG 264, which came out of that retrospective analysis, so comparing carboplatin and paclitaxel to BEP. So this was a non-inferiority trial design. This was opened in 2010 and accrued 128 patients. But there was a futility analysis, and what it was determined that they would not be able to determine a difference between these two groups at that point, and the trial was closed. This included all patients, and I think that's supposed to be 87% had granulosa cell tumors. So the majority of patients on this trial were patients with granulosa cell cancers, and the PFS was 27 months for the carboplatin and paclitaxel and 20 months for the BEP. So it looked like the Taxol was and the carboplatin were a little bit better than the BEP in terms of PFS, and no difference in OS. So what are our other options? So now that paclitaxel and carboplatin is the primary therapy for granulosa cell tumor, etoposide and cisplatin is also used. BEP can be used. And then we've talked about some of the hormonal therapies. You can consider secondary cytoreductive surgery. This is the MD Anderson experience that Dr. Brown put together. About 3/4 of patients can get optimal resection with a median PFS of 33 months. So again, a somewhat indolent tumor. If you have a single site that you can remove, like our patient had a multi-site, but again, only 2, so their PFS was 46 months. Multifocal disease, the PFS was 31 months. 66% of patients in their trial had multiple surgeries, and so again, we would try to resect this as much as we possibly can, but the PFS will go down with each surgery. Bevacizumab has some activity. Again, this is a small cohort. 8 patients were treated with Bev for recurrent disease. Response rate was 38%, with stable disease and a total of 63%. PFS was 7 months and OS was 24 months. And so this is GOG 251, again, Dr. Brown's study, looking at bevacizumab in the recurrent setting. 36 patients were treated with Bev at standard doses, with a 17% response rate, but 78% of patients had stable disease. And as you know from these studies, they're very vascular tumors and they bleed a lot. In their trial, the PFS was 8 months. The median OS wasn't reached. So it was deemed this has some activity. It's probably a reasonable choice if you want to avoid chemotherapy. The Alienator trial has looked at chemotherapy with weekly paclitaxel versus weekly paclitaxel and bevacizumab, a very active combination in ovarian cancer. 60 patients were randomized. Most of these had granulosa cell cancers. There was actually no difference when you added the bevacizumab to the weekly paclitaxel, which I thought was interesting. And in the overall survival, although the paclitaxel looked a little better, there was no statistical difference between those two arms. So again, I think either single agent bevacizumab or single agent paclitaxel would be reasonable. For hormonal therapy for patients who haven't been treated, the response rate to an aromatase inhibitor is about 30%. The response rate to gRNA agonists is 22%. So there is some certainly activity there. We don't have any, I didn't find any reports of the use of CDK4/6 inhibitors with aromatase inhibitors, but those would be an interesting combination. I believe that's an arm in the Bouquet trial. So again, tumor rupture is an adverse prognostic factor here. We don't need to sample nodes with granulosa cell tumors. We certainly can consider chemotherapy in stage 1C disease. We should probably use it in more advanced disease. Paclitaxel and carboplatin is certainly reasonable for the first line and certainly better tolerated than BEP. And secondary surgical resection should always be considered if at all possible. So we talked about some of the other active agents. So that's it. Thank you guys for your participation. And we've finished on time. Questions? No. No. Sophia's not going to ask a question? I'm sorry? Oh, okay. Well, thank you very much, and I really appreciate you staying until the end. Thanks.
Thanks, dear professor.